It's time for another warm-up review. Let's get going. Which intracranial tumor is associated with each of the following statements? So first we have polycythemia. That's going to be associated with hemangioblastoma. Neurofibromatosis 2. That's going to be associated with schwannomas and also meningioma. Hyperprolactinemia leading to galactorrhea, amenorrhea, and anovulation. Think about a pituitary adenoma. Psammoma bodies. That's going to be seen in meningiomas. Perivascular pseudorosettes, that's going to be seen in an ependymoma. Next, which cranial nerve is responsible for the motor innervation of the tongue? So motor control of the tongue comes from the hypoglossal nerve. Next, a 28-year-old woman is brought to the emergency room following a motor vehicle accident. Her passenger says that immediately after the impact, she appeared fine. However, 5 minutes later, she lost consciousness. A CT scan of the head shows an intracranial hemorrhage that does not cross suture lines. Which bone and vessel were most likely injured in the accident? So this is classic for an epidural hematoma, which is commonly due to rupture of the middle meningeal artery, and that's caused by injury to the temporal bone. All right, that's it for the warm-up. Let's get to that video.
In this video, we're going to review the embryological development of the heart and also the fetal circulation. Heart embryology is kind of confusing because the path of blood is all different from the adult heart, and you've got blood being shunted in all sorts of crazy directions. And there are structures that appear and disappear and change shape, and they all have names that sound like magic spells from Harry Potter, like truncus arteriosus. So let's begin at the beginning. The heart starts out as a simple tube, an enlarged portion of a blood vessel. This tube starts folding up on itself, kind of like a balloon animal. The first step of converting this tube into a 4-chambered heart is that the tube folds into an S shape. This S is oriented so that the distal part, which is eventually going to become the atria, is posterior, and the proximal part, which will become the ventricles, is anterior. So when the tube folds, it goes from this to this. And then the atrial chamber, which is now posterior, is going to grow and eventually form the superior vena cava and the pulmonary vein, which are in the back of the heart. So that gets us to this. And then we need to start building a septum to divide the left heart from the right heart. In the study guide, there's an outline of how the atria develop. We've just walked through the first couple of bullets. And instead of reading this to you, I'm going to show you how the atrial septum forms, and then you can refer back to this outline later. Heart embryology is complicated enough that you'll probably need to review this a few times on your own. So let's look at the heart in cross-section and talk about how the atrial septum forms. You start with a large, single primitive atrium, and the primitive ventricle is down below. And right in the middle is something called the endocardial cushion, which acts as an anchor for the atrial and ventricular septa to form on. We'll talk about the endocardial cushion a little later. So we need to build a septum that separates the right atrium from the left atrium. But we also need to leave some kind of opening so that during the embryonic and fetal periods, blood can bypass the pulmonary circulation and go right from the venous side to the arterial side. So the first thing that happens to construct this septum is called the septum primum, which grows from top to bottom toward the endocardial cushion. As it's growing, we see this gap, or ostium, between the septum primum and the endocardial cushion gradually shrinking and shrinking, right? That gap is called the ostium primum. As the septum primum grows, the ostium primum shrinks. And before the septum primum actually reaches the endocardial cushion and forms a solid wall, it starts to develop some perforations superiorly, again to allow the blood to flow from right to left. Then, as the septum primum reaches the endocardial cushion and obliterates the ostium primum, these perforations kind of merge, and we now call this the ostium secundum, or sometimes the foramen secundum. The next thing that happens is that a second septum starts to grow, which we call the septum secundum. And again, as it develops, it leaves a gap, or a foramen, to allow shunting of blood from right to left. And this foramen is called the foramen ovale. Let's hold it right there for a second and look at the next question in the study guide, which says, what divides the right and left atria? Again, it's the septum primum and the septum secundum. The next question is, how is blood shunted from the right atrium to the left atrium in the embryo. It's shunted through the foramen ovale and the ostium secundum. Again, you need that right to left shunt during development, and we'll see exactly why when we talk about fetal circulation in a little bit. Now we're ready to go back to our cross-section of the heart and pick up where we left off. Here's the septum secundum starting to form. And up here, you can see the perforations in the superior part of the septum primum, just about to completely merge to form the ostium secundum. Don't get confused. The ostium primum and the ostium secundum both develop into the septum primum. Don't think primum primum or secundum secundum. That's not right. Now here, the septum secundum has completely formed, and you can see the foramen ovale in the inferior part of the septum secundum. And then in the superior part of the septum primum, you have the ostium secundum. These two openings don't overlap. You can see how blood comes from the vena cava into the right atrium, then through these two gaps in the developing septum and into the left atrium so that it can be pumped to the rest of the body. Very, very important. It's important because if something goes wrong with this process, you can end up with a heart defect called an atrial septal defect, or ASD. We'll talk about congenital heart defects like ASD in another video. But for now, let's look at the next question in the study guide. It says, what are the 3 possible causes of an atrial septal defect? This list isn't super high yield, but it's nice to understand conceptually what's going on. The first possible cause of an ASD is that the ostium secundum gets too big and overlaps the foramen ovale. The second possible cause is an absence of the septum secundum. And the third possibility is that neither the septum secundum nor the septum primum develop. Then the next question says, what structure grows to close the opening between the atrial chamber and the ventricular chamber into 2 smaller openings? This is the superior and inferior endocardial cushion. We saw that before, right in the middle of the heart. And the next one says, what genetic abnormality is commonly associated with endocardial cushion defects? This one is important to know for sure. This is trisomy 21, or Down syndrome. Let's talk about how the ventricular septum develops. There's a study guide prompt that says outline the pathway by which the ventricles and their outflow tracts are separated. You start with the S-shaped heart tube and the ventricular chamber lying anteriorly. A muscular ventricular septum develops from the bottom up, growing toward the endocardial cushion, and that septum begins to divide the ventricles. The single primitive ventricle has a single outflow tract called the truncus arteriosus. But as that single ventricle is divided into a left and right ventricle, we need to divide the truncus arteriosus into an aorta and a pulmonary artery. There are ridges of tissue called truncoconical swellings that start forming inside the truncus arteriosus, and they grow toward each other until they meet in the middle. And these truncoconical swellings are oriented so that they form a 180-degree spiral. We call this the spiral septum or aorticopulmonary septum. And remember, the cells that form the truncus arteriosus and this aorticopulmonary septum come from neural crest cells. And once the spiral septum fuses with the interventricular septum, you have an aorta that connects to the left ventricle and lies posteriorly, and a pulmonary trunk that connects to the right ventricle and lies anteriorly. In the study guide, there's a list of several defects that can occur because of problems with the development of the spiral septum. There are 6 defects listed, but the main ones I want you to know are tetralogy of Fallot, persistent truncus arteriosus, where you only have partial spiral septum development, and then transposition of the great vessels, where the right ventricle is pumping blood into the aorta and the left ventricle is pumping blood into the pulmonary artery because that 180-degree spin did not take place. You can see other pathologies, but those 3 are important to know. We'll talk about these congenital heart defects in detail in another video, but when you see them again, I just want you to remember there was a problem with the development of the spiral septum. And then the next question says, describe how the ventricles are remodeled in order to form the atrioventricular valves. Basically, the ventricular myocardium erodes and the ventricles enlarge. So you start with a rather narrow ventricular lumen that enlarges as the myocardial cells erode away. Then the residual bands of mesodermal tissue become fibrous, and they form the chordae tendineae, and then the papillary muscles and AV valves can form. Let's match up the primitive heart tube to the adult structures each piece of that tube is eventually going to become. First of all, the truncus arteriosus gives rise to the great vessels, the proximal aorta and the proximal pulmonary trunk. The bulbus cordis gives rise to the outflow tract of both the right and left ventricles, the smooth parts of the ventricles. The primitive ventricle gives rise to the trabeculated parts of the left and right ventricles, which are the muscular portions of the ventricles. The primitive atrium gives rise to the muscular or trabeculated parts of the left and right atria. Then the sinus venosus is divided into the left horn and the right horn. The left horn gives rise to the coronary sinus, and the right horn gives rise to the smooth part of the right atrium. And then one structure that is not pictured is the superior vena cava, which is derived from the right common cardinal vein and the right anterior cardinal vein. The cardinal veins are the really primitive veins found early on in embryonic development. Embryology of the cardiovascular system also includes aortic arch derivatives, which are important to review. If you think back to the pharyngeal apparatus, you'll remember that each pharyngeal arch has a muscle, a cartilage, and an artery. Those arteries within the pharyngeal arches are also called aortic arches, interconnected arteries that come off the truncus arteriosus and supply blood to the pharyngeal arches. And just like the pharyngeal arches and clefts and pouches all went on to develop into something else, each aortic arch develops into something. We're going to walk through all of them, but I'll tell you up front that the ones you're most likely to be tested on are the third and the fourth aortic arches. The first aortic arch becomes part of the maxillary artery. Remember, the first pharyngeal arch contributes to the mandible and all those jaw structures, and here the first aortic arch is forming the maxillary artery, which takes off from the external carotid right behind the neck of the mandible. The second aortic arch becomes the stapedial artery and hyoid artery. And remember that the second pharyngeal arch gives rise to the stapes and the stapedius muscle and part of the hyoid bone. So the artery names match up. The third aortic arch, and this is the one that I want you to focus on, the third arch becomes the common carotid and the proximal part of the internal carotid. Then for the fourth aortic arch, we have to talk about the left arch and the right arch separately. Remember, these are paired arteries. So the left fourth arch becomes the arch of the adult aorta, which is easy to remember because the adult aortic arch is on the left side of the chest. And the right fourth arch becomes the proximal part of the right subclavian artery. The sixth aortic arch becomes the proximal part of the pulmonary arteries and the ductus arteriosus. And remember, there is a fifth arch that develops early on, but it degenerates and never develops into any adult structures. So, those are the aortic arches. Make sure you know the derivatives of the third and fourth arches, but remember, the rest are fair game too. Let's review the circulation of blood in the fetus, which is substantially different from the mature circulation. I'm going to walk you through the flow of blood, starting in the most highly oxygenated vessels and working our way to the least oxygenated vessels, and pay special attention to the shunts, where the highly oxygenated blood mixes with the less oxygenated blood. First of all, which vessel carries oxygenated blood from the placenta to the fetus? The umbilical vein or the umbilical arteries? It's the umbilical vein. Remember that veins are defined by the fact that they carry blood back to the heart, not by whether they carry oxygenated or deoxygenated blood. So the umbilical vein carries oxygenated blood from the placenta, and it first goes to the liver. In the liver, you have mixing of oxygenated blood from the umbilical vein with some of the deoxygenated blood from the lower extremities, which takes place at the ductus venosus, and then the inferior vena cava. So here, the order of oxygenation from highest to lowest is the umbilical vein, the ductus venosus, the IVC, and then the right atrium. In the right atrium, the blood can take one of two pathways. It can either pass through the foramen ovale and go directly to the left atrium, or it can go through the right ventricle into the pulmonary artery. Let's talk about this pulmonary artery pathway for a second. From the right ventricle to the pulmonary artery, here again there are two more ways that the blood can go. It's kind of like choose your own adventure if you're a red blood cell. The blood can either go to the lungs, just like in the adult circulation, or it can go through the ductus arteriosus, which is a fetal connection between the pulmonary trunk and the aorta. So a lot of the blood that took the pathway through the right ventricle and the pulmonary trunk is still going to bypass the lungs and go directly into the systemic circulation. But let's say that you're a red blood cell that went through the pulmonary artery to the lungs. Well, when you finally make it to the left atrium, you're going to meet up with some of those shortcutters that came from the right atrium directly through the foramen ovale. So there are two different pathways to the left atrium. But however the blood gets to the left atrium, from there it goes to the left ventricle and through the aorta. And again, this blood going through the aorta is going to meet up with blood that came through the ductus arteriosus. And then all of that will go from the aorta out into the rest of systemic circulation. And part of that systemic circulation goes through the umbilical arteries back to the placenta to drop off CO2 and pick up more oxygen and nutrients. So that's fetal blood flow. Just to reiterate, the areas where you have shunting are the ductus venosus in the liver, the foramen ovale between the left and right atria, and the ductus arteriosus between the pulmonary artery and the aorta. Make sure you know all three of those shunts. How does the fetal circulation switch over to the mature circulation? And when does that take place? Well, it takes place shortly after birth, when the newborn baby starts breathing. When the baby takes a breath, the intrathoracic pressure decreases. This decreases resistance in the pulmonary vasculature. You expand the pulmonary vasculature and it creates a little vacuum that starts to suck some blood from the right side of your heart. So now more blood is entering the pulmonary artery. That also means that more blood is returning to the left atrium via the pulmonary vein. So decreased resistance in the pulmonary vasculature eventually causes an increase in the left atrial pressure. So now the left atrial pressure is higher than the right atrial pressure, and that causes closure of the foramen ovale. That higher left atrial pressure basically pushes the septum primum up against the septum secundum so that the passage between the atria is now closed. Eventually those two septa will fuse, but until then, the increased left atrial pressure just holds them together. So now there is highly oxygenated blood coming from the lungs and the pulmonary veins into the left atrium and the left ventricle and out into the aorta. And that highly oxygenated aortic blood causes closure of the ductus arteriosus. If that doesn't close, we call that a patent ductus arteriosus, or PDA. And just one FYI, it's fairly common to hear the murmur of a patent ductus arteriosus in the first 24 hours of life. You don't need to panic. Just give the baby some time before you do anything about it, because it may still close on its own. And then occasionally, if there are significant cardiac anomalies and you want to keep the ductus arteriosus from closing, you could give prostaglandins to help keep it open. Prostaglandins dilate vessels and keep vessels open. And if you needed to close the ductus arteriosus, you would give an NSAID, like indomethacin, which inhibits prostaglandin synthesis and closes vessels. All right, that's it for fetal circulation. Go ahead and work through the end of session quiz, and then we'll go through those answers together. First question, what embryologic structure of the heart gives rise to each of the following adult structures? The ascending aorta and pulmonary trunk come from the truncus arteriosus. The coronary sinus is derived from the left horn of the sinus venosus. The superior vena cava comes from the right common cardinal vein and right anterior cardinal vein. The smooth parts of the left and right ventricle come from the bulbus cordis. The smooth part of the right atrium comes from the right horn of the sinus venosus. The trabeculated parts of left and right atria are derived from the primitive atria, and the trabeculated parts of the left and right ventricles are derived from the primitive ventricle. Next question. What structure divides the truncus arteriosus into the aortic and pulmonary trunks? And what is the cellular origin of this structure? This is the spiral septum, or the aorticopulmonary septum, and this is a neural crest derivative. Next question. Which fetal vessel has the highest oxygenation? Again, you've got to know the order. The highest oxygenation is found in the umbilical vein, then the ductus venosus, then the IVC, then the right atrium. And then you start getting into the choose your own adventure stuff. So the umbilical vein is the fetal vessel that contains the most highly oxygenated blood. Next question. What causes the ductus arteriosus to close? It's the infant's breathing and the increase in oxygenated blood in the aorta, which leads to decreased prostaglandins and closure of the ductus arteriosus. Okay, next. What causes the foramen ovale to close? It closes because of decreased pulmonary vascular resistance when the newborn starts breathing, and that leads to higher left atrial pressure, which pushes the septum primum against the septum secundum. That's it for now. See you next time.
It's time for another warm-up review. Let's get going. Which cell types are rich in smooth endoplasmic reticulum? The main ones you should know for step 1 are going to be hepatocytes, and then steroid hormone-producing cells of the adrenal cortex. Next, what is the treatment for heparin overdose? So for heparin overdose, you give protamine sulfate. Next, what is the treatment for warfarin overdose? So for a warfarin overdose, you can give fresh frozen plasma, and then you can also give vitamin K. All right, that's it for the warm-up. Let's get to that lecture now.
We've just been talking about the embryology of the heart. So now we're going to talk about congenital heart defects, which is basically what happens when that complex embryology goes wrong. Generally speaking, we can divide congenital heart defects into right to left shunts and left to right shunts. Now, which one of these do you think is worse? Well, would you rather have deoxygenated venous blood from the right ventricle shunted over to the left side in the systemic circulation? Or would you rather have oxygenated blood shunting over to the right and then going back to the lungs? I hope it's obvious that left to right shunts are much less dangerous in the short term. Babies can survive a long time with a mild left to right shunt, and they may be asymptomatic until the child's several years old and starts having exercise intolerance or shortness of breath or episodes of cyanosis. So right to left shunts cause cyanosis early, immediately after birth, but left to right shunts cause cyanosis much later on. Left to right shunts are less severe and also more common, which is fairly fortunate. There are 3 main causes of a left to right shunt: ventricular septal defect, which is the most common, atrial septal defect, and a patent ductus arteriosus. A VSD, or ventricular septal defect, is where there's a defect in the interventricular septum. Now, this may be completely asymptomatic, but it will cause a harsh holosystolic murmur as the ventricles contract and blood rushes across that defect from the left ventricle to the right ventricle. We're going to talk about heart murmurs in another video. About 40% of VSDs close spontaneously within the first 6 months, but larger symptomatic VSDs may need surgical repair. An atrial septal defect, or ASD, is a defect in the interatrial septum. In the last video, we talked about some different ways an ASD could develop, but the most common way is that the foramen ovale and the ostium secundum overlap each other. That means that the foramen ovale just doesn't close the way it's supposed to. This is sometimes called a secundum ASD, or a patent foramen ovale, and that's the most common type of ASD. Now, following the purple arrow here, we can see that blood can flow from the higher pressure left atrium over to the lower pressure right atrium, creating those higher pressures in the right side of the heart. So this leads to a very loud S1 heart sound and wide fixed splitting of S2. There may be some hypertrophy of the right ventricle. And the least common cause of a congenital left to right shunt is a PDA, or a patent ductus arteriosus. Normally, the ductus arteriosus remains open during fetal life to let blood from the pulmonary trunk bypass the lungs and go into the aorta in the systemic circulation. But then, after delivery, the ductus arteriosus is supposed to close. This usually occurs within the first 24 hours or so after birth, but it may take up to 2 weeks. So initially, it's fairly common to hear a continuous machine-like murmur at the left upper sternal border in a newborn while they're transitioning from fetal circulation to postnatal circulation. But that murmur should resolve within 24 hours usually. If that murmur persists, that means that the ductus arteriosus has remained patent, as we see here. And this causes a left to right shunt as blood moves from the high pressure aorta over to the low pressure pulmonary trunk. Now, we treat a PDA by giving indomethacin, which blocks prostaglandin synthesis, and that closes the PDA. Remember, prostaglandins help keep vessels open. So we give indomethacin to block prostaglandin synthesis, and that allows the PDA to close. But sometimes we want to keep the ductus open. So in certain congenital heart diseases where you have cyanosis, where there's a right to left shunt, like transposition of the great vessels, for instance, which we're going to talk about later. But in those cases, you need to keep that ductus arteriosus open to allow oxygenated blood to make it over to the systemic circulation. So if you want to keep the ductus patent, you can use prostaglandins like PGE. Now, I said that right to left shunts were severe and dangerous, which they are. But I don't want to give you the impression that left to right shunts are completely benign and harmless. In fact, severe, long-standing, uncorrected left to right shunts can lead to something called Eisenmenger syndrome. So I want you to think about this sequence of events for Eisenmenger syndrome. You start with some left to right shunt, like a big VSD, and you're shunting blood from the left side of the heart over to the pulmonary circulation. Well, this increases pressure in the pulmonary circulation, and that leads to pulmonary hypertension. And then since the right ventricle has to work harder to pump blood against all that high pulmonary artery pressure, you're going to start to get some thickening of the right ventricle, and you're going to get some right ventricular hypertrophy. And eventually, that right-sided pressure can exceed the pressures over on the left side of the heart, and that left to right shunt that you started with will reverse flow, and it'll convert to a right to left shunt. So now you have deoxygenated blood going from the right side of the heart over to the left side of the heart and into the systemic circulation. And this leads to cyanosis, and shortness of breath, and clubbing of the fingers. So again, one reason you might give indomethacin to close a PDA is to prevent Eisenmenger syndrome. So left to right shunts like PDA or VSD are not cyanotic lesions initially, but if they're severe and if they're left untreated, they may develop cyanosis later in life. So before we talk about the types of right to left shunt that lead to early cyanosis, let's talk about coarctation of the aorta, which is one more non-cyanotic condition, but it doesn't really cause a shunt. A coarctation or a coarct is a focal circumferential narrowing of a vessel, in this case, the narrowing of the aorta. In the aorta, this usually occurs near the ductus arteriosus. But the key clinical feature to remember is that this classically causes elevated blood pressure readings in the upper extremities and low blood pressure in the lower extremities. So if you think of the aorta like a big garden hose and you kink that hose, the pressure proximal to the kink is going to be very high up in the arms, and the pressure distal to the kink down the legs will be low. So again, the blood pressure will tend to be high in the arms and low in the legs with a coarctation of the aorta. You may also see notching of the ribs on a chest x-ray because the intercostal arteries become dilated and that carves out little notches or indentations along the inferior aspect of the ribs. Coarctation of the aorta can also be associated with aortic regurgitation, either from coexisting abnormal valves or because with increased afterload pressure on the aortic valve, the valves are eventually weakened and they get damaged and they begin to regurgitate, and that can lead to heart failure symptoms. So now let's talk about right to left shunts, where blood is being shunted from the right side of circulation over to the left side of circulation, basically bypassing the pulmonary circulation. So this means that deoxygenated blood is going into the systemic circulation. That means these patients develop cyanosis very early on in life. So you can remember these 5 different causes of cyanotic heart disease because they all start with the letter T. You can also use the numbers 1, 2, 3, 4, 5 to help you remember them. 1 is a persistent truncus arteriosus because it's one big vessel. Then 2 is transposition of the great vessels because there are 2 great vessels that have swapped positions. Then 3 is tricuspid atresia, 3 for the tri and tricuspid. And then 4 is tetralogy of Fallot because tetra is Greek for 4. And then 5 is total anomalous pulmonary venous return because that name, total anomalous pulmonary venous return, has 1, 2, 3, 4, 5 words in it. And also it's total, so it has to be the largest number. So let's look at each of these one at a time. The first one was a persistent truncus arteriosus, not ductus arteriosus, but persistent truncus arteriosus, which is failure of the truncus arteriosus to divide into the pulmonary trunk and the aorta. So remember, this is failure of those neural crest cells to cause the aorticopulmonary septum to form properly. This is usually associated with a VSD. So as you see here, deoxygenated blood from the right ventricle is mixing with the oxygenated blood from the left ventricle, going back out into the systemic circulation. So you get some cyanosis and respiratory distress and heart failure. The second one was transposition of the great vessels, which means the aorta and the pulmonary trunk switch positions. Again, this is related to failure of the normal aorticopulmonary septum to develop properly. So the left ventricle is pumping blood back into the lungs, and the right ventricle is pumping deoxygenated blood into the aorta and the systemic circulation. So you have complete separation of systemic and pulmonary circulations, two completely separate closed loops. Now, in order for this to be compatible with life, you have to have some type of shunt to allow oxygenated and deoxygenated blood to mix, such as an ASD or a VSD. Or you may have to artificially keep the ductus arteriosus from closing in order to buy some time until the patient can go to surgery. And again, how do we keep the ductus arteriosus patent? With prostaglandin E. Remember, prostaglandins keep vessels open. The third member of the 5 T's was tricuspid atresia. Remember, number 3 for tricuspid atresia. Now, tricuspid atresia is where the tricuspid valve doesn't develop, so there's no opening from the right atrium into the right ventricle. And with that, the right ventricle is often going to be underdeveloped and hypoplastic. And again, this is incompatible with life unless there's a shunt. And actually, you need 2 shunts. You need an ASD so the blood can get from the right atrium over to the left atrium. And you also need a VSD so blood can get from the left ventricle to the right ventricle and then out to the pulmonary vasculature. And while we're talking about the tricuspid valve, let's take a quick sidetrack and discuss another anomaly of the tricuspid valve called Ebstein anomaly. Ebstein anomaly is a constellation of findings in which the tricuspid leaflets are displaced inferiorly into the right ventricle, and there's hypoplasia of the right ventricle, and there's also some tricuspid regurgitation or stenosis. Now, 80% of these patients have a patent foraminal valley with a right to left shunt, and you have a dilated right atrium causing increased risk of SVT and Wolff-Parkinson-White syndrome. And on physical exam, there's a widely split S2 and tricuspid regurgitation. Now, Ebstein anomaly is associated with maternal lithium use. So if a woman's taking lithium for bipolar disorder and she gets pregnant, her baby would be at an increased risk of being born with an Ebstein anomaly. So going back to the 5 T's, the fourth cause of right to left shunt is tetralogy of Fallot. Now, this one is very high yield, probably 4 stars, maybe even 5 stars. Remember, tetra means 4, and with a tetralogy, you have 4 defects clustered together, and you need to know all 4 of these defects. So the first one is right ventricular outflow tract obstruction, usually in the form of pulmonic valve stenosis. So that's the most important determinant of how much blood is going to be shunted away from the right side of the circulation. Then the second defect is right ventricular hypertrophy. You can think of the right ventricle having to get thicker and become hypertrophied in order to push blood through that tight stenotic pulmonic valve. Then the third defect is a VSD, and the fourth defect is an overriding aorta, which means that the opening of the aorta sits right over the VSD. So make sure you know those different components of a tetralogy of Fallot. Now, a student sent in a mnemonic IHOP for these 4 defects. The I is for interventricular septal defect, which is a fancy name for a VSD. The H is for hypertrophy of the right ventricle. The O is for overriding aorta, and the P is for pulmonic stenosis. Now, depending on how severe the defects are, the right to left shunt may only occur intermittently in tetralogy of Fallot, depending on the pressure differentials. So these kids may spend most of their time shunting left to right, meaning they're acyanotic. But there may be times where that deoxygenated blood gets shunted from right to left. For example, when the child cries, when the child feeds, or during periods of increased activity. And when that right to left shunt occurs, the kids become cyanotic. Now, older kids will learn to squat down during those cyanotic spells because that's going to relieve symptoms, because squatting increases systemic vascular resistance and it forces their right to left cyanotic shunt to go back to being a left to right shunt. They're physically forcing blood back across the VSD to the lungs to oxygenate it. So, if you have an infant with tetralogy of Fallot who's having these cyanotic spells, well, infants can't squat on their own, but you can artificially squat for them by pushing their knees up to their chest. That's going to increase afterload and relieve that cyanosis. Now, the classic X-ray finding with tetralogy of Fallot is that the heart looks vaguely boot-shaped on chest X-ray because of right ventricular hypertrophy. So, if they show you a boot-shaped heart in an infant, I want you to think about tetralogy of Fallot. But if they show you a boot-shaped heart in an adult, think about right ventricular hypertrophy from other causes like COPD or primary pulmonary hypertension. Then the fifth and final cause of cyanotic heart disease and right to left shunt is called total anomalous pulmonary venous return.
This is where the pulmonary veins drain into the systemic venous circulation. So instead of oxygenated blood coming from the pulmonary veins to the left atrium, it might empty into the SVC or it might empty into the coronary sinus, but it eventually empties into the right atrium. So again, this is a completely closed loop, just like transposition of the great vessels was. And without some shunt, this is incompatible with life because there's no blood going into the left ventricle and the aorta. Let's also mention a few conditions that are associated with these types of congenital heart defects. Now, these have been known to turn up on practice tests, and you may see them on the real deal as well. Let's start with some conditions that affect the mother. We've already mentioned maternal lithium use, which can lead to which abnormality? Epstein anomaly, with that downward displacement of the tricuspid leaflets and right ventricle hypoplasia. Now, what about maternal alcohol use? Well, that'll increase the risk of several cardiac malformations, such as tetralogy of Fallot, VSDs and ASDs, and also patent ductus arteriosus. And then if the mother has pregestational diabetes, not gestational diabetes where she developed diabetes during pregnancy, we're talking about pregestational diabetes, diabetes that existed before she became pregnant, that tends to be associated with transposition of the great vessels. So those are conditions that mom has that affect the baby. But what about conditions the baby has that leads to heart defects? For example, congenital rubella infection increases the risk of a PDA, and it also increases the risk of pulmonary artery stenosis. DeGeorge syndrome, also known as the 22q11 deletion syndrome, can be associated with either tetralogy of Fallot or a truncus arteriosus. Turner syndrome is associated with coarctation of the aorta, as well as aortic valve defects like bicuspid aortic valve. And then trisomy 21 or Down syndrome increases the risk of an endocardial cushion defect. Remember, the endocardial cushion is the place where the ventricles and the atrium meet, right in the center of the heart. So endocardial cushion defects can lead to ASDs and VSDs. And that's it for the congenital heart diseases. So go ahead and work through the end of session quiz, and then we'll go over the answers together.
All right, first question. What are the four components of the tetralogy of Fallot? Well, remember the mnemonic IHOP: interventricular septal defect, or VSD, hypertrophy of the right ventricle, overriding aorta, and pulmonic stenosis. Next, explain how the great vessels are attached in a transposition of the great vessels. So in transposition of the great vessels, the pulmonary trunk originates from the left ventricle and the aorta originates from the right ventricle. Next question. A 45-year-old man presents with a blood pressure of 160/90 in the right arm and 170/92 in the left arm. There are no palpable pulses in the feet or the ankles. So what problem does this patient most likely have? Well, hypertension in the arms and weak pulses in the feet should make you think of a coarctation of the aorta. And the last question. What heart defect is associated with each of the following disorders? So that chromosome 22q11 deletion is associated with truncus arteriosus and also tetralogy of Fallot. Down syndrome or trisomy 21 is associated with endocardial cushion defects like ASD or VSD. Congenital rubella is either PDA or pulmonary artery stenosis. And Turner syndrome is coarctation of the aorta, and also remember bicuspid aortic valves. Think of aortic problems with Turner syndrome. So that's the end of session quiz, but let's also run through these rapid fire facts. If you hear a continuous machinery-like heart murmur, I want you to think PDA. If you see a boot-shaped heart on chest x-ray, think about tetralogy of Fallot or possibly other causes of right ventricular hypertrophy in an adult. If you see rib notching, think coarctation of the aorta. The next one, the most common congenital cardiac anomaly is a VSD. Definitely know that. And the most common congenital cause of early cyanosis is tetralogy of Fallot. All right, that's it for the congenital heart defects. I'll see you soon.
I think atrioseptal defect is one.
Yeah, that sounds right.
Dr. T!
I pity the fool who doesn't know the cyanotic congenital heart diseases.
But Dr. T, this is so difficult. However are we to remember?
Stop all of that jibber jabber. It's easy. It's the 5 T's. Truncus arteriosus, transposition of the great vessels, tricuspid atresia, tetralogy of Fallot, total anomalous pulmonary venous return. It's the 5 T's.
Wow, I get it now. Thanks, Dr. T.
No problem, Shrimp. Now get back to studying.
Let's go over the warm-up review. First question. A farmer suffering from organophosphate poisoning continues to have significant symptoms despite administration of atropine. What additional drug should this patient receive? So you should give pralidoxime, which is a drug that regenerates acetylcholinesterase. Next, which enzymes are involved in the catabolism of norepinephrine? So the two enzymes are catechol O-methyltransferase, or COMT, and monoamine oxidase, or MAO. And the last question, what are the various clinical applications of atropine? So we use atropine to treat bradycardia and some types of AV node block in code situations. Anesthesiologists use atropine to decrease airway secretions. It can be used as eye drops to dilate the pupils and paralyze the ciliary muscles for ophthalmologic procedures. And we mentioned that it's used to treat organophosphate poisoning. So that's it for the warm-up, so let's move on to the lecture.
Hello everyone and welcome to our Step 1 video on cardiac output. You better put on your math hats today because today we're talking about equations and looking at graphs and stuff like that. Wait a minute. This isn't my math hat. This is my role-playing. Hey, let's talk about cardiac output. So first, what is cardiac output? Well, cardiac output is the volume of blood that is pumped out of the heart in 1 minute. So the equation for cardiac output is actually quite simple. Cardiac output is equal to the stroke volume times your heart rate. Now, stroke volume is exactly what it sounds like. It's the volume of blood pumped out of the heart with each heartbeat. And of course, heart rate is measured in beats per minute. So again, we get the amount of blood pumped out in 1 minute. Pretty easy, right? Now, through the magic of algebra, we can rearrange this equation and discover that stroke volume is equal to the cardiac output divided by the heart rate. And another way to calculate the stroke volume is to know the difference between the end diastolic volume and the end systolic volume. It's all still pretty easy stuff. Now that's looking at the volume of the blood of the heart when it's at its fullest and then subtracting out the amount of blood that is left in the ventricle after the heart pumps. So the difference is the amount of blood that is ejected from the heart. Now the next equation is not quite so easy. It's called the Fick principle, or sometimes referred to as the Fick equation. And you definitely need to know the Fick principle here. So the Fick principle allows you to ascertain the cardiac output by using the rate of oxygen consumption and the difference between the arterial and the venous O2 content. So cardiac output equals the rate of oxygen consumption divided by the arterial O2 content minus the venous O2 content. Now you may very well get a question on your test that asks you to calculate one of those values given a certain set of information. Now the next topic is the mean arterial pressure. The mean arterial pressure is the average arterial pressure during a single cardiac cycle. Now mean arterial pressure commonly is going to be abbreviated as P, and it's going to be equal to cardiac output times total peripheral resistance. So if you break it down a bit, the MAP, or the mean arterial pressure, is how much blood you get out of the heart in 1 minute times the resistance in the system. So cardiac output, sometimes referred to or abbreviated as Q, and then resistance is commonly abbreviated as R. So when you take the equation all together, that makes the equation easy to remember. P equals Q times R, or just remember PQR. Now, mean arterial pressure can be approximated using another equation as well. This only works with normal resting heart rates, though. So the mean arterial pressure is 2/3 of the diastolic plus 1/3 of the systolic pressure. Moving along, pulse pressure. Pulse pressure is systolic pressure minus your diastolic pressure. So it's basically the pressure involved in the pulsatile wave. Again, it's the difference between the systolic and the diastolic, and it's proportional to the stroke volume. The higher the stroke volume, the more the pulse pressure. Now let's cover the effect of certain things on cardiac output. So first, let's talk about preload and afterload. So preload is the pressure at the end of diastole. So when the ventricles are at their fullest right before contraction, think of that as your preload time period. And where does your diastolic volume of your heart come from? Well, it comes from your arterial volume, from your atriums. So in order to fill up the ventricle, it has to come from the atrium first. So atrial pressure is another surrogate for preload as well. So again, preload is ventricular end diastolic pressure, roughly equal to that atrial pressure, which if you take it one more step out, it's roughly equal to the central venous pressure, or the amount of blood that's returning to the heart. So what are some examples of how the preload can change? Well, preload increases with exercise slightly, and the reason for this is because your muscles are contracting, they're pushing more blood back up to the heart. That increases the preload. And by increasing your preload at the beginning of exercise, you increase your stroke volume. Cardiac output increases initially in exercise because that stroke volume increases. Now, preload is also going to increase with increased blood volume. So if you maybe overtransfuse a patient or if you overhydrate a patient, that's going to increase their preload. Pregnancy has a very high preload as well. Women have an increased blood volume during pregnancy. Next, let's talk about afterload. So afterload is approximated by mean arterial pressure, which, as we just said, is cardiac output times peripheral resistance. But what I want you to equate afterload with, maybe more simply, is just peripheral resistance. So how much pressure is pushing back against the heart? Preload is how much blood is coming back to the heart through the venous system. Afterload is how much pressure is pressing back against the heart. Now, if you see mean arterial pressure or total peripheral resistance, sometimes abbreviated by TPR, these again, all measures of afterload. Now, there are a couple of prototypical drugs that decrease the preload and the afterload. First, we have venodilators. So your nitrates, like nitroglycerin, decrease preload. Nitroglycerin venodilates the veins. Now, by dilating the veins, you're going to pool blood and fluid. You're going to pool your venous fluid in your veins instead of having it return to the heart, so you're decreasing the preload. Now, your vasodilators, think of something like hydralazine. They're going to decrease afterload. So hydralazine works mainly at the arteries, and by expanding those arteries, you decrease the back pressure on the aorta as well. Okay, so now we know the equations and some of the definitions. Let's look and see what affects our cardiac output again. Definitely a very high yield 4 to 5 star topic. Again, to review, cardiac output is how much blood the heart ejects in a minute, or the stroke volume times the heart rate. So how does exercise affect cardiac output? We mentioned this before. It makes sense that it would increase. During exercise, cardiac output increases initially as a result of increased stroke volume. Remember, the muscles are contracting, more and more is getting back to the heart, meaning blood. And during sustained exercise, the cardiac output is then maintained primarily due to increased heart rate. Now, does that mean that as you increase heart rate, the cardiac output continues to increase? Well, the answer is no. If the heart rate is too high, the diastolic filling is incomplete. You're not allowing enough time for the ventricles to fill up because they're just contracting too quickly. So each heart contraction is pushing out less than ideal volume. So your cardiac output in that situation actually goes down if your heart rate is too high. And that's why a highly elevated heart rate, like with atrial fibrillation or ventricular tachycardia, can cause a decrease in cardiac output even though the heart rate is around 150 or even above. Next, let's talk a little bit more about stroke volume. So contractility is directly related to stroke volume. The harder the heart pumps, the more blood the heart is going to push out. And the reverse is true. If you contract less forcibly, then the stroke volume goes down. So what increases contractility? Well, contractility and stroke volume increase with catecholamines. So which adrenergic receptor stimulates the heart? Well, those are going to be those beta-1 receptors. They're going to be the major receptors on the heart. So how do the beta-1 receptors do this? Well, beta-1 receptors, when stimulated, will increase intracellular cyclic AMP, which will then result in that increased muscle contraction. Okay, so what decreases contractility? Well, it's just the reverse of what increases contractility. So beta-1 blockade. So when we give beta blockers, they decrease contractility. A heart failure decreases contractility. If there's heart muscle damage, this is going to decrease that contractility. Now, acidosis in and of itself can decrease contractility, as does hypoxia and hypercapnia. Now, the non-dihydropyridine calcium channel blockers, like verapamil, will decrease contractility as well, maybe not as much as some of the other drugs. The other calcium channel blockers are the dihydropyridine calcium channel blockers. They work primarily on the blood vessels, but the non-dihydropyridines, like verapamil, again, going to work primarily at the heart. So now back to stroke volume. What happens to stroke volume when you increase afterload? Well, if you have a lot of back pressure from the aorta and the rest of the body, it's going to be harder for the ventricles to push out a lot of blood against that back pressure, again, from the aorta. So increasing the afterload is going to decrease your stroke volume and thus the cardiac output. Now, how does increasing preload affect stroke volume? Well, preload is another way of thinking of diastolic filling volume. So it's the amount of blood you're pushing into your heart, into the ventricles. So if you push more blood into your heart, you're going to expel more blood from your heart in general. Now, the stroke volume is increased when preload is increased. So to recap, to increase the stroke volume, you can increase contractility, decrease afterload, or increase preload. All right, so now let's go over ejection fraction. How is it different from stroke volume? This can be confusing for some folks. So ejection fraction is what your heart can pump out divided by what your heart can hold with each beat. So it's a percentage or fraction. A normal ejection fraction is about 55 to maybe 70%. Now the stroke volume is how much the heart can pump out per beat. So it's a volume, not a percentage. The ejection fraction is an index of ventricular contractility. So as your ejection fraction goes up, that generally means that you've improved or increased your contractility. Now, one of the most common findings with systolic congestive heart failure is a decrease in that ejection fraction. Now, as the heart decreases its ability to provide a strong coordinated contraction, the ejection fraction then thus goes down. All right, so now let's look at some calcium physiology in the heart muscle. All right, everyone, welcome to another Lewis Notes, and we're talking about muscle cells today, and we've got this beautiful picture that I just wrote for you. You might want to take a minute to either just at least familiarize yourself with it or even write it yourself to get an idea of how calcium affects the myocyte. So we have a myocyte that's going to want to contract because that's going to be how your heart is going to function, and it's all about calcium. So let's go through some of these ways in which calcium either gets in or out of the cell. And before we do that, so we talked about in the lecture what causes the calcium to increase in a cell. Well, the big major change is that the sarcoplasmic reticulum releases a whole bunch of calcium, and then that's going to lead to muscle contraction. But we have to get to the point where that sarcoplasmic reticulum gets stimulated. And how do we stimulate a sarcoplasmic reticulum? With even more calcium. So calcium begets calcium in this situation. So let's go through sort of these different pathways in which we see all of our different electrolytes moving all over the place. So first, if we look over here we have a sodium-potassium ATPase. And you'll notice there's no calcium involved there. So why am I even talking about this? Well, you have to have different gradients of potassium and sodium in order to maintain a certain gradient. And then that gradient is then going to help us move other types of things like calcium in and out of the cell. So in this case, we're moving sodium out, and then we have an extracellular sodium concentration, and we have an intracellular sodium concentration. So how's that going to affect other things? Well, we've got this other thing called this sodium-calcium exchanger. So in this case, we're actually moving calcium out of the cell as we're moving sodium into the cell. So you can see how this sodium gradient is still going to be very important on whether or not we can move calcium out of the cell. And then our third thing here is what we call a voltage-gated calcium channel. And this thing is just a big old gap that allows calcium into the cell. And it can either open or close depending on what type of voltage is going on in the cell. So that's one way we're going to get calcium in. And then we've got this other way in which we're going to leave calcium getting out with this other exchanger. All right, so as soon as this calcium level right here gets high enough, that's actually going to kind of move over here to the sarcoplasmic reticulum. Now there's just another random transporter here that we're really not going to talk about, so don't worry about that one. So this calcium, it's going to increase, or it's going to at least stimulate the desire for that sarcoplasmic reticulum to take all of its calcium that's got all stored up over time, and then it's going to shoot it out of the sarcoplasmic reticulum into the cell cytoplasm, thereby triggering muscle contraction. So why is any of this important? Well, what's important is that we have a lot of drugs that will affect on some of these transporters here. So if we look at something like this ATPase, this sodium potassium ATPase, digoxin will shut this down. And that will effectively change the gradient of sodium that's in and outside the cell. So if we shut this down, then we're effectively going to be decreasing our extracellular sodium. And if we don't have a lot of sodium out here, there's not going to be much of a gradient to want sodium to come back in. So that's going to shut down this thing right here, which is going to effectively increase our overall calcium. So what does digoxin do? Remember, it increases contractility. And that's because it's maintaining more of this calcium gradient on the inside. So what if we wanted to decrease contractility? Well, we could use a drug that affects calcium channels. Remember how we were talking about verapamil? Well, what if we shut this thing off? Well, if we shut this thing off, then we're going to decrease the amount of calcium again, the exact opposite of what we were doing essentially with our digoxin. So we're going to decrease this calcium that's right here, and therefore you're going to stimulate the sarcoplasmic reticulum even less. So you don't necessarily need to know all the ins and outs of everything on here. But I would, have a rough idea of where these are going. And then when subsequent lectures come up on some of these drugs specifically, you'll know, it's all about the calcium that's changing the effects of this on the heart and the myocytes themselves. Okay, so now we're going to take those concepts and put them on a curve to help us understand them a little bit better. Welcome to the Starling curves. Sometimes curves and graphs can be a little intimidating, but really if we'll break this down, we'll be able to figure this out pretty quickly. So this is a graph on the y-axis. We have cardiac output. You could also just say stroke volume, but I'll probably refer to it as cardiac output most of the time. And then on the x-axis, we have ventricular end diastolic volume, another way of saying preload. So as we're increasing preload going to the right, then most of the time we're going to see an increase in cardiac output. So you're giving the heart more blood and it's going to want to pump that blood out. But we do have some scenarios where that's going to change and you need to know the changes of these curves and how they go. So look in the middle here. So if you look at our normal right here, you see that it's just kind of following along as you increase in preload, you're increasing your overall cardiac output. Now you notice that it kind of flattens out there. So there does come a part where you can increase the preload only so far and then you start getting diminishing results. This is not a straight line by any means. So you see that does end up running out of room at some point. Now what happens if we exercise? So if we're looking at this one right here, we're seeing that for every given preload, we have an increased cardiac output. So one reason for that, one reason why this is being shifted up or to the left is another way of thinking about it, is that we're increasing contractility. So as we're increasing contractility, for whatever preload is going into that ventricle, it's squeezing it even harder. Therefore, we're getting more and more cardiac output or even more and more blood going into the rest of the body. So what happens if you have a disease state? What if you decrease contractility? Well, you're getting a shift of this curve. What if we have CHF? We're getting a shift of the curve to the right and down. So no matter how much preload we're giving to this person, we're not getting near the cardiac output. We do not have the heart muscle to squeeze out that extra blood and do anything. So you'll notice that even the curve is even flatter here. So instead of even our usual normal curve we see here, this one's going down. It looks even limp. What's even more important here to know is that there was a diminishing return on the normal and the exercise, but it never went back to negative. You'll notice that about right here, you're seeing that as we're increasing the preload, we're actually getting decreased cardiac output. So this is sort of what we call the fluid overload status. So CHF patients will often have episodes where they get too much fluids on board, they start getting pulmonary edema, they're getting too much afterload, they're not doing well at all, therefore their cardiac output even goes down. So that's another scenario that you need to realize is that CHF patients can be very susceptible to that fluid overload state. So what if we wanted to treat someone with CHF? How would we make this movement from CHF up to a CHF plus treatment into a better scenario? Well, you could use something like digoxin. So if you use digoxin here, potentially you're increasing contractility, and by increasing that contractility, you're going to improve that overall cardiac output for every preload that you see there. So the next topic is going to be resistance, pressure, and flow. And actually, I wouldn't spend a lot of time trying to memorize any new equations regarding this. What you do need to know is that as you increase viscosity of blood, you're going to increase resistance, which actually makes a lot of sense because the thicker the blood, the less it flows. So viscosity will increase in diseases like polycythemia. Hyperproteinemic states like multiple myeloma. You have a lot of antibodies around that increases viscosity, which is going to increase your resistance. Hereditary spherocytosis is a state of high viscosity because those big red blood cells are circular instead of biconcave. They're not very flexible, so that increases viscosity, which is going to increase resistance. All right, so now we're going to move on to cardiac and vascular function curves. These function curves are like Starling curves, but just a little bit different. Again, cardiac output is on the y-axis, and on the x-axis we have the right atrial pressure, which we've said before is the preload, which again is the same thing as your end diastolic ventricular pressure. So this is, again, just kind of a different way of drawing out the Starling curve. So in the middle of our curve here we have our baseline. Again, we know this. If you increase your preload, then you're going to increase your cardiac output. But then there is going to be a flattening of that curve eventually. The heart can only hold so much, it can only pump out so much blood. Now what happens if you decrease contractility? We've already gone through this, but this looks a little bit different. What's going to shift that curve over to the right and down? So as we covered before, a heart failure is going to decrease contractility and show that shift. Now what else can make our curve shift to the right and overall decrease cardiac output? Well, increasing afterload, too much pressure going back on the heart. That's going to decrease cardiac output for every given preload. Now what's going to shift our curve up and to the left? Well, we said exercise can do that. Drugs like digoxin can do that. So again, nothing new here. Now, the one other thing that I want you to look at here is the venous return. So these are the lines that tend to go down as you go across the graph here. Now, where these lines intersect is where the cardiac output is equal to the venous return. This is what the body wants. The amount of blood leaving the heart is the same as the amount of blood the venous system is returning to the heart. Now, because the cardiovascular system is a closed loop, this is really what you want. You want this all to be equal, for if you start to have a problem here, you're going to accumulate blood in either the systemic or the pulmonary circulations, and that's when you start to see things like systemic or pulmonary edema. Now, you can also see that if you lose a lot of blood, say through hemorrhage, then that's going to alter your ability to provide enough preload, and again, you see a decrease in cardiac output. All right, so these graphs aren't all that complicated if you know the basic principles, and then you can go through these. All right, so now it's time for that end of session quiz. Try to answer those questions yourself, and then we'll go through those together. What is the pulse pressure in a patient with a systolic blood pressure of 150 and a MAP of 90? Well, the equation for mean arterial pressure, or MAP, is 1/3 of the systolic blood pressure plus 2/3 of the diastolic pressure. Now, you know the MAP and the systolic blood pressure from the question, so you kind of plug those into the equation. So the mean arterial pressure is 90, and then 1/3 of 150 is 50. So we need to calculate the 2/3 of the diastolic blood pressure in that equation. So you need to figure out the diastolic pressure first, so you can plug that into the formula for pulse pressure, which was our ultimate goal here. Now, I won't go through all the math here, but if you do the algebra, you end up with a diastolic blood pressure of 60. Then you know the diastolic blood pressure, so you can plug that into the formula for pulse pressure, which is the systolic blood pressure minus the diastolic blood pressure. Again, the systolic blood pressure 150, the diastolic pressure is 60. Subtract that, you get your answer, which is 90. Next question, what is the basic equation for cardiac output? Well, cardiac output is equal to stroke volume times heart rate. Next, what is the Fick principle? Well, cardiac output is going to be equal to the rate of oxygen consumption divided by the difference between your arterial and venous O2 content. Next, how can the myocardial oxygen demand be decreased in circumstances where the heart is ischemic? So you can decrease afterload, and you decrease afterload by reducing systemic blood pressure. You also can do this by decreasing contractility, you can decrease heart rate, and you can decrease preload. Next question, what can make the stroke volume increase for a given preload? So keep preload the same. Well, you can get this first by increasing contractility. So how are we going to increase contractility? Well, it can be accomplished by sympathetic stimulation. You could give an inotropic drug like catecholamines or digoxin. You can increase intracellular calcium, or you can decrease extracellular sodium, and that again is what digoxin does. Then another way to increase stroke volume is to decrease afterload. Drugs like hydralazine or maybe an ACE inhibitor. All right, next question. What is the cardiac ejection fraction? So that ejection fraction is an index of ventricular contractility, and it's going to be equal to the stroke volume divided by the end diastolic volume. So it's the percentage of that blood that the heart can eject from the heart with any given contraction. All right, guys, that brings us to the end of the video. I hope you learned something. I'll see you next time. It's time for another warm-up review. Let's get going. What drugs are known to inhibit cytochrome P450? So the mnemonic for this was crack amigos. So we have ciprofloxacin, ritonavir, which is a protease inhibitor, amiodarone, cimetidine, ketoconazole, acute alcohol use, macrolides, isoniazid, grapefruit juice, omeprazole, and then finally sulfonamides. Next, what is a disulfiram-like reaction? So a disulfiram-like reaction is where you have an inhibition of acetaldehyde dehydrogenase. So alcohol can't be fully metabolized. So you have accumulation of acetaldehyde, and that causes flushing, sweating, nausea, headache, and hypotension. Next, what drugs cause a disulfiram-like reaction? So the drugs that cause this reaction are going to include metronidazole, and then certain cephalosporins, not all of them, but cefotetam, cefmandol, and then cefoperazone. And then also the first generation sulfonylureas, things like tolbutamide. All right, that's it for the warm-up. Let's get to that lecture now.
In this video, we're going to talk about the physiology of congestive heart failure, or CHF. So let's start by thinking about the pressures in the heart. The heart's number one job is pumping blood. So heart failure is essentially pump failure. Now, when a pump fails, the pressure of the fluid going forward drops way down, and the pressure rises in the system feeding into the pump because that fluid's backing up. So the left ventricle is responsible for pumping blood out to the body, and if the left ventricle starts to fail, the pressure in the aorta tends to fall, and as the blood backs up into the left atrium, the left atrial pressure rises. We use something called the pulmonary capillary wedge pressure to estimate the pressure in the left atrium. So how do we measure the wedge pressure? Well, we measure it with a Swan-Ganz catheter. A Swan-Ganz catheter is a venous catheter that's put into either the internal jugular vein or the subclavian vein. Now the catheter is wired through the superior vena cava and then into the right atrium, and then it continues through the right ventricle. And there's a little balloon on the end of the catheter, and when you inflate the balloon, it kind of drifts along with the blood flow circulating through the heart, and the balloon and the catheter float down through the heart. So this inflated balloon goes from the right atrium to the right ventricle and then into the pulmonary artery. And in the pulmonary artery, it continues until it can't go any farther. At the point where it stops, it's been wedged into one of the small branches of the pulmonary artery. At that point, you have what's called a pulmonary capillary wedge pressure. You've wedged that balloon into a branch of the pulmonary artery. And there's a pressure sensing device in the tip of the Swan-Ganz catheter just beyond the balloon, so that when the balloon's inflated, you can measure the pressure distal to the balloon. That pressure is not coming from the right side of the heart because your balloon's inflated and you've blocked the right side of the heart from contributing anything to that pressure. You basically created a little balloon embolus with the Swan-Ganz catheter. So what pressure are you measuring just distal to the balloon? Well, you're measuring the pressure in the left atrium. The wedge pressure is an approximation of the left atrial pressure, which is generally also a good approximation of the left ventricular diastolic pressure. Now, a normal wedge pressure is less than 12 millimeters mercury, and the left atrial pressure is less than 12, and the left ventricular diastolic pressure is around 10. So, if you want to know what's going on in the left side of the heart, a Swan-Ganz catheter can measure the pulmonary capillary wedge pressure and help determine what's going on. Now, in a patient with mitral stenosis, the wedge pressure is higher than the left ventricular diastolic pressure. So think about it. The mitral valve is stenosed or narrowed. So during diastole, when the mitral valve should be open and the left atrium is contracting, the left atrium is contracting against a partially closed mitral valve. So the pressure inside the atrium is going to rise. The blood has nowhere to go, so the pressure rises. And since the wedge pressure is roughly equal to the left atrial pressure, the wedge pressure will rise also. And the wedge pressure will be higher than the left ventricular diastolic pressure. Now we're ready to talk about heart failure and the physiology of heart failure. Heart failure is not a disease in and of itself. Heart failure is a clinical syndrome, a constellation of signs and symptoms that you find in patients who have abnormal cardiac structure or abnormal cardiac function. So this could be an acquired abnormality, such as ischemic heart disease or toxic damage from drugs or myocarditis, or it could be an inherited disorder. But regardless of the underlying cause, heart failure patients have this syndrome of findings, including things like exercise intolerance and fatigue, shortness of breath, pulmonary ralls or crackles when you listen to the lungs, and peripheral edema. So where do all these signs and symptoms come from? Well, let's look at this busy diagram in the study guide. There's a lot going on here, so let's go through it step by step. On the far left, it starts out with decreased left ventricular contractility. That's pump failure. You have pump failure because the heart isn't contracting as efficiently. And what causes decreased left ventricular contractility? Well, the two most common causes are chronic hypertension and ischemic heart disease, including myocardial infarction. So we call this ischemic cardiomyopathy. But chronic hypertension is probably the most common cause. Chronic hypertension leads to left ventricular hypertrophy because the left ventricle has to work harder to pump blood against all that increased blood pressure. So the myocardium becomes thicker, it becomes hypertrophied. And left ventricular hypertrophy becomes heart failure. So you start out with decreased left ventricular contractility, which causes two things: decreased cardiac output and pulmonary venous congestion. We'll come back to that one. Let's focus on cardiac output for the moment. Low cardiac output will decrease the blood pressure. That makes sense. And the body wants to counteract that. It wants to compensate for that low cardiac output. The body's main goal is to get the cardiac output back up somewhat. That's what we see on the top right. The body's trying to compensate for low cardiac output by doing whatever it can to increase cardiac output. So keep that goal in mind. Now there are two main ways that the body tries to compensate for low cardiac output: by activating the sympathetic nervous system and by activating the renin-angiotensin-aldosterone system. And it's not one or the other. The body's going to do both of these. And we're going to see that both of these compensatory mechanisms do work. They do get the cardiac output back up somewhat, but they also have negative consequences, as we're going to see. So let's look at sympathetic activation first, following along that top row. You have decreased cardiac output leading to activation of the sympathetic nervous system. Now, this is a short-term mechanism to regulate the blood pressure. Your carotid sinus senses that decreased pressure and increases its sympathetic outflow, which increases left ventricular contractility, which is a good thing. That's going to increase cardiac output, but again, that's sort of a short-term fix. The other big compensatory mechanism is to activate the renin-angiotensin-aldosterone system. Let's pause our discussion of CHF for just a moment and review the renin-angiotensin-aldosterone system. So it starts with renin, which is an enzyme made in the kidneys, and there are several things that stimulate renin production. One is the sympathetic nervous system, stimulating beta-1 receptors on the kidneys, and that tells the kidneys to secrete more renin. We see that on the diagram. The dashed line shows that sympathetic activation also activates the renin-angiotensin-aldosterone system. A second way to stimulate renin production is that the macula densa cells in the kidney can sense reduced sodium in the glomerular filtrate. And the third way, which is the important one for us right now, talking about CHF and decreased cardiac output, the third mechanism is that the juxtaglomerular apparatus in the kidney senses the blood pressure. When the juxtaglomerular apparatus senses low blood pressure, it tells the kidney to secrete more renin. Then, what does renin do? Well, renin is an enzyme that cleaves angiotensinogen into angiotensin 1. Then we need to convert angiotensin 1 into angiotensin 2. What enzyme does that? Well, it's called angiotensin converting enzyme, which is produced in the lungs as well as in the kidneys. So we've already seen 3 different organ systems involved in the renin-angiotensin-aldosterone system. The kidneys are making renin, the liver is making angiotensinogen, and the lungs are making angiotensin converting enzyme. So angiotensin converting enzyme converts angiotensin 1 to angiotensin 2, and then angiotensin 2 has several actions, but the 2 most important actions are, first of all, angiotensin tenses angios. It's a vasoconstrictor. It's the most potent vasoconstrictor in the human body. It acts on the angiotensin receptors on vascular smooth muscle cells, and that causes vasoconstriction, and that raises the blood pressure. Then the second important action of angiotensin 2 is that it stimulates the adrenal glands to secrete aldosterone, which comes from the adrenal cortex and the zona glomerulosa. So that's a fourth organ involved here, the adrenal gland making aldosterone. And the downstream effect of aldosterone is that it stimulates the reabsorption of sodium and water in the kidney. So angiotensin directly raises the blood pressure through vasoconstriction, and it also indirectly raises the blood pressure by expanding the intravascular volume through secretion of aldosterone and increased sodium and water retention. That's more of a long-term response to low blood pressure. So going back to our diagram, we said that decreased cardiac output and low blood pressure will stimulate the renin-angiotensin-aldosterone system. So you're going to retain sodium and water, and that increases your systemic venous pressure and increases preload, which is going to help to increase cardiac output. So again, the body's doing all this in an effort to compensate for the left ventricular dysfunction. That's what you want to happen. Unfortunately, the increased fluid and increased venous pressure will also lead to peripheral edema. So the box at the top right, increased cardiac output, that's the positive effect we're trying to achieve. The 2 boxes on the bottom right are negative, unintended consequences of all these compensatory mechanisms. That peripheral edema is sort of an unfortunate side effect. Then going back to the beginning on the far left, we said that decreased left ventricular contractility has 2 effects. Not only does pump failure affect the fluid going forward, which is decreased cardiac output, but it also affects the fluid coming in. So as blood backs up, you get pulmonary venous congestion. The blood backs up from the left ventricle into the pulmonary veins, which is going to result in a decreased right ventricular output. So decreased left ventricular contractility eventually leads to decreased right ventricular output. I'm sure you've heard this before. What's the most common cause of right-sided heart failure? Left-sided heart failure. You can hear that again and again throughout your training. With left-sided heart failure, you end up increasing the afterload on the right side of the heart as you congest the pulmonary vasculature. And then that contributes to the peripheral edema because systemic venous pressure is higher and the fluid in the venous system backs up and then weeps out of the circulation into the tissues. But the pulmonary congestion and the left-sided heart failure also cause pulmonary edema. Now that you understand the physiology of heart failure, let's review what CHF looks like clinically. There are 2 broad categories of CHF symptoms and 2 different types of heart failure. There's left-sided heart failure, which causes pulmonary edema and rales and dyspnea, and there's right-sided heart failure, which tends to cause more of the peripheral symptoms like peripheral edema and JVD. So left-sided heart failure can lead to dyspnea or shortness of breath on exertion because the left ventricle output fails to increase during exercise. So of course that fluid is going to back up into the pulmonary vasculature and you have dyspnea on exertion. You're commonly going to see that abbreviated DOE, dyspnea on exertion. Left-sided heart failure can also cause cardiac dilation because you have a greater ventricular end diastolic volume. So the heart just gets bigger and bigger over time, kind of like you're blowing up a balloon. Left-sided heart failure can also lead to pulmonary edema, as we discussed. And you can have paroxysmal nocturnal dyspnea, where the patient wakes up at night gasping for breath. And you can also have orthopnea, where the patient gets short of breath when lying down, but then it gets better when he or she sits up. So all of those symptoms are due to left-sided heart failure. When you see pulmonary symptoms in heart failure, think left-sided heart failure. L for left and L for lungs. Now, what about right-sided heart failure? Well, we mentioned peripheral edema. There's pedal edema, which is edema in the ankles and the legs. There's also presacral edema, where you press on the skin overlying the sacrum and you can make a nice thumbprint because of the pitting edema. You basically have increased venous pressure, which means more back pressure on the capillaries and more leakage of fluid out of the capillaries into the interstitium. You can also see jugular venous distension because of increased central venous pressure. And then right-sided failure can also cause hepatic congestion. So if the right side of the heart fails, blood's going to back up into the inferior vena cava and backs up into the liver. And you can get hepatic congestion and hepatomegaly. Now on biopsy or autopsy, the liver looks mottled. It looks something like a nutmeg seed, which you've probably never seen, but they call this nutmeg liver. Chronic passive congestion of the liver due to right-sided heart failure. So left-sided heart failure causes the lung signs and symptoms. Right-sided heart failure causes signs and symptoms affecting the rest of the body. So R for right and R for the rest of the body. One other thing I want to mention briefly as we're talking about the signs and symptoms of heart failure is a lab test that's often useful, which is called BNP. BNP stands for either B-type natriuretic peptide, or sometimes it's called brain natriuretic peptide. But BNP is a hormone produced in the cells of the cardiac ventricles in response to ventricular stretch. And it does two things. It causes vasodilation, and it's also a natriuretic peptide. It causes increased excretion of sodium and water in the urine. So it's a diuretic hormone. So when the left ventricle is failing and the end diastolic volume rises and the ventricles start to stretch, those myocytes secrete BNP, and the BNP causes a little diuresis and a little vasodilation, and both of those effects will lower the preload and take some of the strain off the heart. Now we can actually measure serum levels of BNP in order to help diagnose CHF. In general, if the BNP is less than 100, that's not CHF. If the BNP is greater than 400, that most likely is CHF. And a BNP of 100 to 400 is indeterminate. It's not really reliable all by itself. So a BNP might show up on your exam as a lab result that they give you to steer you toward one diagnosis or another. So say a patient comes to the ER short of breath, and he has a history of both CHF and COPD. Well, you've got to make a correct diagnosis so you can treat the patient appropriately. Does he need albuterol for COPD, which is going to make his heart work harder, or does he need to be treated for CHF? So it's extremely important to make the correct diagnosis. Possibly he's got a chest x-ray that's kind of hazy looking. You're not sure if he has some pulmonary edema from CHF, or maybe he has some atypical interstitial pneumonia. So you've got to be able to make a correct diagnosis. So in addition to taking a careful history and doing a good physical exam, one test you can order is a serum BNP level. All right, that's it for now. We're going to talk about how we treat CHF in the next video. But first, let's go ahead and do the end of session quiz. First question, what are the signs of right-sided heart failure? So right-sided heart failure is going to have peripheral signs and symptoms. Remember, the rest of the body, such as lower extremity edema, jugular venous distension, and possibly hepatosplenomegaly or nutmeg liver. Next, what are the signs of left-sided heart failure? So left-sided heart failure is going to cause pulmonary symptoms. Remember, L for left and L for lungs. So you can see pulmonary symptoms like dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea, and possibly pulmonary edema and RALS on physical exam. And the last question, how does poor cardiac output result in an increase in aldosterone? So decreased cardiac output leads to low blood pressure, which is then detected by the juxtaglomerular cells of the kidney. And these cells then secrete renin, which activates the renin-angiotensin-aldosterone system, which ultimately increases aldosterone levels. And that's it for now. I'll see you next time.
It's time for another warm-up review. Let's get going. What are the symptoms of organophosphate poisoning? So organophosphate poisoning makes you very leaky everywhere. So it causes things like diarrhea, a lot of excessive urination, meiosis, bronchospasm, bradycardia, excitation of skeletal muscle and CNS, lacrimation, this is where the leaky really comes in, sweating, salivation, and also some abdominal cramping. Next, what are the symptoms of atropine overdose? So atropine overdose makes you dry up everywhere and you have a hard time cooling off. So it causes decreased secretions, elevated temperature, constipation, urinary retention, cycloplegia, mydriasis, and you have confusion and disorientation, especially if you're a little bit older or elderly. Next, how does hemicolinium inhibit the transport of choline into the nerve terminal? So hemicolinium inhibits the sodium cotransporter, bringing choline and sodium into the cell. All right, that's it for the warm-up. Let's get to that lecture.
Hey guys, Dr. Carmichael here, and this is Step 1, Cardiovascular 5, the treatment of CHF. Today we're going to be talking about the medical management of CHF. There are a lot of different drugs that are useful in treating CHF, and a lot of principles in treating CHF come directly from our understanding of the pathophysiology that we discussed in previous videos. The first question in your study guide says, which classes of drugs are proven to improve the survival and reduce hospitalizations in chronic CHF, and which ones are used only for symptomatic relief? The first group of drugs that we definitely improve our survival outcomes are the ACE inhibitors, the angiotensin receptor blockers, or the ARBs, the aldosterone antagonists such as spironolactone or eplerenone, and certain very specific beta blockers. We'll come back to those in just a moment. And then, in select patients, nitrates plus hydralazine have been associated with reduced mortality and improved survival, but still not as much benefit as ACE inhibitors or the ARBs. Specifically, we're talking about African American patients who have moderate to severe CHF symptoms. It doesn't seem to help Caucasians or other non-blacks, and it doesn't seem to help patients with mild CHF. So nitrates plus hydralazine isn't for everybody, but maybe in some patients it's a good idea. And then the other group of drugs are the ones that are used only for symptomatic relief, like the diuretics, especially loop diuretics, and occasionally the thiazides, digoxin, and vasodilators, which include nitrates and hydralazine again. So for pure symptom relief, nitrates plus hydralazine can be very beneficial. Even if your patient isn't in the very specific group, they still may get some mortality benefit. Now, when you look at this list, it may not be immediately apparent but why these drugs are so helpful in CHF. But as I said earlier, the treatment strategies tie very neatly into the pathophysiology of CHF. For instance, we also said that the body's response to decreased cardiac output and decreased blood pressure was activation of the renin-angiotensin-aldosterone system. What drugs can we give to counteract that? We can use ACE inhibitors or ARBs. Those are going back to block the action of the angiotensin. And we also want to block the downstream effects of aldosterone, so we give aldosterone antagonists like spironolactone or eplerenone, which block the effects of increased aldosterone secretion. And we said that aldosterone will cause increased renal sodium and water reabsorption. Even with an aldosterone antagonist on board, you'll still have some sodium and water retention and edema. So we address that with loop diuretics like furosemide or torsemide or bumetanide, or sometimes a thiazide diuretic like HCTZ. Loops are your heavy-duty, big-gun diuretics, so loops are usually the main diuretics we use. But for a patient with mild CHF and a little edema, a thiazide would be an okay choice. But in one of those acute CHF cases, the sick patient with 4+ pitting edema, florid pulmonary edema with rails halfway up their back, you're not going to mess around with HCTZ. You're going to give that patient a loop diuretic. We also mentioned increased sympathetic activity, so that's where your beta blockers come in. And it's not all beta blockers. Specifically, it's the beta blockers metoprolol, carvedilol, and bisoprolol. Now, at first glance, it may seem counterintuitive to give beta blockers. I've had students ask me, if beta blockade is going to reduce blood pressure and reduce my myocardial contractility, why would I give it to somebody with acute CHF? And that doesn't make any sense. And you're right. You never want to start beta blockade in somebody with decompensated CHF. In those patients with chronic compensated CHF, beta blockade can be helpful to control the negative side effects of the sympathetic activation. Remember, beta blockers are on the list of drugs that improve survival and reduce mortality. You want to start with a low-dose beta blocker and gradually increase the dose. but you got to be careful. Beta blockers are definitely indicated, but be careful. And then are the vasodilators like hydralazine and the nitrates. How do those help you with CHF? Vasodilators will dilate blood vessels. Some tend to dilate arteries like hydralazine, which is a pure arterial dilator, and some are vasodilators, which tend to dilate veins like the nitrates. Well, when you dilate arteries, you reduce the afterload, which means the heart doesn't have to work so hard. And when you dilate the veins, you are reducing the preload, which also means the heart doesn't have to work as hard. So vasodilators are pretty good at keeping the fluid from backing up in the pulmonary vasculature and causing all those pulmonary symptoms of dyspnea and orthopnea and so on and so on. And never forget that the underlying problem with CHF is pump failure. Decreased left ventricular contractility leading to decreased cardiac output. So how can you increase that contractility and increase the cardiac output? Well, you can use an inotrope like digoxin, which increases contractility and increases output. Digoxin definitely reduces hospitalizations and improves exercise tolerance, but there's no survival benefit. So those are the major classes of drugs used to treat CHF. We discussed the mechanisms and side effects of most of these CHF drugs elsewhere. The beta blockers are covered in Pharm Basics, and the ACE inhibitors and ARBs are covered in Cardiovascular video on antihypertensive drugs. And we reviewed the diuretics in the renal section. But the only place we're going to use digoxin is in CHF. Digoxin is a cardiac glycoside and it increases myocardial contractility. To understand the mechanism, we have to dig into how muscle contraction works at a cellular level. So let's look at the diagram in your study guide. Down here at the bottom, you have a sarcomere, which is made up of myosin and actin. And the amount of calcium in the cell influences the interaction of actin and myosin to cause muscle contraction. So an increase in intracellular calcium will increase contraction. Write that down. More calcium means more contractility. When calcium enters the cell through the calcium channel on the left, that influx of calcium triggers the release of a lot more calcium from the sarcoplasmic reticulum, and that massive amount of calcium released from the SR really is what makes the sarcomere contract. So there are the calcium channels in the cell membrane that control the flow of calcium into the cell. You also have the sodium-calcium countertransporter that transports shown in the center that pumps the calcium back out of the cell. Otherwise, the cell would just stay contracted all the time. And the thing that drives the sodium-calcium countertransporter is the sodium gradient, where we have lots of sodium outside the cell and relatively low concentrations of sodium inside the cell. So the sodium is going down its concentration gradient, and that allows the countertransporter to pump the calcium out. So what happens if you disrupt that sodium gradient? If less sodium comes into the cell, that means less calcium is going to leave the cell. The more intracellular calcium means more contractility, so higher sodium levels inside the cell will have an effect on keeping calcium in. So, what maintains the sodium gradient? It's the sodium-potassium ATPase pump, which is over here on the right. It constantly pumps sodium out of the cell and is maintaining that sodium gradient. Digoxin works by inhibiting the sodium-potassium ATPase so that you have an increased intracellular sodium and decreased activity of the sodium-calcium countertransporter. And by doing that, you have more intracellular calcium. One more time, more calcium means more contractility. So, digoxin mechanism of action is to block the sodium-potassium ATPase. It is used to treat chronic CHF, not really for acute CHF, but chronic CHF. And it's not really a first-line treatment for chronic CHF because although it provides some symptomatic relief, it doesn't improve survival like those other drugs. Which drugs are the ones proven to improve survival in CHF? ACE inhibitors, ARBs, aldosterone antagonists, beta blockers, and make sure you know those 4 drugs. Digoxin is also used sometimes to control the heart rate in atrial fibrillation because it decreases conduction through the AV node, but calcium channel blockers and beta blockers are generally first line for rate control in AFib. One of the reasons that digoxin isn't a great first-line drug is that it causes a lot of side effects. Digoxin is one of those drugs with a low therapeutic index, with lots of side effects and lots of potential for overdose. It can cause cholinergic effects like vomiting and diarrhea, blurry vision. Vision disturbances are the classic symptoms for chronic digoxin toxicity. Digoxin can also cause some characteristic EKG changes, especially bradycardia. It makes sense that if you give a digoxin to slow down the heart rate in AFib, digoxin can also just cause bradycardia. And then digoxin toxicity is more likely in patients with renal failure because it's renally excreted. And hypokalemia will also predispose you to digoxin toxicity. So to treat digoxin toxicity, you're going to focus on cardiac manifestation because that's what's going to actually kill the person. You need to gradually correct any hypokalemia. You need to give magnesium. Potassium and magnesium kind of go hand in hand, and when you're dealing with arrhythmias, it's very important to correct both of these. And then, if there's a life-threatening arrhythmia like asystole, ventricular fibrillation, or even symptomatic bradycardia, you can give anti-digoxin antibody fragments. This is very rarely used, but you should know about it because it's a classic test question. If the anti-digoxin fragments aren't available, you may give atropine to treat the bradycardia, or you may need a temporary pacemaker, but really bradycardia is an indication for the anti-digoxin fragments. We've all discussed so far the treatment of chronic CHF. Now let's discuss the treatment for a patient with acute decompensated CHF. If you're seeing an acutely sick patient with pulmonary edema and 4+ pedal edema, that's an acute exacerbation of heart failure. These patients are short of breath and they might even be foaming at the mouth because they have so much pulmonary edema. And maybe they have long-standing CHF but have been out of their diuretic for several days and now they're coming in bad shape. So how do we treat that? We have a mnemonic to help you remember this, and it's LMNOP. L is for loop diuretics, and the patient has too much fluid in their lungs. You want to help him urinate that fluid out of the body. And for your test, loop diuretics are going to be your go-to treatment for pulmonary edema. But in practical terms, nitrates may actually be a better choice. M is for morphine, to decrease the pain associated with the increased work of breathing, and additionally to offer some venodilatory effect in the peripheral vasculature. N is for nitrates. We talked about how nitrates work by dilating veins and reducing preload. They actually dilate arteries and veins, but they dilate veins a lot more. And in terms of pulmonary edema, that's a good thing because when you dilate the peripheral vasculature, the blood is going to pool outside the pulmonary vasculature. So you're taking blood out of the pulmonary circulation and pooling it elsewhere so the patient can breathe. So you can give either sublingual nitroglycerin or IV nitroglycerin, and that's going to help relieve that acute dyspnea really quickly. O is for oxygen. Supplemental oxygen is only indicated if the patient is hypoxic. You can titrate that until the pulse ox is satisfactory. You may start with a nasal cannula or maybe need an oxygen mask or maybe even need to intubate that person. You give them as much oxygen as you need. P is for both positioning and pressors. Positioning the patient sitting up with their legs over the edge of the bed, and in severe cases, the patient may require dobutamine. Also worth knowing, loop diuretics can take a relatively long time to work in a CHF patient. And you and me, IV dose of furosemide is going to start working in 10 to 15 minutes, but in a CHF patient with a low cardiac output isn't going to be perfusing their kidneys very well, and it may take up to 90 minutes to start working. And you don't want to wait an hour and a half to see if the patient is going to diurese, keeping your fingers crossed that the patient doesn't crash in the meantime. The other reason that nitrates may make more sense than loop diuretics is that diuretics only benefit patients that are volume overloaded, and about 50% of patients with cardiogenic pulmonary edema may be euvolemic or even hypovolemic. The problem isn't always that they have too much fluid on board, but the fluid is in the wrong place. Nitrates help redistribute that fluid from the lungs to the periphery, and they work faster. But again, for your test, diuretics are always a good choice. Those are your treatments for acute CHF with pulmonary edema. Now it's time for the end of session quiz. So let's take time to look at those and then we'll go through them together. First question, guys. What medications are used to treat chronic heart failure? Those are the ones that help reduce cardiac remodeling, and the ones associated with improved survival are the ACE inhibitors, the ARBs, certain beta blockers, metoprolol, carvedilol, and bisoprolol, and aldosterone antagonists like spironolactone and eplerenone. And in select patients, African Americans, you can use nitrates plus hydralazine. Then, for drugs that are used only for the symptomatic improvement but no survival benefit, are the diuretics, especially the loop diuretics, and digoxin. Next question, what medications are used to treat acute heart failure? Remember the mnemonic LMNOP. L is for loops, M is for morphine, N is for nitrates, O is for oxygen, and P is for positioning or pressors. Last question, what is the mechanism of action of digoxin? It inhibits that sodium-potassium ATPase, which ultimately increases calcium within the cell. And more calcium means more contractility. That's it for this one, guys. We'll see you at the next one.
It's time for another warm-up review. Let's get going. What drugs have each of the following side effects? So first we have agranulocytosis. Think about clozapine, carbamazepine, colchicine, propylthiouracil, and methimazole. Next we have osteoporosis. Think about corticosteroids and also long-term use of heparin. Next we have pulmonary fibrosis. Think about bleomycin and busulfan, which are both cancer drugs, but also think about amiodarone. Next is gynecomastia, which can be caused by spironolactone, THC, chronic alcohol use, cimetidine, ketoconazole, estrogens, and digoxin. Next, we have photosensitivity. So there's a mnemonic SAT for photo, which stands for sulfonamides, amiodarone, and tetracycline. And then drug-induced lupus, the mnemonic here is going to be SHIP, S-H-I-P-P, and that's going to be for sulfonamides, hydralazine, isoniazid, procainamide, and phenytoin. All right, that brings us to the end of the warm-up. Let's get to that lecture now.
In this video, we're going to talk about edema and shock, which can both be thought of as derangements in hemodynamics. So let's talk about the forces that influence hemodynamics and fluid exchange in the capillaries. Now, this is a 5-star topic, very high yield for step 1, so make sure you understand these forces. When blood enters the capillary bed, fluid is moving out of the capillaries into the interstitium, and at the same time, fluid is moving back from the interstitium into the capillaries. Now, in an ideal system, the fluid moving out would exactly equal the fluid moving in, but in reality, not all the fluid makes it back into the venous system right away. That fluid stays in the interstitium, and it gets collected by the lymphatic vessels, and we call it lymph, and then it gets dumped back into the bloodstream down the road. And if you have too much lymph fluid building up in the interstitium, that's edema. Now, there are 4 basic forces that influence how much fluid moves out of the capillaries and how much moves back in. There's a place in your study guide for you to draw this diagram. You need to know what these 4 forces are and which direction they pull and push the fluid. First is PC, which is the capillary pressure, the hydrostatic pressure of the blood within the capillary. That's going to tend to push fluid out of the capillary. The second force is PI, the interstitial fluid pressure, which is pushing fluid back into the capillary. The third force is Pi-C, which is the colloid osmotic pressure of the plasma in the capillaries. C is for capillaries. This is due to the colloid in the plasma proteins. So those plasma proteins are going to exert an osmotic pressure that draws fluid from the interstitium into the capillaries. If you were to increase colloid in your blood, that would increase the plasma colloid osmotic pressure. And if you were to decrease colloid in the blood, that would decrease plasma colloid osmotic pressure. We'll talk about some conditions that cause this, but one example would be if you have nephrotic syndrome and you're losing a lot of protein in the urine, you're urinating out your plasma proteins. Then there's lower plasma colloid osmotic pressure, so more fluid is going to stay in the interstitium, which is why nephrotic syndrome causes edema. Then the fourth force is Pi-I, which is the colloid osmotic pressure of the interstitial fluid, and that's going to draw fluid out of the capillaries into the interstitium. So at the arterial end of the capillary, you tend to have a higher fluid to colloid ratio, and that causes fluid to leak from the capillary into the interstitium. At the venous end of the capillary fluid is a little more concentrated, a little more protein rich, so the colloid osmotic pressure is balanced out, so there's no net exchange at the end of the capillary. But at the beginning, you tend to draw fluid out because the osmotic pressure would be pulling fluid out of the capillary and into the interstitium. So again, make sure you understand these 4 forces. You've got the capillary pressure and the interstitial colloid osmotic pressure drawing fluid out of the capillary, and then you have the interstitial fluid pressure and the capillary colloid osmotic pressure drawing fluid back into the capillary. So make sure you understand those. There's another factor that affects capillary fluid dynamics you should know about, which is called the filtration constant, which we express as Kf. Kf is a measure of capillary permeability. Now, we're not going to do any calculations with Kf, but we are going to talk about conditions that increase or decrease capillary permeability, and therefore increase or decrease Kf. Now, one way you might be tested on this is if they describe a patient with some edema and they give you some diagnostic clues and they ask you what caused the edema, whether it was increased PC or decreased Pi-I or whatever. So, what conditions could cause increased capillary hydrostatic pressure, or increased PC, increased hydrostatic pressure inside the capillaries? Well, CHF is a big one because with right heart failure, the fluid's backing up from the heart into the venous circulation, which means that central venous pressure is going to be elevated. And that's going to increase the pressure at the venous end of the capillary, and the capillaries kind of become congested, hydrostatic pressure rises, and fluid is forced out of the capillary into the interstitium. So CHF is a big one. Venous thrombosis can also increase venous pressure locally, which is why a patient with a DVT in the leg is going to have edema in that leg. Or anything that compresses the veins, like a tumor or even restrictive clothing or a cast, anything that obstructs venous outflow. And finally, if you have sodium and water retention, either from kidney disease or increased activation of the renin-angiotensin-aldosterone system, that increased fluid volume is going to increase the central venous pressure and the capillary pressure, and that'll cause edema. A second major mechanism of edema is increased capillary permeability, because this increases that filtration constant, Kf. Now, septic shock will do this because of release of chemicals like histamine and bradykinin, which cause the capillaries to become leaky, which allows more fluid to leave the capillaries, and that leads to edema. And then certain toxins can do this as well, and so can burns. Now, a third mechanism of edema is decreased plasma colloid osmotic pressure, or decreased Pi-C. We talked about how decreased plasma proteins like albumin could lower Pi-C. For example, patients with liver disease may not be able to synthesize albumin. Or if a patient has protein malnutrition, where he's just not eating enough protein in order to have sufficient amino acid building blocks to make albumin. Or perhaps the patient is making plasma proteins, but then losing them. So we mentioned nephrotic syndrome as a cause of decreased plasma proteins. Or some patients have a protein-losing enteropathy, which is a small bowel problem where they're losing protein in the GI tract. And then the fourth mechanism is increased interstitial colloid osmotic pressure, increased Pi-I. So instead of decreased protein in the blood, here we're talking about increased protein in the interstitium. And lymphatic obstruction is an example of this. Under normal circumstances, any plasma proteins that end up in the interstitium should be taken up by the lymphatics and pumped back into the circulation through the thoracic duct. But if the lymphatics are obstructed by a tumor or inflammation, or maybe following surgery or radiation that damages the lymphatics, but if for whatever reason the lymphatics are obstructed and those interstitial proteins don't get picked up by the lymphatics and they just stay in the interstitium, that's going to increase interstitial osmotic pressure. And on that note, let's briefly go over the difference between pitting versus non-pitting edema, because that's related to these interstitial proteins. Pitting edema is an edema caused by an excess amount of fluid in the absence of additional colloid. So it's kind of like a water balloon, just a sack of fluid, a bunch of fluid. Now, pitting edema is usually a gravity-dependent phenomenon, so it's often going to be seen down in the legs. So when you press on the patient's tibia, on the shin, it's going to leave an indentation or a pit. And that pit's going to stay there for several minutes after you remove your finger or your thumb. And that's called pitting edema. Now, non-pitting edema is where you press on the tibia, but there's no indentation left. Now, this occurs when there's a lot of colloid in the interstitial fluid, which balances out the excess interstitial fluid. Instead of being like a water balloon, it's more like Jell-O, where all that fluid is balanced by a lot of protein. So this balance of fluid and protein creates a semi-solid substance, kind of like Jell-O, and that colloid-rich edema won't pit. Another way to think about it is that the edema fluid from either increased capillary pressure or from decreased plasma proteins is basically just water. It's protein-poor fluid, and we call that a transudate. But edema fluid from increased capillary permeability is going to be protein-rich because you're leaking fluid and protein alike into the interstitium. And this protein-rich fluid is called an exudate. Remember, exudate has extra stuff in it, like proteins and cells. Now let's talk about shock, which is another important disorder that's related to hemodynamics and capillary function. Shock is basically poor perfusion, typically either from cardiac failure or from vascular failure. And there are several different types of shock that you've got to be able to recognize. In your study guide, there's a table that says, how do systemic vascular resistance and cardiac output change in each of the following types of shock? The nice thing about shock is that it's very logical, and you can kind of reason your way through most of this.
Hypovolemic shock might occur following trauma and massive blood loss. There's just less blood around for your heart to pump, so the cardiac output is decreased, and then the arteries are going to clamp down to try to raise the blood pressure, which increases the systemic vascular resistance. Then the treatment, obviously, is to replace fluids. You give IV fluids, most likely normal saline, 0.9% saline. And if you're giving blood products because of the trauma, that also will address the hypovolemia. The next one is cardiogenic shock. Now, what's the primary problem with cardiogenic shock? Well, the heart isn't pumping, so you have decreased cardiac output. Maybe you have a massive MI and the myocardium is stunned, or maybe you had a massive PE. So in either case, cardiac output is decreased. And then, how would you expect the body to respond to that? Again, systemic vascular resistance is going to increase. So with cardiogenic shock or heart failure, there's a compensatory increase in systemic vascular resistance. It's a compensatory mechanism. And then how do we treat this? Remember, inotropic drugs mostly, like dobutamine. The next category is septic shock. Now, sepsis can lead to vasodilation, which means SVR is decreased. You also have leaky capillaries and fluid moving into the interstitium, but vasodilation is the major component with decreased SVR. And the compensatory mechanism is to increase cardiac output. One of the earliest signs of septic shock is tachycardia. If you have a patient with fever, they just look pretty bad, and all of a sudden they become tachycardic, that would be very concerning that the patient's going into septic shock. It looks like the cardiac output is low because the blood pressure is falling, and the cardiac output is actually inadequate to perfuse the tissues, but the cardiac output is really elevated due to tachycardia. The treatment, of course, is antibiotics to treat the infection, and then you also need to fill up that dilated vascular space. Vascular resistance is decreased, and you want to fill up all that vascular space with IV fluids. So with septic shock, you bolus a lot of IV fluids. And then if you need to, you can also give a vasopressor to clamp down the vasculature. Now, which pressor is that? Norepinephrine. Norepinephrine is a drug of choice in septic shock, if a vasopressor is needed at all. And also, be aware that septic shock can be complicated by multi-organ failure, renal failure, liver failure, pulmonary failure, ARDS. You can also get acute pancreatitis, adrenal insufficiency, and DIC. So just be aware that with severe sepsis, everything can start to shut down. And then one thing you'll see, not only with septic shock, but with other forms of shock as well, is that because you're not perfusing the tissues, you're not supplying them with the oxygen they need. So the tissues might shift into anaerobic metabolism and start producing lactate. So this can cause some lactic acidosis, which only makes things worse. The next one is anaphylactic shock, which looks a little bit like septic shock because the underlying cause is vasodilation again. Anaphylaxis occurs when the immune system is pre-sensitized to some allergen. When that allergen is encountered, there's degranulation of mast cells and basophils, and lots of vasoactive amines like histamine are released, and that causes massive vasodilation. So just like in septic shock, the SVR will fall and the cardiac output will rise to compensate. Then what's the treatment for anaphylaxis? Epinephrine. And then the last type of shock is neurogenic shock from something like a brain injury or a spinal cord injury. So the brain isn't communicating well with the heart and with the peripheral vasculature. So brain injury or spinal cord injury can cause neurogenic shock. You're going to see a decrease in both SVR and cardiac output. And again, the treatment here is to fill up the vascular space, so you give lots of IV fluids. And then with spinal cord injury, high-dose steroids are usually indicated to help reduce cord edema.
You'll notice that in terms of SVR and cardiac output, both hypovolemic shock and cardiogenic shock look very much the same. So let's talk about what causes each of these and how you can tell them apart. The most obvious cause of hypovolemic shock is loss of blood. If you have a trauma patient who's in shock, you've got to think about blood loss and hypovolemic shock first. This can also occur in patients with severe burns. Burn patients can have a lot of insensible fluid loss, and that's going to cause a hypovolemic shock as well. Then, what can cause cardiogenic shock? Well, we mentioned MI and pulmonary embolism already. CHF, obviously heart failure, can cause cardiogenic shock. And then so can life-threatening arrhythmias like ventricular tachycardia or ventricular fibrillation, where the heart's beating so fast that it's just not pumping anything forward. Cardiac tamponade can cause cardiogenic shock, and so can tension pneumothorax. And then cardiac contusion can cause cardiogenic shock as well. Shock can be very dangerous because patients can deteriorate rapidly over just a matter of hours. So these patients need to be monitored very closely in the ICU. Now, we've mentioned that you treat several different types of shock with lots of IV fluids and potentially some pressors, so these patients are usually going to need a central line. A central line is an IV catheter that goes into one of the central veins, like the subclavian vein or the internal jugular vein or the femoral vein. And technically, a central line is called a central venous catheter, or a CVC. Now, central lines can often remain in place a lot longer than a peripheral line can. and they also allow you to give more than one drug or fluid at a time. So let's look in the study guide and talk about the different sites where you can insert a central line. The femoral vein is a very easy place to start a line, but it usually can't stay in place more than 5 to 7 days due to risk of infection because it's located in the groin. Plus, patients can't really get out of bed and walk around or even sit up comfortably because they've got this big thing in the groin. And when patients are immobilized, they're more likely to get a DVT. So let's take a quick detour and talk about the anatomy of the femoral region for just a moment. The important anatomy to know is the position of the vein relative to the artery and the nerve. You can use the mnemonic NAVAL: nerve, artery, vein, empty space, and lymphatics. Now, almost everyone can remember that NAVAL is the order, but sometimes in an emergency situation you forget which way the order goes. Is the nerve medial or lateral to the artery? Well, there are a couple of ways to help you remember this. One is that you go from lateral to medial to find the navel. So the order is going to be lateral to medial. Or you can remember the idea that dirty STDs need to be cleaned out by the lymphatics. So the lymphatics are the things that are closest to the genitalia. Or the way I learned it as a student was to think NAVY, which stands for nerve, artery, vein, and yin-yang. Yin-yang means the genitals, which is kind of stupid and childish, but sometimes the childish, stupid stuff sticks in your brain, right? If you know the genitals are the yin-yang, then you know right away that the vein is medial to the artery. And then just a quick reminder that there's a tube of fascia kind of perpendicular to the inguinal ligament called the femoral sheath. And the artery and the vein are within the sheath, but the femoral nerve is outside the femoral sheath. It's pretty straightforward. Now, beyond knowing this for step one, why is this anatomy important clinically? Well, say you're trying to place a central line in the femoral vein. Well, you remember the mnemonic, and you know that the femoral vein is medial to the artery. So you palpate the femoral pulse, which is the artery, then you insert the needle 1 or 2 centimeters medial to that femoral arterial pulse. Now if you get confused and you stick your needle lateral to the artery, what are you going to hit? The femoral nerve. And not only will you not get any blood back, but you might injure the nerve. So remember to palpate the artery and then insert the needle medial to the artery. So that's it for femoral lines. Let's go back to the study guide and wrap up the rest of these central line locations. The subclavian vein is preferred by some because it's easy to find and it can remain much longer for 3 to 4 weeks, and it's not as uncomfortable to the patient. But it has the highest risk of a pneumothorax, so it's not such a great choice in barrel-chested COPD patients or patients with lung tumors. And you always need to check a chest x-ray after you place a subclavian line to make sure there's no pneumothorax, and you also want to check the placement of the tip of the line. You don't want the tip of the line to be all the way down in the right ventricle. The internal jugular vein, or IJ, is a good choice because they're good landmarks, and it can usually remain in place for 3 to 4 weeks, but it can be a little more uncomfortable to the patient, plus there's a risk of puncturing the carotid artery or causing a pneumothorax. And with the left IJ line, there's a risk of perforating the left subclavian artery. Now it's time for the end of session quiz, so work through those questions, then we'll go over them together. First question, how does each of the following circumstances impact the Starling forces of fluid movement through the capillaries? So heart failure will lead to increased venous pressure, which gets translated back to the capillaries as increased hydrostatic pressure in the capillaries, and that pushes fluid out of the capillaries. So right heart failure can lead to peripheral edema, and left heart failure can lead to pulmonary edema. Liver failure will have a decrease in osmotic pressure in the capillaries because you're going to have decreased production of proteins. This decreased osmotic pressure allows fluid to leave the capillaries and stay in the interstitium. The next one is oliguric renal failure. Now with oliguria and fluid overload, there's going to be increased capillary pressure. Infections and toxins are going to increase capillary permeability. Nephrotic syndrome will result in the loss of plasma proteins and decrease the plasma colloid osmotic pressure. Lymphatic blockage causes protein retention in the tissues and in the interstitium, and that increases interstitial osmotic pressure and draws fluid out of the capillaries and into the interstitium, resulting in non-pitting edema. Burns will increase capillary permeability, just like with infection and toxins. And in diuretic administration, the diuretic reduces the hydrostatic pressure in the capillaries, so less fluid is going to be forced out of the circulation and into the interstitium. IV infusion of albumin or clotting factors would increase plasma proteins and increase the plasma colloid osmotic pressure. And venous insufficiency increases capillary pressure and increases local edema. Next, how do the vascular resistance and stroke volume differ in hypovolemic shock compared to septic shock? Well, in hypovolemic shock, the stroke volume decreases and the vascular resistance increases to compensate for the drop in cardiac output. In septic shock, the vessels dilate and vascular resistance decreases. Then the heart attempts to compensate by increasing stroke volume and also increasing heart rate. Next, what are some of the causes of cardiogenic shock? So we talked about MI, PE, CHF, certain arrhythmias, cardiac tamponade, tension pneumothorax, and cardiac contusion. And the last one, how is the skin of a patient different in cardiogenic shock compared to septic shock? So in cardiogenic shock, the skin is typically cold, clammy, cyanotic, and poorly perfused. In septic shock, the skin is initially warm and flushed because of peripheral vasodilation, which is the main driving force in septic shock. And that's it for now. I'll see you next time. Let's go through the warm-up review. The first question has an image. 2 drops of drug X are instilled into a patient's left eye. In the dark, both pupils are dilated. In the light, which is on the bottom image, the right pupil becomes myotic while the left pupil remains mydriatic. So what is drug X? Well, there are 2 classes of drugs that could do this. It's either going to be a sympathetic agonist like epinephrine, which would cause mydriasis, or it's an anticholinergic drug, an antimuscarinic like atropine. But since they don't make epinephrine eye drops, it's probably atropine or some other antimuscarinic. And the last one, what's the antidote for poisoning with each of the following? So the antidote for copper poisoning is penicillamine, remember copper pennies. The antidotes for mercury poisoning are dimercaprol and also succimer. The antidote for TPA and streptokinase is aminocaproic acid. And for digoxin, the specific antidote is anti-digoxin antibody fragments. But remember, the main treatment for dig toxicity is to stop the digoxin. You're going to give potassium and magnesium as needed, and then treat any arrhythmias with atropine or lidocaine, depending on whether it's bradycardia or tachycardia. Now let's go ahead and get started with the lecture.
I am empty. I am nothing.
End of systole.
The door slams in my face.
Closure of the aortic valve.
I must rest, regain my strength.
Isovolumetric relaxation.
Oh, but now the door is open.
Opening of the mitral valve.
I am renewed. I'm filling with life.
Filling of the left ventricle.
Oh, I'm bursting. This is too much. Shut the door, shut the door.
Closure of the mitral valve.
Confined. I feel the pressure building within me.
Isovolumetric contraction.
I must burst forth against the barriers of this world.
Opening of the aortic valve.
Share all that's within me. Pour out every last drop.
Systolic ejection.
I am empty. I'm nothing.
End of systole.
The door slams in my face.
Closure of the aortic valve.
I must rest, regain my strength.
Hello everyone and welcome to our Step 1 video on the cardiac cycle. Today is exciting because we're going to be talking about grafts, but not just any old grafts. Today we're looking at the cardiac cycle. Now this is a 5-star topic. You can expect to have at least a couple questions about this on your test. So we're going to start by looking at the pressure volume loop. And this pressure volume loop is looking at both the pressure and the volume, strangely enough, that is present in the left ventricle during both diastole and systole. So a complete cardiac cycle or just one heartbeat. Now, as you can see, pressure is on the y-axis and volume is on the x-axis. And again, this is referring to pressure and volume in the left ventricle only here. So where should we start? We should start on this loop. We should go to the diastole part. So diastole is going to be beginning with the closing of the aortic valve. And you find this at the left upper corner of this loop. Now at this point, the ventricle has just finished its contraction and expelled a whole bunch of blood. Now the pressure is initially pretty high in the ventricle because of that contraction, but after the aortic valve closes, the pressure drops dramatically. And you'll notice that the volume is not changing at this time. The line is going straight down. No blood is entering or leaving the left ventricle at this time. This is called isovolumetric relaxation. And as the name implies, the ventricle is relaxing and no blood is entering or leaving. Next, we move to the bottom left corner. Now, when the pressure in the ventricle drops below the pressure in the left atrium, something happens. Because the pressure in the left atrium is greater than that pressure in the left ventricle, the mitral valve is then forced open. And when the mitral valve opens, you have blood moving from the left atrium into the left ventricle. Now the ventricle is still not contracting yet. Right now all we are seeing is passive filling, and at this stage I think of the ventricle as a very pliant underfilled balloon. And even though there's an increase in volume, we don't see much of an increase in pressure. So the line here is still pretty flat. Now you may see loops in other books or other resources where that line is maybe sloped up more just a little bit, and that's fine, but realize that the pressure is not increasing much here. You do have an atrial contraction at the end, which completes the filling of the ventricle, and then the mitral valve is going to close. Now we see this at the bottom right of the circuit, and that completes diastole. Now the left ventricle is full of blood and all the valves are closed and the pressure in the left ventricle is still very low. And now that mitral valve is closed, now we can actually begin systole. So at the beginning of systole, you have what's called the isovolumetric contraction period. It's called isovolumetric because, again, we're not changing the volume, but the pressure is increasing at this point. During isovolumetric contraction, both the mitral and the aortic valves are closed. Pressure is increasing because the ventricle is now contracting. And then all of a sudden, the aortic valve opens. This is in the right upper corner of the loop. Blood rushes out of the ventricle. So what causes the aortic valve to open? Well, it opens when the pressure in the ventricle is going to exceed the pressure that's in the aorta. So when the ventricle overcomes that aortic pressure, blood is able to escape the heart. And as you can see by the graph, when the aortic valve opens, the volume of blood decreases because it's leaving the heart, but the pressure is going to continue to increase in that ventricle because of a continued contraction of that ventricle. Then after the ventricle contracts and a significant percentage of the blood has been expelled from the ventricle, then the aortic valve closes, and that signals the end of systole. And then we start all over again with diastole and that isovolumetric relaxation again. So next, let's move on to some pressure volume loop variation. So we saw what the normal loop looks like. Now let's see what happens to that loop when we alter things like afterload, like contractility, and like preload. So first, let's remind ourselves what the normal loop looks like again. We see all the different phases here, not too difficult. So then what happens when you increase afterload? This loop has a very different appearance. Why do we see this loop getting very tall and very skinny? Well, an increased afterload means you have more pressure exerted back on the heart. So think of that as an increased aortic pressure. So the pressure in the ventricle will need to increase even further before that aortic valve can open and then let all the blood out. So the ventricle has to work harder to overcome that increased aortic pressure. Otherwise, the aortic valve will never open. And luckily for us, our ventricles are really strong, and they have the ability to produce a stronger contraction. And with that stronger contraction, the aortic valve opens at the top right corner here, just like in our normal loop, except it's at a higher pressure now. Now, when the aortic valve opens, then you start to lose volume. But you've utilized so much contraction power during that process to overcome that aortic pressure that the volume that you're able to expel from the ventricle is then decreased. So the heart just doesn't have enough contraction power to get as much volume out of the ventricle before the aortic valve closes again. So that's why the loop is skinnier. Now that means that the stroke volume is decreased. Remember that stroke volume is the difference between the end diastolic volume and the end systolic volume. And because the ventricle was unable to eject its usual volume of blood, the left ventricle is then left with an increased end systolic volume. So the left ventricle never empties as well as it should. So that's what you see with increased afterload. So remember that increased ventricular pressure is needed to overcome that aortic afterload pressure, and the stroke volume is then therefore decreased. Next, what happens when we increase preload? Well, when you increase your preload, you're putting more blood into the ventricle from the atria. And that's why the graph moves further to the right. There is more volume in this left ventricle now. Most of the time when you put more volume in the ventricle, the heart is actually able to expel more blood without actually changing the amount of pressure that you're generating. So as you can see, you do not need more pressure for the aortic valve to open. Now, after the aortic valve opens, the heart is able to expel that extra blood in addition to the usual stroke volume, and you're left with a normal end systolic volume. So increasing the preload allows you to increase your stroke volume simply because you're putting more volume in that ventricle, not because you've changed the contractility at all. Now, the end diastolic volume has increased, but the end systolic volume is unchanged. Now, what happens when you increase contractility? Well, by increasing contractility, you will achieve higher pressures in the ventricle. The ventricle is squeezing harder. The afterload, again, is the same, and the preload is the same. The aortic valve is still going to open at its normal pressure point because the aortic pressure, or that afterload, hasn't changed at all. Now, because we have more contractility, the heart is able to eject more blood out of the heart. So we see an increase in stroke volume and a larger ejection fraction. And we see a decrease in the end systolic volume. There's less blood left in that ventricle. But the end diastolic volume is still going to be unchanged. the left ventricle is still able to fill up to its usual capacity. Now, an easy, maybe sort of dumb way to remember how the PV loops change with each parameter. So if we have increased afterload, you would write the letter A. And the letter A is kind of a tall and skinny thing. So you can kind of imagine that's how that pressure loop looks, like a tall, skinny A. And then if you have increased contractility, you can write the letter C, and you make that kind of curve to the left. So it kind of tells you that it's going to move that curve over to the left. And then you have the increased preload. So when you write a P, the curve of the P, letter P, is going to move you to the right. So that's kind of an easy, cheap way of remembering which direction these curves are going to move whenever you change those right there. Okay, so let's look at another diagram. And yes, I know this has a lot of stuff on it, but it's actually pretty useful, not that hard, and you do need to know it. Pressure here is on the y-axis, time is on the x-axis. Pay special attention to where systole and diastole are taking place, and use what we just learned about that cardiac cycle to kind of orient yourself to when these events are taking place. Now there are many lines here. Each of these lines represents a different area or a different measurement regarding the heart. So the very top dotted line here is your aortic pressure. The first section is systole. Well, what happens first in systole? Well, we just learned that we have isovolumetric contraction and then the aortic valve opens. So when that aortic valve opens, it's opening because the pressure of the ventricle starts to exceed that of the aorta. And you can see that right here. The orange line is the left ventricular pressure, and right here where these two lines intersect is where that aortic valve is forced open. Now there is a rapid ejection taking place from the ventricle into the aorta at this time. Now, that's why you see an increase in that pressure. Now, then the pressure is going to decrease, and then that aortic valve is going to close. Now, after the aortic valve closes, you have an abrupt, kind of mild increase in pressure again. The dip here is called the dicrotic notch, and that brief increase in pressure is referred to as the dicrotic wave. So what's going on here? Why is the pressure increasing in the aorta after the aortic valve closes? Well, as the ventricles enter into diastole, there is actually a brief reversal of flow from the aorta back into the left ventricle. And this helps aortic valves to actually shut. This will also result in a slight increase in aortic pressure caused by the elastic recoil of the semilunar valves and the aorta. So the dicrotic notch and that second increase in the aortic pressure is due to that elasticity of the aorta. Now there's another important event occurring at this time period as well. Here we see the filling of the coronary arteries. Yes, the coronary arteries are filling during diastole, not during systole. Now this backflow of blood back towards the aortic valve is the blood that is actually going to fill those coronary arteries. The coronary arteries open right behind those aortic valve leaflets, and so that allows for filling of the coronary arteries. Next, let's go over the left ventricular pressure. So we talked about this a little bit already. This is the orange line, and it's pretty self-explanatory. We went through the cardiac cycle with the pressure volume loops. And you can see the dramatic increase in pressure during isovolumetric contraction, and then a continued increase in pressure even after that aortic valve opens, and then a rapid decrease in pressure during isovolumetric relaxation, and then relatively low pressures during diastole. Now it's obviously up during systole and at baseline during diastole. You do see a little increase in pressure just before the beginning of systole, and this is due to atrial contraction. So as that atria contract to get that last little bit of blood into that ventricle, we do see a small increase in pressure just before the close of the mitral valve. Next, let's look at the left atrial pressure or the venous pulse. These are not exactly the same, but their waves will look very similar. Now, on some images, you might actually see these separated. On this image, they are actually combined. So let's start at diastole on this one. The pressure in the atrium is pretty flat throughout most of diastole. And as we just saw with the ventricle, we see an increase in atrial pressure during that atrial contraction. And this is sometimes referred to as the A wave. Usually we refer to the A wave on the jugular pulse. But then we see another spike in pressure during isovolumetric contraction. This is called the C wave. So this pressure is actually coming from the ventricles. So when the ventricle contracts, the pressure will actually cause the mitral or the tricuspid valve to kind of bulge into the atria, and that causes an increase in pressure in the atria. And then we see one more wave called the V wave, and this is an increase in atrial pressure due to filling against a closed mitral or tricuspid valve. Now let's talk about your heart sounds next. So your heart sounds are definitely worth knowing and very testable and high yield as well. So let's start with your S1 heart sound. So you see your S1 heart sound, it's going to correspond to mitral and tricuspid valve closure. S2 occurs right with the aortic and the pulmonic valve closure. So those are easy. Now we get to some hard ones. And then there's an S3 heart sound. So what is the S3 heart sound? Well, the S3 heart sound is in early, kind of to mid diastole during rapid ventricular filling. And it's associated with increased filling pressures and is more common in dilated ventricles. So when you think of S3, think of rapid ventricular filling. And what specifically can cause that S3 heart sound, because not everyone's going to have one. Let's go through a few of these things. So remember that we said that this is associated with dilated ventricles. So what dilates a ventricle? Well, this can occur with dilated cardiomyopathy, congestive heart failure, mitral regurgitation, and a left to right shunt. So what is that left to right shunt? Think about things like a VSD, an ASD, or a PDA. So those are the few scenarios where we can actually have that S3 heart sound. Now just to reiterate, dilated cardiomyopathy, CHF, mitral regurg, left to right shunting, including that VSD, ASD, or PDA. And that S3 can be normal in children. It can also be normal in pregnant women. So in these situations, you see a lot of preload, a lot of filling pressures there, but you also want to think pathologically with dilated hearts. Now let's move on to your S4. Your S4 heart sound should be right before your S1 heart sound, and your S4 heart sound is your atrial kick. It occurs in late diastole, and this is due to high atrial pressure associated with ventricular hypertrophy. So the left atrium, when it contracts, it must push against a very stiff left ventricle wall. So when you think of an S4 heart sound, think of stiffened left ventricle wall in that atrial kick. Now, when do you have a stiffened left ventricle? Well, you would see it during hypertrophic cardiomyopathy. You could see it during aortic stenosis and just chronic hypertension with left ventricular hypertrophy. In chronic hypertension, the left ventricle has to hypertrophy to overcome that huge afterload. And then also commonly after an MI, you might hear an S4 heart sound in that situation as well. So just to reiterate, hypertrophic cardiomyopathy, aortic stenosis, chronic hypertension with left ventricular hypertrophy, and after an MI, those are the major scenarios where you're going to see an S4 heart sound. All right, so now let's look at our ECG stuff. So the QRS segment is associated with atrioventricular valve, or the mitral and tricuspid valve closure. And that's just going to make sense there. Now, what does your QRS segment represent? Well, it represents ventricular contraction. So it represents that electrical signal going through the ventricle. So as the ventricles contract, they build up pressure, and that's what's causing the tricuspid and mitral valves to close. So your QRS segment is associated with that AV, atrioventricular, or the mitral and tricuspid valve closure. Now let's move on to splitting. We're talking about splitting of S2. So the splitting of S2 can actually be normal, especially in younger individuals and also especially in athletically trained individuals. Now, normal splitting of S2 happens with inspiration. So why does this happen? What's going on here? So the S2 is split here because your aortic valve closes earlier than your pulmonic valve. Now, much of the time, the closure of these two valves is happening so closely together that it sounds like one heart sound. It sounds like just the S2 heart sound. But as you inspire, those two closures can spread apart. So you might hear two brief heart sounds of the split S2. So why does this happen? Well, as your diaphragm lowers, you decrease the intrathoracic pressure, and when the atmospheric pressure exceeds intrathoracic pressure, air goes into your lungs. That's how we breathe. Well, the same thing happens in the vasculature. So as your diaphragm goes down, you decrease intrathoracic pressure, which causes that air to go in the lungs, but it also causes more blood to actually come into the right atrium. So inspiring causes more blood to go into the right atrium. Therefore, more blood in the right atrium is going to mean more preload, and that's going to go into the right ventricle. Well, because there's more volume in the right ventricle, it takes a little bit longer for that right ventricle to squeeze out all that extra blood, and it takes a little bit longer to close the pulmonic valve. So the right ventricle has to get rid of more volume than the left ventricle. Now, also, as the right ventricle fills with more volume, the interventricular septum gets maybe a little bit pushed over to the left slightly. So not only are you increasing the amount of blood in the right ventricle, you're maybe slightly decreasing the amount of blood in the left ventricle. So all that leads to the aortic valve closing a little before the pulmonic valve, and you get that split. Now, wide splitting of the S2 is an exacerbation of what we just described. Wide splitting of S2 is associated with pulmonic stenosis or a right bundle branch block. So these are areas where it's going to take even longer for the right ventricle to expel its volume. It's not just with inspiration here that you have this wide splitting. It can also be with expiration as well. So a split S2 on expiration is never normal. Split S2 on inspiration can be normal. Next, let's talk about fixed splitting. So this is associated with atrial septal defects. So again, what's going on? Where do you have high pressures, on the left side of the heart or the right side of your heart? Well, most of your higher pressures are going to be on the left side of your heart. So with an atrial septal defect, the left atrium is spilling blood into the right atrium. So more blood or preload is going into that right side of the heart. And now there's an overloading of that right ventricle again. So again, this will lead to a slower closure of the pulmonic valve and a fixed splitting of the S2. So it's during inspiration and expiration again. And then next we have paradoxical splitting. This occurs when there is a delay in the emptying of the left ventricle. We've been talking about right this whole time. Now let's talk about the left. So instead of the aortic valve closing slightly before the pulmonic valve, now the pulmonic valve is closing first because of this delay in the closing of the aortic valve. And paradoxical splitting is associated with aortic stenosis or left bundle branch block. So how does this splitting change with inspiration? Well, in our previous types of splitting, the splitting would actually worsen with inspiration. But within paradoxical splitting, the aortic valve closure and the pulmonic valve closures are actually getting closer together because the pulmonic valve is delayed slightly due to that increase in blood going into that right side of the heart, as usual. So that's why it's called paradoxical splitting, because the splitting seems to improve with inspiration. All right, guys, that brings us to the end of the lecture part. I know that was a lot. Let's go through our end of session quiz. First question, when does isovolumetric contraction take place? Well, it's going to take place during the QRS, so after the mitral valve closes, but before the aortic valve opens. Next, how does an increase in afterload affect the stroke volume of the heart, assuming contractility remains the same? So it's going to decrease the stroke volume. Remember, it's making our pressure volume loop taller and skinnier, like the letter A. Next, what impact does an increase in contractility have on stroke volume, assuming preload and afterload remain constant? So this will increase the stroke volume. Remember, it's shifting that curve to the left, like the letter C going to the left on that pressure volume loop. Next, what heart sound is associated with dilated congestive heart failure? So dilated ventricles, that's going to make you think of an S3 heart sound. Next, what heart sound is associated with chronic hypertension and a stiffened left ventricle? Remember that stiffened left ventricle should make you think of an S4 heart sound. And what gives rise to the jugular venous A, C, and V waves? So remember, A is the atrial contraction, C wave is the ventricular contraction, and then the V wave is an atrial filling against a closed tricuspid valve. Next question, where does the QRS complex fall in relation to valvular dynamics? Well, basically it's right before mitral and tricuspid valve closure because it's the electrical signal of the QRS complex that causes the ventricles to contract, and that increased pressure in the ventricles will cause these valves to close. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time. Hello everyone and welcome to another warm-up review. Let's get going. What drug category has each of the following endings? Well, first we have sartan. If it ends in sartan, think of the angiotensin receptor blockers. Next we have stigmine. So those are the cholinesterase inhibitors. Think of neostigmine, physostigmine. Curium or curonium. So those are the non-depolarizing neuromuscular blocking drugs. Glitazone. So think of the TZDs or the thiazolidine diones. Dipene, so those are the dihydropyridine calcium channel blockers, so that's things like nifedipine or amlodipine. Azepam, those are the benzodiazepines. Conazole, those are antifungal drugs. Caine, think of local anesthetics. Cycline, think of tetracycline antibiotics. And Navir, think of protease inhibitors. All right, that's it for the warm-up. Let's get to that video.
In this video, we're going to talk about heart murmurs, which you definitely need to know for step 1. Heart murmurs are a 5-star topic. You're definitely going to see questions where you have to identify a valvular heart lesion based on the clinical picture plus a recording of the murmur. And we're going to listen to some recordings of heart murmurs, so make sure you have some headphones handy. Now, the good news is you don't have to be the king or queen of cardiac auscultation to get these questions right. But there are 3 key pieces of information that you need to pay attention to in heart murmur questions. The clinical scenario, the location on the chest where the murmur is the loudest, and the timing of the murmur, whether it's systolic or diastolic. So, as we talk about different types of heart murmurs, pay attention to those 3 pieces of information. Now, on the audio questions, they're going to show you an illustration of the patient's chest, and you can click on different areas of the chest and hear how the murmur sounds at different locations. And there's a separate window with a computer-animated patient. And you can see the chest rising and falling as the patient breathes. So you can listen for whether the murmur changes during inspiration or if there's paradoxical splitting of S2 or wide splitting or whatever. But again, the most important things to focus on are the clinical scenario, the location of the murmur, and the timing of the murmur. Now, what do we mean by the location of the murmur on the chest? Well, placing your stethoscope on different areas of the chest allows you to listen to different valves. There are tons of different mnemonics for these, like apartment M, or all physicians take money, or all patients try medication. But whichever mnemonic you use, A is the aortic valve, which is heard best at the right second interspace, adjacent to the sternum. P is for the pulmonic valve, which is heard at the left second interspace, adjacent to the sternum. T is for the tricuspid valve, which is heard at the left fourth interspace, adjacent to the sternum. And then M is for the mitral valve, which is heard at the left fifth interspace in the midclavicular line, out at the apex of the heart. So you have to know what valve you're listening to when you put your stethoscope on the chest. And before we get into the murmurs themselves, there's a question in the study guide that says what abnormal heart sounds are considered benign when there's no evidence of disease. Now, if there's evidence of disease like syncope or poor perfusion or any other evidence of cardiovascular disease, that's a different story. But if there's no evidence of disease and you just happen to hear one of these incidentally, it's not a big deal. They are a split S1, a split S2 on inspiration, an S3 heart sound in a patient younger than 40. So if you hear an S3 in a patient older than 40, you need to think about heart failure, maybe from ischemic cardiomyopathy. But an S3 heart sound in a patient under 40 is generally benign unless there's evidence of disease. And then the fourth one is an early, quiet systolic murmur. So if it's a holosystolic murmur or a loud murmur, or if there's evidence of disease, it's not benign. But an early, quiet systolic murmur in a patient with no evidence of disease is generally not a problem. Most of the murmurs we're going to talk about are related to valvular heart disease, because if the valve doesn't open completely or doesn't close completely, that's going to cause turbulent flow of blood across the valve, and that's what makes the murmur sound, turbulent flow. So it can be very helpful to think about when blood is flowing across each valve in relationship to the cardiac cycle, because that's going to help you really understand why certain valve lesions cause systolic murmurs and why other valve lesions cause diastolic murmurs. So what's going on in the heart during diastole? Well, the ventricles are relaxing, they're filling with blood. So which valves are going to be open during diastole? It's the mitral valve and the tricuspid valve. So if you know that, you can reason out what types of valve lesions will cause diastolic murmurs. Stenosis of the mitral valve or stenosis of the tricuspid valve will produce a murmur during diastole. The blood that's flowing from the atria to the ventricles can't pass through those stenotic narrowed valves very easily, and that generates turbulent flow and that generates a murmur. So those are examples of diastolic murmurs, mitral and tricuspid stenosis. And then what are the aortic valve and the pulmonic valves doing during diastole? Well, they should be closed. Normally there's no blood flowing across the aortic valve or the pulmonic valve during diastole. But if the valves don't close completely so that some of the blood can leak back into the ventricles, that's going to cause a murmur. We call that leaking of blood regurgitation. So aortic regurgitation and pulmonic regurgitation will also cause diastolic murmurs. Now you have to be able to listen to a murmur and tell if it's systolic or diastolic. When you hear a diastolic murmur, it's generally going to be one of those four I just mentioned: mitral stenosis, tricuspid stenosis, aortic regurg, or pulmonic regurg. And then if you hear the diastolic murmur best in the mitral position, you know it's mitral stenosis. Or if you hear that diastolic murmur best at the pulmonic position, you know that's pulmonic regurgitation. Now, what about systolic murmurs? Well, think about what happens during systole. The ventricles are contracting. So which valves do you expect to be open during ventricular contraction? Well, the aortic valve and the pulmonic valve. So stenosis of either the aortic valve or the pulmonic valve is going to cause a systolic murmur. And then regurgitation through the mitral valve or the tricuspid valve can also cause a systolic murmur. So make sure you can reason that out. Understanding the physiology is much better than simply memorizing it. There are some bedside maneuvers that you can have the patient perform that's going to change a heart murmur. Either make the murmur louder or softer, or make it longer or shorter. Now, this can get very confusing, so I want to keep it simple. And again, I want you to try to understand what's going on so that you can reason it out instead of just memorizing it. First of all, think about how breathing affects the pressures in the heart. During inspiration, there's negative intrathoracic pressure. That negative intrathoracic pressure pulls blood from the vena cava into the right atrium. So during inspiration, you have more right atrial filling. So which type of murmur do you think is going to be louder with more blood filling the right atrium during inspiration? A tricuspid murmur or a mitral murmur? Well, tricuspid murmurs on the right side of the heart become louder during inspiration because there's increased blood flow across the tricuspid valve. But with the mitral valve, the opposite is true. Mitral murmurs become louder with expiration because you're filling up the left atrium more. A couple of students have suggested that the I in right could remind you that right-sided murmurs are louder during inspiration, I for inspiration. And then the E in left can remind you that left-sided heart murmurs are louder during expiration. Another maneuver is hand grip. You tell the patient to make a tight fist and hold it for 60 seconds. And when those muscles are contracted, they clamp down around all the arteries in the forearm. And that increased tension is going to increase systemic vascular resistance and increase afterload, and that makes the murmur of mitral regurgitation louder, as we're going to see. There's also the Valsalva maneuver, where you have the patient close his mouth or close the glottis and bear down like they're straining to go to the bathroom. And the Valsalva maneuver will increase intrathoracic pressure, so it's kind of the opposite of inspiration. It reduces venous return to the right side of the heart, and it also reduces systemic blood pressure if you have them Valsalva long enough. So Valsalva reduces both preload and afterload, and it makes most heart murmurs quieter. But there's one murmur that gets louder with Valsalva. That's the murmur of hypertrophic cardiomyopathy. Now, we're going to talk about hypertrophic cardiomyopathy another time in the video on cardiomyopathies. But I want you to file that away from now. Valsalva makes most murmurs quieter, but it makes the murmur of hypertrophic cardiomyopathy louder. So let's look at some specific murmurs and the conditions that cause them. We're going to review the diastolic murmurs first, starting with aortic regurgitation. Now, this is a phonocardiogram of an aortic regurgitation murmur. It's a visual representation of what the murmur sounds like. So you can see the S1 heart sound, which occurs when the mitral and tricuspid valves close. And you also have the S2 heart sound when the aortic and pulmonic valves close. So on this phonocardiogram, you can see that aortic regurgitation is causing a murmur during diastole, after S2. And I want you to take note that the murmur begins immediately after S2. Again, think about what's going on during diastole. The aortic valve should be closed, but in aortic regurgitation, as soon as the ventricles start to relax and the ventricular pressure starts to drop, blood starts flowing backwards from the aorta into the left ventricle. And you're going to start hearing that diastolic murmur immediately. Aortic regurgitation is usually heard the loudest along the left side of the sternum because that regurgitant jet of blood is kind of shooting right down into the left ventricle. Another clinical clue to the diagnosis of aortic regurg is a wide pulse pressure. Instead of a blood pressure of 120/80, it might be 120/40. Think about it. The left ventricle has ejected a bunch of blood into the aorta, and then as the heart relaxes, some of that blood is starting to flow back into the left ventricle, regurgitating back through that leaky aortic valve. So the systolic blood pressure is normal, but what happens to the diastolic blood pressure? Well, as that blood flows back into the ventricle, the pressure in the aorta drops off rapidly. So the systemic diastolic pressure will tend to be low, and you have a wide pulse pressure. And then a couple of exam findings they might give you, without actually giving you the blood pressure readings, are that this wide pulse pressure can make the peripheral pulses feel really strong and bounding, which is sometimes called a water hammer pulse. And sometimes you see a subtle head bobbing because of that strong arterial pulse. You feeling okay, Dr. Lewis? Now, what kinds of things cause aortic regurgitation? Well, it can be due to dilation of the aortic root. So why would the root of the aorta be dilated? Well, one reason is syphilis. We don't see syphilis very often in the U.S. anymore, but tertiary syphilis can cause dilation of the thoracic aorta and some aortic regurgitation. And it can also sometimes cause aortic stenosis. Another cause of dilation of the aortic root is Marfan syndrome, which can result in aortic regurgitation. Then another cause of aortic regurg is a bicuspid aortic valve. So instead of having a normal 3-leaflet aortic valve, the patient just has a 2-leaflet valve. Now that most commonly causes aortic stenosis, as we're going to talk about later, but it can also cause some aortic regurg. Then a final cause of aortic regurg would be rheumatic fever. Rheumatic fever can cause all sorts of valve lesions. Let's talk about mitral valve stenosis. One thing you'll notice about mitral stenosis is that there's a little pause between S2 and the beginning of the murmur. Now, that's different from aortic regurgitation, where the murmur started immediately after S2. So why is mitral stenosis different? Well, S2 occurs when the aortic valve and the pulmonic valve close. At that moment, all 4 valves are supposed to be closed. The ventricles are relaxing and the pressure in the ventricles is dropping, but the pressure hasn't dropped enough for the mitral valve to open. So with all 4 valves closed, the volume in the ventricle isn't changing. So this is the isovolumetric relaxation period. But the important thing is that the valves are closed, including the mitral valve. And if there's no blood flowing across the mitral valve, there's no murmur. So in mitral stenosis, the murmur starts a little bit after S2 because the mitral valve hasn't opened yet. Then when it does open, it's stenotic or narrowed, and there's a snap when it opens. You can think of it as though the leaflets are sort of stuck together, and in order to open, it has to snap open. Even if you don't quite notice that subtle distinction, the other key feature that's going to help you tell mitral stenosis from aortic regurg is the location. We said that aortic regurg is heard along the left border of the sternum, but mitral stenosis is heard loudest at the mitral position, at the apex of the heart, the fifth intercostal space in the midclavicular line. Mitral murmurs are also heard best when the patient's lying in the left lateral decubitus position. So you have the patient roll over onto his or her left side, you put the stethoscope on the mitral area, and that murmur may be easier to hear. Now, what other heart sounds are heard best in the left lateral decubitus position? Well, there's mitral stenosis and also mitral regurgitation, and a left-sided S3 heart sound or a left-sided S4 heart sound are also going to be heard best in the left lateral decubitus position. The murmur of mitral stenosis is enhanced by expiration and other maneuvers that increase blood return to the left atrium. So again, we see that expiration is going to enhance left-sided murmurs, like mitral murmurs. Then one other thing to highlight is the S2 heart sound. Sometimes it's tricky to tell whether you're listening to a split S2 heart sound or a normal S2 heart sound with an opening snap due to mitral stenosis. Well, the opening snap of mitral stenosis is going to be followed by the murmur, obviously. But another clue is that the splitting of S2 is exacerbated by inspiration. So inspiration makes S2 more split, while the opening snap and the murmur of mitral stenosis are enhanced by expiration. So that could help you. Mitral stenosis is often caused by rheumatic heart disease, which can lead to scarring of the mitral leaflets. And then chronic mitral stenosis can result in left atrial dilation, which makes sense if you think about it. If you're not able to empty the left atrium because that mitral valve is stenotic, there's going to be more blood and more pressure in the left atrium, and over time, the left atrium will dilate. Let's touch on the murmur you hear with a patent ductus arteriosus, or PDA, which is a non-valvular lesion. These other murmurs so far have been caused by valve problems, but a PDA is a non-valvular murmur. This is a continuous machine-like murmur that's heard throughout both systole and diastole. It's continuous. There's always blood flowing through the PDA. Now, how do we keep a PDA open? With prostaglandins. And how do we close it? With NSAIDs like indomethacin. So that's pretty much it for the diastolic murmurs. We're going to cover systolic murmurs in the next video. So for right now, let's take a look at the end of session quiz. First question, through which heart valve should blood be flowing during systole and during diastole? So during systole, blood should be flowing through the aortic and pulmonic valves, and during diastole, it's the tricuspid valve and the mitral valve. Next, what are the diastolic murmurs? Well, there's tricuspid stenosis, mitral stenosis, aortic regurgitation, and pulmonic regurgitation. And the last one, what murmurs are heard best in the left lateral decubitus position? Well, we said it was your mitral murmurs, both mitral stenosis and mitral regurg, and then also left-sided S3 and S4 heart sounds. Then we have two rapid-fire facts for this video. Bounding pulses, head bobbing, and a diastolic murmur, that should make you think about aortic regurgitation, and a continuous machine-like murmur should make you think about a PDA.
That's it for now. I'll see you next time.
It's time for another warm-up review. Let's get going. Outline the pathway of converting phenylalanine to epinephrine. The first step is going from phenylalanine to tyrosine. The enzyme phenylalanine hydroxylase is going to add a hydroxyl group. Next, going from tyrosine to dopa, the enzyme tyrosine hydroxylase adds another hydroxyl group. Next, you go from dopa to dopamine, and the enzyme is dopa decarboxylase. This requires vitamin B6. And this is the enzyme inhibited by carbidopa. Next, you go from dopamine to norepinephrine, and then the last step is norepinephrine to epinephrine, which is the enzyme phenylethanolamine N-methyltransferase, or PNMT. All right, that brings us to the end of the warm-up. Let's get to that lecture now.
We began our discussion of heart murmurs with the video on diastolic murmurs. And if somehow you missed that one, I strongly suggest you go back and watch that video first. Now in this video, we're going to review systolic heart murmurs, including aortic stenosis, mitral regurgitation, mitral valve prolapse, tricuspid regurgitation, and VSD. So let's start with aortic stenosis, which is my very favorite valvular heart lesion, which did not sound quite so nerdy until I just said it out loud. Before we look at the phonocardiogram and listen to the murmur, think about this with me. Aortic stenosis causes a systolic murmur, which occurs between S1 and S2. But do you expect the murmur to begin right with S1? No. There's a tiny gap between S1 and the beginning of the murmur during the isovolumetric contraction period.
So S1 is the sound of the mitral valve and the tricuspid valves closing. And right at first, the ventricles are contracting, but the pressure isn't high enough to open the aortic valve and the pulmonic valve yet. So the volume of the ventricles isn't changing, and this is isovolumetric contraction. So even if there is some aortic stenosis, right after S1, the aortic valve is still closed, and there's no blood flowing across it, so there's no murmur right after S1. And then when that pressure gets high enough, it forces the aortic valve open. When the valve opens, you have this ejection click due to those valve leaflets coming to an abrupt stop. In aortic stenosis, the valve leaflets are usually scarred and calcified. That's why they aren't opening fully. That's why you have stenosis. So those calcified leaflets come to an abrupt stop, and it makes this abnormal sound, this ejection click. So you hear S1, then there's an ejection click, and then the murmur starts. And this murmur is sometimes described as a crescendo, decrescendo murmur. Those are musical terms. Crescendo means it gets louder, and then decrescendo means it gets softer. So you hear the murmur start soft after that ejection click, and then it peaks in intensity, and then it decrescendos or gets softer. And it ends at S2 when the valve closed. That ejection click can be difficult to hear, but think about the timing and the location. If you can tell this is a systolic murmur that's loudest in the aortic position, the right second interspace, you should be able to guess that it's aortic stenosis. And there are also some clinical clues that can help you. Not only is the murmur heard at the aortic position, but it's also going to radiate to the carotids. As blood goes from the ventricle through the aortic valve and up into the carotids, it's still going to have turbulent flow all the way up there. So if you put the stethoscope on the carotids, you can hear that systolic murmur. It sounds a lot like a bruit. You can also feel the weak, delayed peripheral pulses, which is kind of what you'd expect. That narrowed stenotic aortic valve is kind of blocking the blood from going into the aorta, and it's reducing the force of each beat. Now, you're not going to perfuse very well because you're not maximizing the blood that can flow through the aortic valve with each contraction. So as a result of this, not only do you feel weak pulses, but the patient could also have syncope. If normally you're able to push a certain volume of blood through, now with stenosis you can't push as much blood through. You're not going to be perfusing the brain like you should be. So if they give you an elderly patient with syncope, at least entertain the possibility of aortic stenosis. Then besides syncope, two other symptoms you should think about with aortic stenosis are angina, or chest pain, and also dyspnea, or shortness of breath. So know those three classic symptoms: syncope, angina, and dyspnea. You don't have to have all three. If you have any one of those in the presence of aortic stenosis, it's a very dangerous situation. It's time to replace that valve. Now, what kinds of things cause aortic stenosis? Well, there are 5 causes of aortic stenosis that I want you to make note of in your study guide. The most common cause is a bicuspid aortic valve. So instead of having a 3-leaflet aortic valve, the patient just has a 2-leaflet valve. We saw that as a potential cause of aortic regurgitation as well. A bicuspid aortic valve is a congenital defect, but it generally doesn't start causing problems until after age 40. So most people with bicuspid aortic valves don't know that they have a problem until they get to age 40 and that abnormal valve starts to become calcified, kind of similar to the calcification you get in your vessels due to atherosclerosis, only here we're talking about calcification of the valve leaflets. So these patients are born with a bicuspid valve, and then as they age, the valve starts to become calcified. They start having progressive stenosis of that valve, and then they get syncopal episodes or chest pain or other evidence of aortic stenosis. So be aware of that. Then the second most common cause of aortic stenosis is what's called senile calcification or degenerative calcification. So here you have a normal 3-leaflet valve, and that valve becomes calcified. This usually becomes apparent after age 60. It takes longer to become problematic, not because it becomes calcified later, but because the normal valve can naturally just open wider than an abnormal bicuspid valve can. A bicuspid valve is already a little narrowed, and then that senile calcification just becomes symptomatic about 20 years sooner than it was if the valve were normal. So if you have a patient over 60 that develops aortic stenosis, think about senile calcification or degenerative calcification. A third cause of aortic stenosis is chronic rheumatic heart disease. Rheumatic heart disease can cause lots of different murmurs, especially mitral valve lesions. But rheumatic fever can damage the aortic valve as well, and that can lead to aortic stenosis. Another cause of aortic stenosis is you can have a congenital unicuspid aortic valve, just one leaflet. It's much less common than any of the other causes we've just mentioned. And then a fifth cause would be syphilis, because again, tertiary syphilis can affect the aortic root and the aortic valve, just like we saw with aortic regurgitation. So again, the 5 most common causes of aortic stenosis are a congenital bicuspid valve, senile or degenerative calcification, chronic rheumatic valvular disease. So those are the big 3. And then number 4 is unicuspid valve. Number 5 is syphilis, which is very, very rare. Next, let's talk about mitral regurgitation, which is another common systolic murmur. This is a systolic murmur that does begin immediately following S1 with no gap. So what causes the S1 heart sound again? Closure of the mitral and tricuspid valves. So during systole, the mitral valve should be closed and there shouldn't be any blood flow across it. But if the valve doesn't close completely, as the left ventricle contracts and pressure rises, blood is forced back across the mitral valve into the left atrium. So blood regurgitates back across the valve. So this murmur starts immediately after S1, even during isovolumetric contraction, and it continues all the way to S2. So we say that mitral regurg is a holosystolic murmur. It occurs throughout systole. Mitral regurgitation is sometimes described as a high-pitched blowing murmur. That's not nearly as helpful for your exam as the fact that it's a holosystolic murmur. And where do you expect the murmur to be loudest? In the mitral area, which is the 5th intercostal space in the midclavicular line. We sometimes call this the apex of the heart. It's where the pointy end of the heart is located. The opposite end, superior and medial, is sometimes called the base of the heart. It's almost like the heart's a pyramid with a wide base up top and the point of the pyramid down here. Another good clue is that mitral regurg murmurs can radiate to the left axilla. So if you put your stethoscope in the axilla, you might hear the murmur up there too. And we also said that mitral murmurs are better heard when you put the patient in the left lateral decubitus position, lying down on their left side. Mitral regurg is enhanced by maneuvers that increase total peripheral resistance, or afterload. So hand grip will do this, and so will squatting. When you have the patient perform a hand grip or a squat, it compresses all the arteries, and that increases afterload. With increased afterload, there's more pressure for the left ventricle to work against, so it's harder to eject the blood. So if there's more pressure in the left ventricle, and more blood in the left ventricle, more blood is going to regurgitate back across the mitral valve, and that regurg murmur will be louder. Now, what are the causes of mitral regurgitation? Well, by far the most common cause is rheumatic heart disease. The valve that's most commonly affected by rheumatic fever is the mitral valve. Endocarditis can also damage the valve and cause some mitral regurgitation. Mitral regurg can be due to ischemic heart disease or left ventricular dilation. If the heart dilates, you can imagine how that might cause some separation between the valve leaflets so that they don't close properly, and that allows blood to leak back through. And then mitral regurg can also be associated with mitral valve prolapse. Now, be aware that mitral prolapse and mitral regurg can occur together, but they don't have to. You can have prolapse without regurgitation. You can also have regurgitation without prolapse. Let's talk about mitral valve prolapse, which is relatively common, but it usually isn't problematic unless there's also some mitral regurgitation associated with it. So what is mitral valve prolapse? Well, you can think of mitral valve prolapse as being a mitral valve with very large, floppy valve leaflets, almost like there's redundant tissue, so that the valve leaflets billow out like a parachute. During systole, the mitral valve is closed, but it's prolapsing back into the left atrium, expanding, 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 and then when the chordae tendineae reach their endpoint, they sort of catch abruptly, and you can hear this mid-systolic click. And then after the click, you may hear a systolic crescendo murmur that increases in intensity as you approach S2. If you have the patient Valsalva, that makes the mid-systolic click happen earlier, and it makes the murmur start slightly earlier. But like most murmurs, the murmur gets slightly softer with Valsalva. So it starts earlier, but it's softer. Let's talk about tricuspid regurgitation. The murmur of tricuspid regurg is very similar to the murmur of mitral regurg because the tricuspid valve is the right-sided equivalent of the mitral valve. So like mitral regurg, tricuspid regurg is a holosystolic murmur, and it's heard loudest in the tricuspid area, in the left lower sternal border, in the fourth or fifth interspace. So it's very important to listen in different areas and decide where the murmur is loudest. The other important distinction is that the murmur of tricuspid regurg is louder with inspiration because of increased right atrial return. Remember, if you hear a murmur that gets louder with inspiration, it's more likely to be a right-sided heart murmur, like a tricuspid murmur. If your murmur gets louder with expiration, it's more likely to be a left-sided murmur, like a mitral murmur. So what causes tricuspid regurgitation? Again, rheumatic heart disease and endocarditis. And what type of patients most likely to have endocarditis of the tricuspid valve? IV drug users. They're injecting drugs, they're contaminating their veins with skin flora, and the bacteria kind of travel to the right side of the heart first. So IV drug users are at increased risk of tricuspid endocarditis, which can cause valve damage and tricuspid regurg. Let's talk about the murmur you hear with a ventricular septal defect, or VSD. Now, this is another type of non-valvular heart murmur. A VSD is a hole in the interventricular septum that allows blood to pass from one side to the other. So what does this murmur sound like? Again, this is a holosystolic murmur, similar to mitral regurg or tricuspid regurg. And it's heard best along the left sternal border, kind of in the tricuspid area. So it could be very difficult to tell a VSD from tricuspid regurg. That's where the clinical scenario comes in. If you see a newborn with this murmur, think about a VSD. If you see an IV drug abuser with this murmur, think about tricuspid regurgitation secondary to endocarditis. To wrap up heart murmurs, I want to do a quick audio quiz. I'm going to give you a short scenario and play you a murmur, and I want you to give me the correct diagnosis. Now, we're going to go through 4 cases, and then I'll give you the answers. Ready? The first one is a 68-year-old woman with a history of rheumatic heart disease and this murmur, which is heard loudest at the apex of the heart. Next one. A tall, thin, 42-year-old man with long extremities and fingers. His blood pressure is 138/56. His head bobs rhythmically when he's sitting still, and you hear this murmur, which is loudest at the left lower sternal border. Next one. A 72-year-old man comes to the ER for syncope, and on exam you hear this murmur at the right upper sternum in the second intercostal space. And the last one, a 49-year-old woman with palpitations and chest pain, and when you roll the patient on her left side and you have her hold her breath with expiration, you hear this murmur at the fifth intercostal space in the midclavicular line. Ready for the answers? The first one was a woman with rheumatic heart disease and a holosystolic murmur in the mitral position. That's mitral regurgitation. The second one was a tall, thin man with long extremities, which means he either plays center in the NBA or perhaps he has Marfan syndrome. Then he has a wide pulse pressure and that head bobbing and an early diastolic decrescendo murmur along the left sternal border. So this is aortic regurgitation. Remember, patients with Marfan syndrome tend to have dilation of the aortic root, which pulls those aortic valve leaflets apart, and that can cause aortic regurg. The third one was an older man with syncope and a diamond-shaped systolic murmur at the aortic position. That's aortic stenosis. And the last one was a woman with a rumbling, late diastolic crescendo murmur, heard best on expiration, which makes you think mitral, and it's heard best in the left lateral decubitus position, which also makes you think mitral. So this is mitral stenosis. These are exactly the kinds of presentations you can expect to see on step 1, so be able to correctly diagnose these valve lesions. You've seen the images in the study guide, and we've also included a composite image showing all the major murmurs together, which you can download below. Now, the big table in the end of session quiz is a review of all the murmurs we've been discussing, both systolic murmurs and diastolic murmurs. So I want you to work through the quiz, and then we'll go over the answers. First question, which heart murmur is associated with weak pulses? That's aortic stenosis. Sometimes this finding is called pulsus parvus et tardus, which is Latin for weak and delayed pulses. And then for the enormous table, what pathology is associated with each of the following murmurs? A crescendo, decrescendo systolic murmur heard best in the second to third right interspace close to the sternum. That's aortic stenosis. early diastolic decrescendo murmur, heard best along the left sternal border with blood pressure 160/55, is most likely aortic regurgitation. There's that wide pulse pressure again. The late diastolic decrescendo murmur, heard best along the lower left side of the sternum, would be tricuspid stenosis. Holosystolic murmur, best heard at the apex and often radiates to the left axilla, is mitral regurgitation. Late systolic murmur, usually preceded by a mid-systolic click, is mitral valve prolapse. The crescendo-decrescendo systolic murmur, heard best at the second or third left interspace close to the sternum, would be pulmonic stenosis. So it's similar to aortic stenosis, but the location is different. Holosystolic murmur, best heard along the left lower sternal border. This could be either tricuspid regurg or a VSD. You really need the clinical scenario to make a more accurate diagnosis. A rumbling late diastolic murmur with an opening snap, heard loudest in the fifth interspace in the midclavicular line, is mitral stenosis. A continuous machine-like murmur occurring both in systole and diastole is a patent ductus arteriosus. So that's it for heart murmurs. I'll see you next time.
Hey girl! Whoa, I seriously need to know when you're going to let me borrow that top! Anyway, so during rounds today, I was presenting this patient with syncope from aortic stenosis, and Dr. Wilkerson was all like, describe his murmur. So I was like, it was a harsh, high-pitched grade 2/6 crescendo-decrescendo systolic ejection murmur radiating to the carotids. And he was all like, did he have strong pulses? You know, trying to trick me. And I was like, cha, as if. The pulses were weak and delayed, you know, classic pulsus parvis etardis, dude. My physical exam skills are like seriously legit. So we sent his butt into surgery. The patient, not Dr. Wilkerson. Okay, so when can I borrow that top? Seriously.
Let's get started with this warm-up review. First question. A gardener has shortness of breath, salivation, meiosis, and diarrhea. What is the most likely diagnosis and what is the underlying mechanism? So this would be organophosphate poisoning from insecticides. What's the mechanism of action? This is one of those two-step questions. You need to know what caused the clinical presentation, and then you need to know what the mechanism of action of the substance is that caused it. Organophosphates are inhibitors of acetylcholinesterase. Organophosphates inhibit cholinesterase, which causes excess cholinergic stimulation of the muscarinic receptors. Next question. What is the mechanism of action of N-acetylcysteine when given as an antidote for acetaminophen or Tylenol overdose? So the answer here is that N-acetylcysteine regenerates glutathione. And next question. What is the equation for half-life? So you just derived this from your equation for clearance. Clearance equals 0.7 times the volume of distribution divided by the half-life. Then you do some algebra and you get half-life equals 0.7 times the volume of distribution divided by the clearance. All right, that's it for this warm-up review. Let's move on to the lecture.
Hello everyone and welcome to our Step 1 video on electrophysiology. This subject always reminds me of my first day of surgery as a third-year medical student. I had this patient that was suffering from a terrible wound dehiscence in her belly. She had this kind of big abdominal wound that kind of broke open after the surgery, and it was all juicy and smelly. It was gross. So she was in the ICU, and anytime a nurse or a doctor would comment on kind of how she was doing, maybe she was a little tachycardic, she'd start screaming, "Oh my God, I'm tachycardic! Somebody save me!" She would also sing Beach Boy songs. It was hilarious. So that was my first exposure to ICU psychosis. She was kind of off her nut. And then one day she looked at me and she said, "You have perfect hair. May I touch it?" And I said, "No, crazy ICU lady, you can't touch my hair." But it was at that moment that I realized she wasn't psychotic at all. She just really liked hair. All right, so we're moving on this lecture, and this lecture is going to deal with electrophysiology. Now, specifically, we'll be looking at myocytes and how different types of myocytes create different action potentials. Now, first we'll cover ventricular action potentials, and then we'll cover the pacemaker cells and their action potentials as well. So this can be a bit intimidating at first because we're dealing with potassium and calcium and membrane potentials, but all that'll be pretty easy by the end of this video. All right, so let's talk about some heart physiology. So in order for the heart to pump, there needs to be an organized and well-timed electrical signal that travels through the heart. And along with that signal, you need to have muscle cells that can contract repeatedly. Now, normally the sinoatrial node, the SA node, is the pacemaker because it exhibits something called automaticity. And we'll go over that in just a minute. Therefore, it undergoes regular depolarizations and it's going to create action potentials. And before we get too far down the rabbit hole, what is an action potential? Well, an action potential is a short-lasting event where the electrical membrane potential of a cell rapidly rises and then falls. So this electrical signal then propagates down the conduction pathway in the atria until it reaches the AV node. And from there, the signal is propagated to the distal end of the ventricles, and then the rest of the ventricular tissue is signaled. So what is the result of all this? Well, all this is designed to allow the atria to contract before the ventricles. So the electrical signal from the SA node moves through the atria, causing that atrial contraction. And there's enough delay in that signal that blood has enough time to move from the atria to the ventricle, and then finally that electrical signal produces a nice ventricular contraction, and all that blood that was delivered by the atria is then pumped either to the body or to the lungs. So now we need to look more closely at the actual myocytes and how these cells are able to either propagate or create action potentials. All right, so let's talk about ventricular action potentials. So I think it's a little confusing to try to memorize all the different types of action potentials. There's quite a few of them. But if you look at action potentials for the atria, for the ventricles, for the bundle of His, they all look pretty similar. So I group all of these together and just covered a typical, what we call a myocyte action potential. Now the SA node and the AV nodes, they're similar as well. So we'll group those together and that'll be our second category. But first, let's master the good old-fashioned regular myocyte action potential. So there are 4 phases to the action potential of a myocyte. Now the key to understanding the action potential is knowing what the membrane of the myocyte is permeable at any given time. Now, if the membrane is permeable to potassium and nothing else, then the membrane potential will want to stay somewhere between about -75 and -95 millivolts. Potassium tends to leave the inside of a cell through potassium channels, and this causes a very negative electrochemical gradient. Now, if the cell is permeable to only sodium, then the membrane potential will want to jump up to about +50 millivolts. Sodium tends to enter cells, and that's why we see a positive gradient. What about calcium? Calcium permeability will also want to keep the membrane potential positive, and it's at about 130. So again, the key to understanding why an action potential occurs is based on what the cell is permeable to. So to recap, potassium about -75 to -95, sodium is +50, calcium is about a +130, but memorizing those in particular numbers, not that important, but remember which ion is causing a positive and which is causing a negative potential. All right, so let's look at this picture. So now I like to start looking at phase 4 first. And I know that seems a little bit out of order, but phase 4 is considered the resting potential. So to me, this is the baseline status of the ventricular myocyte. And now it's at about -75, maybe -85 millivolts, and nothing interesting is happening. It's pretty flat. So what would you think the membrane is permeable to at this phase? Well, it's obviously potassium. So potassium can move back and forth through those potassium channels, mostly out, and the membrane is low at about that -75. Now move to the left side of the picture. So we're kind of starting over here. And here you see a vertical line that is referred to as phase 0. So you can imagine a cell hanging out in phase 4, the resting potential, and then this phase 0 occurs rather abruptly. So what's changed? Well, at phase 0, the voltage-gated sodium channels open, and thus it's going to increase the sodium permeability. Now it's going to drive up and depolarize the cell up towards that +55 direction that we talked about before. Now you notice that we don't get all the way up to +55 because there's still potassium permeability going on, and we're starting from such a negative resting potential. So connect in your mind, phase 0 equals increasing sodium permeability. Phase 1, you go back down a little bit in our gradient here. So this is what we call the initial repolarization. Here we see inactivation of those sodium channels. So the same sodium channels that brought that potential up and depolarized the cell is now, those are all closing, and the potential starts to come back down. And the other thing that's happening is the voltage-gated potassium channels are now beginning to open as well. So less permeability to sodium is going to prevent it from staying high. Increased permeability to potassium is going to start causing it to go back down, and you have that initial repolarization. Next is phase 2. So what's happening at phase 2? Well, this is referred to as the plateau phase. So the potential goes up just a little bit, or maybe just kind of flattens out for a bit. Here you have voltage-gated calcium channels opening. And again, this is going to drive the membrane potential in a more positive direction. It balances the potassium effect. And then this is what triggers calcium release from the sarcoplasmic reticulum and then myocyte contraction. So it's phase 2 that actually causes the myocyte to contract. Now let's move on to phase 3. Phase 3 is rapid repolarization. So what would you think is happening here? Well, you have more permeability to potassium again, and you also start to close all those calcium channels that we saw in the previous phase. Now the same calcium channels that were maintaining the plateau in phase 2 are now going out of service here. They're starting to close. And so the potassium is becoming more and more relevant. It's decreasing that slope rather dramatically, and then we end up back at the resting potential in phase 4, and then the pattern just begins all over again. Now, the other thing that you should know is that between phase 0 and towards the end of phase 3, this is what we call the effective refractory period. And during your effective refractory period, you cannot elicit another phase 0 depolarization. And this is a very critical element, a very critical piece of the puzzle, because something that will increase the effective refractory period will make it so that you can't depolarize very quickly. You can't go through another phase 0 quickly, and that's going to slow the heart down. So if you want to slow the heart down with an antiarrhythmic, you increase your effective refractory period. So when we go through the antiarrhythmic drugs later, then you'll already know why these medicines are working. Okay, so let's go to the pacemaker action potential. So not everything in your heart is just a mindless muscle cell. You have pacemaker cells like the SA node and the AV node. So what's the difference between a pacemaker action potential and a ventricular action potential? Well, if you look at their graphs, you notice that there's no phase 1 or phase 2 with the pacemaker cells. So no phase 1, no phase 2. So what's happening here? This is kind of weird. Well, let's start with phase 4 again, which is again your quote-unquote resting membrane potential. But it's not really resting, is it? It appears to have a slope. And phase 4 is down here somewhere between, again, minus 60, maybe minus 80. It's not that important to know the exact number. Again, freely permeable to what, again? It's going to be potassium. Now, potassium is just freely leaving that cell, and the gradient is, again, pretty negative. But again, you should notice that there's a gradual increase in the slope during phase 4. So what is causing this gradual increase in phase 4? Well, the membrane potential is spontaneously depolarizing as sodium conductance increases. So you have sodium channels that are gradually opening one by one and increasing the membrane potential of those SA and AV nodes. And then a threshold is reached. And when that particular threshold is reached, that causes the opening of voltage-gated calcium channels. And when that occurs, we call it, again, the phase 0. So your phase 0 of your pacemaker cells is not due to sodium, like we saw with our regular myocytes. Phase 0 here is due to calcium influx. So let me repeat that. Phase 0 in a pacemaker cell is due to calcium influx. Again, what caused phase 0 in that regular myocyte? It was sodium. But now in the pacemaker cells, it's going to be calcium. That's going to cause the dramatic depolarization. Now, what was calcium doing in that regular myocyte? Well, remember, it was causing that plateau phase in phase 2. But you'll notice that in the pacemaker cell, we don't even have a phase 2 or a plateau. So when we start talking about antiarrhythmics again, what might work on a pacemaker cell? Which do you think would inhibit that phase 0 again? Well, it's going to be the calcium channel blockers, right? So you need to know what ion contributes to phase 0, and that calcium channel blocker would inhibit that step. Also, we're moving on. There's no phase 2, but we still have a phase 3, which is the inactivation of the calcium channels, which will allow the gradient to drop again. And we also see in phase 3 an increase in potassium permeability again, which is again going to eventually lead us back down to our phase 4 baseline, and we start the entire process over again. So fewer steps in this pacemaker look at here. So to wrap this section up, the big differences here is that our phase 4 is not a resting potential. With a gradual increase in sodium permeability, the membrane potential is always increasing. This is what leads to that automaticity of the SA node and the AV node. And then it's calcium influx that leads to the big depolarization. All right, that brings us to the end of the video part. It's time for that end of session quiz. Try to answer all those questions on your own, and then we'll go through them together. First question, Diagram the phases of a myocardial action potential and describe which ion channels are responsible for each phase. So we're going to basically do this all over again to really get it into your brains. So first we have phase 0. What was that? Rapid depolarization, which is due to the opening of sodium channels. And then the phase 1 is early repolarization, where these sodium channels are going to close and the voltage-gated potassium channels begin to open. And then you have phase 2, which is that plateau phase. What was that due to? Voltage-gated calcium channels. Phase 3 is the repolarization due to opening of slow potassium channels. And then phase 4 is your baseline membrane potential, which is mainly due to just potassium permeability. Next, describe the flow of ions during a pacemaker action potential. Let's go through it again. So let's start at 4 this time. Phase 4, which is your baseline membrane potential. And in your pacemaker cells, there's a slow increase in your sodium conductance, which causes that slow increase in the slope of phase 4. And then you reach a threshold and you depolarize, which is that phase 0, and its influx of calcium, which is causing that depolarization. There's no plateau. And then phase 3 is the repolarization back down to baseline, which is due to potassium permeability. All right, next question. What physiology accounts for the automaticity of the AV and the SA nodes? You should know by now, we've talked about it a bunch. It's primarily that phase 4 gradual sodium conductance, the fact that during phase 4 that membrane becomes more and more slowly permeable to sodium. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.
Let's get started with Cardiovascular 11. First question, what are the 4 important pharmacokinetic equations? So the first one is volume of distribution equals the amount of drug given in IV form divided by the concentration of that drug in plasma, or volume of distribution equals D over C. The second equation is for clearance. Clearance equals 0.7 times the volume of distribution divided by the half-life. The third equation was for the loading dose. So loading dose is equal to the concentration at steady state, or the desired plasma concentration, times the volume of distribution. And the last one is maintenance dose equals the concentration at steady state times clearance. All right, time for the lecture.
Welcome to our Step 1 video on antiarrhythmics. Please don't get this confused with the 1980s band, the Eurythmics. We will not be finding out what dreams are made of. Neither will we travel the world or the 7 seas. Everyone is looking for something, and yes, some of them will want to use you, and some of them will want to get used by you. But really, guys, you need to hold your head up. Keep that head up. And now, we're moving on. All right, so in another video, we talked about the electrophysiology of the heart, and we looked at those fantastic action potentials of the myocytes and the pacemaker cells. So in this lecture, we're going to take that knowledge and then start talking about the antiarrhythmic medications. Now, some of you might be saying, but wait, Dr. Lewis, shouldn't we talk about arrhythmias before we talk about antiarrhythmic drugs? And then I would just ignore you and keep moving on. Just kidding. Now, I like to teach it in this order because we just talked about how those ion channels are critical to the action potentials in the heart. These drugs work on those channels, so it makes a lot more sense to cover this now while it's fresh in your mind. Now, we will discuss which arrhythmias these will treat, but don't panic, we'll cover those in detail in other lectures. So, there are 4 different classes of antiarrhythmics, and there are several mnemonics. Now, one mnemonic is no bad boy keeps clean. So, the no is for sodium channel blockers, which is class 1. Bad boy is for class 2, those beta blockers. Keeps is, the K there is for potassium, so these are your potassium channel blockers, the class 3s. And then the clean is for calcium channel blockers, your class 4 antiarrhythmics. Now another mnemonic that we've had several students write in about is some block potassium channels. That one is actually a bit more specific. I kind of like this one. Some is for sodium, block is for beta blockers, potassium is for potassium, and then the channels is going to be for calcium channel blockers. So use whichever one is easiest for you to remember. So let's go through these by class. So first we have the sodium channel blockers. So all class 1 drugs are going to decrease the slope of phase 0. And by decreasing the slope of phase 0, you are elongating the effective refractory period. Now what happened at phase 0 in the myocyte? Well, in myocytes, phase 0 was when sodium channels opened, which caused that depolarization. Okay, so that's how these sodium channel blockers work. Now the different classes of these sodium channel blockers, class 1A, 1B, 1C, have different effects on phase 3. I don't really want you to worry too much about the phase 3 effect in these drugs. The main effect, again, is that these are sodium channel blockers and they're working on 0 phase primarily. All right, so let's talk about your different classes of those sodium channel blockers and where we might use them. So first we have quinidine and procainamide, and also disopyramide as well. Those are the class 1A. Lidocaine, mexiletine, and toconide, those are class 1B. And then flecainide and propafenone, those are 1C. Now, it is worthwhile to know which of these drugs is going to fall into those different categories, and there are a few mnemonics, again, that can help you with this. So 1A is the double quarter pounders. Class 1B is going to be the mayo, lettuce, and tomato, so that's the inside of the burger. And then class 1C is fries, please, so that's the side. So to help you remember how to divide these up, remember the burger, the insides of the burger, and then a side. But use whatever mnemonic works for you. So let's go down the list here. Class 1A, we're going to talk about a few of these drugs in particular. So class 1A, remember it was procainamide, quinidine, and disopyramide. So these will increase action potential duration, effective refractory period, and that QT interval. Now the two things I want you to know about procainamide is that it's used for Wolff-Parkinson-White. And Wolff-Parkinson-White is pretty much the only time you're ever going to see procainamide being used. And then the number 2 thing about procainamide is that it can cause reversible SLE-like syndrome, so drug-induced lupus. Now there's a mnemonic, SHIP, S-H-I-P-P, for drug-induced lupus. Well, one of the P's was for procainamide. So procainamide can cause that drug-induced lupus. Now phenytoin was the other P in that mnemonic. And now technically it is a sodium channel blocker, but it is not an antiarrhythmic, so we're not actually going to talk about it here. Next we have quinidine. Don't confuse quinidine with quinine. Remember that quinine is an anti-malarial drug. Quinidine is the antiarrhythmic. Now quinidine can cause synconism. That's the important thing to remember on this one. What is synconism? So it's headache, dizziness, and tinnitus. Quinidine can also cause thrombocytopenia, and it can also cause torsades de pointe due to increased QT interval. And most all of these antiarrhythmics can cause arrhythmias, which is a bit ironic. So you have to be very judicious with your use of any antiarrhythmic. Now you may notice that some books include amiodarone in the 1A sodium channel blocker group. Amiodarone does act on sodium channels, but it's probably better recognized as a potassium channel blocker. Therefore, we'll save our discussion on amiodarone until we get to that section. Let's move on to class 1B. 1B probably a little more often used. This includes lidocaine, toconide, and mexiletine. That's the mayo, lettuce, and tomato. Now, lidocaine is probably the most commonly used out of these. It's useful for acute ventricular tachyarrhythmias. It's beneficial because it slows the heart rate down pretty dramatically. Lidocaine also used in digitalis-induced arrhythmias. So lidocaine is used for those tachyarrhythmias, especially after an MI. So a patient has an MI, develops a tachyarrhythmia, they're not doing so well, like ventricular tachycardia, you might consider using lidocaine for that acute situation. The toxicity of these drugs can be worse in the setting of hyperkalemia, so remember that as well. And finally, we have the 1C class. Not as commonly used, though I do see flecainide being used more and more nowadays. Propafenone I don't see being used much at all. Fries, please, is the mnemonic here to remember. Now, they're used in ventricular tachycardia progressing to VFib, so these patients are not doing well. They are the last resort in ventricular arrhythmias in general. Class 1C drugs are pro-arrhythmic, as we've already said before about the other ones, especially in the post-MI state. And again, the toxicity is going to be worse in the setting of hyperkalemia again as well. Now, there is one more drug I want you to know about. It doesn't fit in these categories very nicely at all. The drug is ivabradine. Now, it inhibits the funny sodium channel. So funny sodium channels are named this because they are permeable to both sodium and potassium and are classified as 1F channels. Now, when you block these channels, then we see a prolongation of phase 4, which will decrease SA node firing. Now, ivabradine is used in chronic stable angina, especially in patients that maybe don't tolerate beta blockers, and they can also be used in patients with chronic heart failure. Adverse side effects are kind of interesting, include hypertension, bradycardia. That's not very interesting. But what is interesting is what's called the luminous phenomena. So that's where a patient kind of describes their vision being overly bright. So I think that's interesting. Next class, beta blockers. These are the bad boys. So the beta blockers like to end in olol, like propranolol, esmolol, metoprolol, atenolol, timolol. There's a lot of alls out there. So the mechanism is that they decrease cyclic AMP, and they're going to decrease calcium currents as well. So they increase the PR interval and suppress abnormal pacemakers, especially the AV node. So how do they work? Well, they suppress abnormal pacemakers by decreasing the slope of phase 4. So remember phase 4 in beta blockers. Decreasing the slope of phase 4 is going to slow down the heart rate generally. So remember that what we saw in our phase 4 of the pacemaker cell, there's a gradual increase in charge caused by the gradual opening of sodium channels that ultimately lead to a depolarization. Beta blockers are going to flatten out that phase 4 some, which prolongs the frequency of those depolarizations. Now, the clinical uses of beta blockers include things like coronary artery disease, hypertension, SVT, slowing ventricular rate down during AFib as well if you're going to do a rate control, and also A-flutter as well. You might use beta blockers. Beta blockers do have some adverse reactions that are high yield. They include exacerbations of asthma, also bradycardia. AV block can get worse with these, CHF exacerbation. Also remember that beta blockers can mask the effects of hypoglycemia, so be careful with your diabetic patients. Now, the treatment for beta blocker overdose is glucagon. Moving on to our potassium channel blockers. These are the class 3 drugs. Potassium channel blockers are working at phase 3, so that's easy, class 3, phase 3. It slows down the release of potassium, thereby elongating the effective refractory period. These drugs increase the action potential duration and the QT interval. These include things like sotalol. Don't be confused there. Sotalol kind of looks like a beta blocker, but it's actually not. Ibutylide, beryllium, dofetilide, and amiodarone. Those are the potassium blockers here. Now, the two most commonly used are going to be sotalol and amiodarone. Both of these are commonly used for rhythm control in patients with atrial fibrillation. Amiodarone also used for Wolff-Parkinson-White syndrome. So we've mentioned two drugs now that can be used for WPW, procainamide and amiodarone. Probably more important for your test is the toxicity of these drugs, specifically amiodarone. Torsades de pointe is an important adverse reaction to remember with all the potassium channel blockers, but I do want to spend a little extra time with amiodarone. Amiodarone can cause pulmonary fibrosis, hepatotoxicity, hypo or hyperthyroidism. So remember to check your PFTs, your LFTs, and your TFTs when using amiodarone. Now, why does amiodarone cause hypo or hyperthyroidism? Amiodarone is actually 40% iodine by weight, and the only tissue in your body that uses iodine is your thyroid. Now, amiodarone can cause a lot of other things: corneal deposits, skin deposits resulting in photodermatitis. Remember your mnemonic SAT for photo. The SAT stood for sulfonamides, amiodarone, and tetracycline, which can cause photosensitivity. Neurologic effects as well: constipation, cardiovascular effects like bradycardia, heart block, and heart failure. So it slows down the heart, which is why it works for rhythm control and atrial fibrillation. So to reiterate, your class 3 drugs, your potassium channel blockers, are working at phase 3. Easy to remember, phase 3, class 3. Phase 3 is the myocyte phase where potassium is leaving the cells. Now, these drugs slow down the release of potassium, thereby elongating that effective refractory period. So good memory tools there. Finally, let's move on to our calcium channel blockers. The calcium channel blockers include verapamil, diltiazem. Calcium channel blockers do come in two main categories. There's the dihydropyridine and the non-dihydropyridine calcium channel blockers. The non-dihydropyridine calcium channel blockers work primarily at the heart. And then the dihydropyridine, they do not work on the heart very much. They're more for blood pressure. So you do not see calcium channel blockers like nifedipine and amlodipine here, because nifedipine is that dihydropyridine. So how do the non-dihydropyridine drugs work? Well, calcium channel blockers decrease the slope of phase 0 of the pacemaker cells. So that's going to elongate that effective refractory period again. Now remember that calcium was the cause of the depolarization in the pacemaker action potential. Therefore, there is a decrease in conduction velocity of the AV node specifically when you give a calcium channel blocker to a patient. Toxicity, well, this can cause things like constipation, they can cause flushing, edema, that's a big one, lower extremity edema, cardiovascular effects like heart failure, AV block, sinus node depression, and even torsades de pointe again. So somebody that's in heart failure exacerbation, you would not want to use a lot of drugs like this because it could worsen that CHF. And then you're going to want to use caution in combining your calcium channel blockers like verapamil and diltiazem with other antiarrhythmics, especially beta blockers. Combining those two classes together can cause a more substantial heart block. So I bet you remember everything that we just covered. Yeah, me neither. Let's hit a Lewis Notes. All right, guys, welcome to another Lewis Notes, and we're looking at the wonderful world of antiarrhythmics. It can be a little bit tricky to know where each one of these drugs fits into their class, so we're going to go through those again because the more you do this, the more it's likely to stay into your brain. So let's get going here. We're going to take all of our green drugs here. We're going to put them into classes. So the first one we have here is propafenone. Propafenone is one of our 1C sodium channel blockers. We're going to put that one right over there. Next, we have propranolol. So olol should immediately make you think of bad boys or beta blockers. So we're going to put that right there. Quinidine. So quinidine is going to be our quarter pounder. So remember, quarter is going to go into our class 1A sodium channel blockers. Lidocaine is one of our 1B. That's our lettuce. Diltiazem is a calcium channel blocker. So calcium channel blockers are class 4. Metoprolol is an olol again, so that should make you think of a beta blocker. Next we have sotalol. So should that go into the beta blockers? That one is tricky. This is actually an alol, so that's a good indication of where this should go, and it's going to go over here in our class 3, our potassium channel blockers. Disopyramide is the double in double quarter pounder, so we're going to put that over here in our class 1A. Mexilotine is our mayo in the inside of our burger, so that's going to be class 1B. Amiodarone, so it has actually a lot of actions. It's probably primarily recognized as a potassium channel blocker. It does have some sodium channel blockade as well. Verapamil is another calcium channel blocker. That's going to go over in our 4. Procainamide is going to be the pounder in our double quarter pounder in our class 1A. Toconide is going to go over here. It's the tomato that's going to be over here in the class 1B again. And then our last one, flecainide. So flecainide is another class 1C drug. Now, one other thing I want to add on here is like where these drugs are acting when we're talking about the electrophysiology. So if we look at all of these class 1 drugs, these sodium channel blockers, remember they're working on phase 0. So phase 0, and that's going to be on the myocyte. So phase 1 on the myocyte is where those are going to act. If we look at our class 2 here, at class 2, we're looking at a phase 4. And it's prolonging that phase. In our class 3, we're looking at phase 3. That's where those are acting right here. Remember, class 3, phase 3. And then here again, with our class 4, we're working on phase 0 again. But it's not on the myocyte, it's on the pacemaker. So remember, it's on the pacemaker on our phase 4. That's a little bit different than our sodium channel blockers. All right, guys, so those are all the antiarrhythmics. I think if you know this stuff, you'll do well for your test. All right, so now let's move on to adenosine. So adenosine increases potassium leaving the cells, thereby hyperpolarizing the cell. Additionally, it decreases the permeability of the cell to calcium. So let's think about that for a second. If more potassium is leaving the cells, that's causing the cell's resting membrane potential to stay at the cell resting membrane potential. It's not moving. And if calcium can't trigger a depolarization of your SA and AV nodes, you're not going to depolarize. So this is exactly what happens with adenosine. You're causing flatlining. You cannot depolarize. So you push adenosine into somebody, you're going to stop that heart. So what can you do with this drug? Well, we use it for supraventricular tachycardias. So it can help both diagnose and then also treat SVT. Now, sometimes you see a tachycardia, it's really maybe not obvious that it's SVT. So by slowing down that rate, you can get a really good look at it and diagnose it. So we just said that adenosine will cause a flatline. Well, how's this better than tachycardia? The good news is that we've stopped your tachycardia. The bad news is that we've stopped your heart completely. You're welcome. Well, luckily adenosine is a very short-acting drug. It only lasts about 15 seconds. So a patient comes into the ER with tachycardia, maybe at 150, 160 beats per minute. You don't know what the rhythm is at this point, so you try a few things, maybe vagal maneuvers, carotid massage. If that doesn't work, then you might use adenosine. The patient is hooked up to the monitor. You should probably tell them that this is going to be uncomfortable, and don't forget to turn down the volume on the monitor. Patients tend to freak out a bit when they hear themselves flatline. So you push the adenosine, and basically the heart stops. So that kind of 5 to 10 second moment can seem like an eternity, just waiting for the heart to start back up. And when it does start back up, it's generally at a much slower rate, and then it gradually works itself back up to SVT in many cases. Now in some cases, that adenosine is going to actually stop that SVT altogether and you're done. But at the very least, you have this window of a much slower heart rate where you can get a good ECG strip and where you can then analyze and then determine what type of rhythm that you're dealing with in that situation. Now, toxicity for adenosine includes flushing, hypotension, and chest pain. Another sneaky test question is that adenosine is blocked by another completely unrelated drug. The effects are blocked by theophylline. So who uses theophylline? Well, patients with COPD, really bad asthma, might use theophylline. It's really like a third-line drug at this point where you don't use it very often. So that's about it for adenosine. Couple little final things here, potassium, magnesium. Potassium depresses ectopic pacemakers in hypokalemia, so that's where you can use that. It's also commonly used in digoxin toxicity. Magnesium is effective in torsades and digoxin toxicity as well. Potassium and magnesium, when deficient, are highly correlated with arrhythmias, especially in patients that are predisposed to arrhythmias. Maybe someone who's already just had a heart attack, so watch out for magnesium and potassium in that situation. So patient comes in having an MI, always make sure their potassium is above 4, their magnesium is above 2. Because when those drop below 4 and 2, they are more likely to have arrhythmias because the MI is setting them up for that arrhythmia. So you want to make sure you're always looking at those electrolytes and making sure they're optimized to avoid those arrhythmias. All right, that's it for the lecture part. It's time for that end of session quiz. Try to answer those questions on your own, and then we'll go through them together. First question, what is the mechanism of action of each class of antiarrhythmic? So the mnemonic here, no bad boy keeps clean, or maybe some block potassium channels. Choose which one you like. Class 1 are the sodium channel blockers. Class 2 are the beta blockers. Class 3 are the potassium channel blockers. Class 4 are the calcium channel blockers. Next, which antiarrhythmic has the side effect of synchronism? So remember, that's going to be quinidine. Next, what are the potential side effects of amiodarone use? So pulmonary fibrosis, hyper or hypothyroidism, hepatotoxicity, blue-gray skin discoloration, photodermatitis or photosensitivity. It can cause bradycardia, heart block, corneal deposits, neurological problems, and constipation. So a ton of stuff. Next, what is the mechanism of action of adenosine as an antiarrhythmic? So remember, adenosine increases the outward potassium current, causing hyperpolarization of cells and decreasing intracellular calcium, so it basically stops the heart. Next, to which class of antiarrhythmics do each of the following agents belong? So first we have sotalol. That can fool you. It's OLOL, but it's not a beta blocker. It's a potassium channel blocker, so it's classified as a class 3 antiarrhythmic. Propranolol is a beta blocker, so it's class 2. Beryllium is class 3. Quinidine is a class 1A. Verapamil is a calcium channel blocker, so it's class 4. Procainamide is a class 1A. Lidocaine class 1B. And diltiazem is another class 4. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.
Let's go over the warm-up review. First question, what's the mechanism of action of fomepizole? Fomepizole inhibits the enzyme alcohol dehydrogenase. Next, what effects will a non-competitive antagonist have on an enzyme's Vmax and Km? A competitive antagonist does not affect Vmax, which is the orange line here. The yellow line is the uninhibited enzyme. If you give enough substrate, you can still achieve that same maximum velocity and overcome the competitive inhibitor. The curve is shifted to the right, but the Vmax does not change. But this question is asking about a non-competitive inhibitor, which is the purple line. With a non-competitive inhibitor, you can't overcome the inhibition by giving more substrate. So eventually you saturate the available enzyme and you hit zero order velocity. What you'll find is that when you reach that plateau, the Vmax is lower. So to answer the question, with a non-competitive inhibitor, the Vmax is lower. So it's going to decrease Vmax, but it does not change Km. The last question, which G protein class does each of the following receptors stimulate? Alpha 1 is GQ, alpha 2 is GI, beta 1 is GS, beta 2 is GS, muscarinic M1 receptors is GQ, M2 receptors is GI, M3 receptors is GQ, and dopamine D2 receptor is GI. That wasn't so terrible, was it? Let's move on to the lecture.
Come one,
everyone, come out and see our video on ECGs. For one low price, it can all be yours. Guaranteed to raise your scores. We've got tracings, we've got leads. Count them all. 1, 2, 3. But that's not all. Call now and get AVL, RF. Act now. Avoid humiliation. You gotta know axis deviation, PR intervals, QR complexes, deflection, infarctions. Great for both sexes. We've got EKG paper. Who could want more? Multiply those tiny boxes by 0.04. Without this ECG video, your patients may die. 10% off for a limited time.
All right, guys, so today we're talking about ECGs, the electrocardiogram. So ECGs, or I'm an old person, I might slip and say EKGs on occasion. Basically, ECGs are measuring the electrical signals as that electrical signal is moving through the heart. And there's actually a direction to that signal. That signal starts out at that SA node and then travels down the AV node and then the bundle of His and then down into the ventricles. So you can imagine the overall direction of that electrical signal is actually just kind of down and to the left. And the ECG, with all of its leads, is trying to determine if that electrical signal is normal or abnormal. So there are multiple electrodes that we place all over the body, which will measure that electrical activity through the heart. Now, you will often hear the term lead used when talking about ECGs, and a lead can actually have two different meanings. Now, sometimes the actual electrical cable itself is referred to as a lead, but I don't really want you to use the term lead in this way. A lead, when we use it in referring to ECGs, is the tracing of the voltage differences between two of the electrodes, and this is what you'll see on the ECG paper. Now, for example, lead 1 is the voltage between the right arm electrode and the left arm electrode. Now, how many leads are on an ECG? Well, on a good ECG, you're going to find 12 leads. Now, what are the 12 leads on an ECG? Well, it's leads 1, 2, 3, and then you have AVL, AVR, and AVF, and then you have V1 through V6, so V1, V2, V2, V3, all the way up to V6, which are called the precordial leads. Now, the first thing to realize, again, is that each of these leads has a specific direction. So let's look at this diagram of these 6 limb leads. Now here we see in which direction each of these leads measures the electrical activity. So your AVR is measuring the signal in the direction of the center of your chest from your heart to your right arm, which is why it's called AVR. The R is for right. AVF is measuring from the heart down to your feet. AVL is measuring from your heart to the left side. Now 1 is measuring straight across from right to left. 2 is measuring from the right arm to the left leg, and then 3 is measuring from the left arm to the left leg. So as you can see, each of these have a very distinct direction. Now, if you combine all of these leads together, then you might see something like this. Lead 1 is at 0 degrees, 2 is at 60 degrees, AVF is at 90, 3 is at 120, AVR is at negative 150, and then AVL is at negative 30. Now, this is definitely something that you're going to want to memorize. Okay, so now that we've established that each lead has a direction, how does that help us? Well, as we said before, as your heart beats, it's producing an electrical signal. It starts off at the top of your heart at the SA node in the atria, then down to the AV node, and then through the interventricular septum, and then finally moves through the ventricles. Now, all of this is designed to produce a coordinated heart contraction. So there is a direction to this electrical signal, and a normal heart will have a net electrical signal that moves down into the left. But this net electrical signal will be interpreted differently depending on which lead you look at. Now, if the heart electrical signal is moving in the same direction of the lead, then you will see a positive deflection on the ECG. Now, what does a positive deflection look like? So a positive deflection means that you'll see more of the QRS above the line than below the line. Conversely, if the signal is moving away or in the opposite direction as the lead, then the ECG will show a negative deflection, meaning that you would see the QRS below the line. Now let's look at an example. What would a normal electrical signal look like on AVR? So AVR is measuring the signal from the center to the right side. Now if the normal net electrical signal of your heart is going down and to the left, then you're going to have a negative deflection of your QRS complex because it's going to end up being in the opposite direction of that vector of AVR. So a net electrical signal going in the opposite direction of what is being measured means your QRS complex is going where? Below the line. Now, AVF would be just the opposite. Since that electrical signal of the heart is moving generally towards the same direction as AVF, down, then you would see a positive deflection or a very tall QRS segment on that EKG. So AVR, AVL, AVF are called the unipolar leads. Now let's review the direction of the bipolar leads again. So your bipolar limb leads are 1, 2, and 3. Remember, limb lead 1 measures from the right arm to the left arm. Limb lead 2 measures from the right arm down to the foot. And then the limb lead 3 is measuring from the left arm down to the foot. And again, if we look at a normal ECG leads, 1 and 2 are usually going to have a positive deflection because they are measuring both left and down. Lead 3 can also be positive because it's pointing down, but on some patients this might be a bit more neutral. Now let's look at how to determine a normal or abnormal axis. This is how we're going to use all this information for some sort of practical purpose. So we're using our axis here, and the green section is the normal electrical axis. Now a normal axis is a net electrical signal somewhere between -30 and +90. Now as we said before, down and to the left. So let's go through a normal example here. So normally a person will have a positive deflection of your QRS on limb lead 1. Now there is more of that QRS complex above the line than there is below the line. Now that tells you that the net electrical signal is somewhere on that right-hand side of the axis, somewhere between -90 and +90 on the right-hand side in the same vector direction as that limb lead 1. We also generally see a positive QRS in a lead 2. So we can then say that the net electrical signal of the heart is somewhere between +150 and -30. Now, if you have a positive deflection of the QRS in lead 1 and a positive deflection in QRS in that limb lead 2, then you can actually combine those two images together, and that gives you the net electrical signal somewhere in the shaded region that is common to both of these two vectors. Now, why is that important? What does this axis tell us? Well, if the heart signal is not going down and to the left into that section there, then that indicates some level of pathology. And when we're looking at the axis and we see the signal moving away from down and the left, then we call it either a right axis deviation or a left axis deviation. Left axis deviation is generally between -30 degrees and -90 degrees. And then the right axis deviation is usually between +90 and +180. All right, so now there are some certain pathologies associated with left axis deviation and right axis deviation. Let's go through some of those. Let's say you had an ECG with a positive deflection of the QRS complex on AVL, which could be normal or maybe even abnormal as well. But there's also a positive deflection of the QRS complex in AVR. So this is going to be a left axis deviation because that common area is likely going to fall somewhere between -30 and -90 degrees. Now, what causes left axis deviation? Well, things like inferior wall myocardial infarctions, left anterior fascicular blocks, left ventricular hypertrophy, sometimes, not always, or maybe even a left bundle branch block. So if a patient comes into the ER with chest pain and you see an ECG with left axis deviation, what might that indicate? Well, that's pretty concerning for an inferior wall MI, so you're going to have to look further into that. So if you have a positive deflection of the QRS in limb lead 3 and AVR, that's likely going to be a right axis deviation. Now the common area is going to fall between +90 and +180. Now technically you could see a negative AVR with right axis deviation between maybe 90 and 120 degrees, but you're most likely going to see it positive when that deviation is greater than +120. Now, the right axis deviation can be caused by a lot of things as well. By right ventricular hypertrophy, acute right heart strains, like something that might happen like a massive PE might lead to that, a left posterior fascicular block, or a right bundle branch block. Now, having said all this, one very quick and easy trick to determine if the axis of the ECG is normal is actually just look at limb lead 1 and limb lead 2. And if the QRS is positive in both, then it's likely that the axis is going to be normal. So a positive deflection, limb lead 1 and 2 normal. But if you get a positive deflection in limb lead like AVR, it's almost always going to be abnormal because that vector is in the complete opposite direction of what is normal. So you can look at those 2 or even 3 and you'll get a good idea there. All right, let's see if we can hit this again in a different way in a Lewis Notes. Okay, so in this Lewis Notes, we're looking at our axis deviations. And instead of giving you a bunch of EKGs and asking you, well, is this left or right, we're going to go backwards. We're actually going to tell you that it's a left axis deviation or a right axis deviation. And then we're going to actually put in if we think there's going to be a positive or a negative deflection on the EKG. Now, for a cheater, I actually put the actually mean axis over here so we can actually practice and look at the 1, the 2, the 3, the AVF, the AVL, the AVR. All right, so first we have the left axis deviation. So we look at our left axis deviation area, and we're looking at this area over here. So this is the kind of the area that we're going to be looking at mostly for our left axis deviation. So keep that in mind when we're thinking about, is this going to be a positive or negative deflection? So first we have in our limb lead 1, what are we going to see in 1? Well, more than likely, if we're going to try to hit that area over there, we're going to see a positive deflection here. So we're going to see a big positive deflection, maybe nothing going on there. And I'm not going to make these really pretty EKGs just for speed's sake. And then if we look at 2, well in 2, it's likely going to have to be a negative deflection because you see it's basically in the opposite direction of 2. So we're going to see a pretty big dip right there, and it's going to go across. What about 3? Again, 3, it's basically going in the exact opposite direction. So you're going to see a really big dip of a negative deflection in 3. What about AVR? AVR maybe might be a little positive, but it's maybe a little neutral as well. So sometimes in AVR you'll see kind of this kind of medium looking one, but it's not going to be negative, that's for sure. And then in AVL is going to be about where we want it to be in the right direction. So that's going to definitely be a positive deflection on that one. And then in AVF, again, it's kind of going in the opposite direction. AVF is going down for the floor. That left axis deviation is pretty much at the top. So we're going to see another pretty big deep dip right there. All right, so let's move over to our right axis deviation. So if we're looking at the right axis deviation, we're looking like more in sort of this area over here. Somewhere over here is about where we want our right axis deviation. So that's where we're going to go from there. So in 1, what are we going to see here? Well, 1, it's basically going to be almost in the opposite direction, so we're definitely going to see a negative deflection here on 1. On 2, it could be a positive because you are seeing that over there, so you might see maybe a medium or kind of a neutral looking thing, but I think you're going to see more of a positive on this one. On 3, definitely you're going to see a positive because it is going in mostly the right direction from there in regards to that. AVR might be a little neutral. Again, remember we talked about AVR being a bit neutral in that last one, but in this one we're probably going to see a little bit of a back and forth here. AVL, big negative deflection here, so that's what you're going to see there. And then in AVF, we are going down in that right direction, so that's going to definitely see us with a positive deflection there. All right, so really not all that complicated, but if you really need to keep the big axis deviation chart in your mind on where 1, 2, 3, AVF, AVR, and AVR are going to be, and that way you won't get fooled. Okay, so when you're looking at an ECG, there are tiny little boxes all over the place, and for every 5 boxes, you're going to see one of these big bolded boxes. Now, each tiny little box is 1 millimeter, and each 1 millimeter segment is going to represent 0.04 seconds, so not much time. And then for every 5 boxes, you have that bolded box, and that's going to be 5 millimeters, and then you just multiply it out. It's 0.2 seconds, or 200 milliseconds. So let's look at a normal ECG here. What is the first bump in the tracing? Remember, that's going to be your P wave. And the P wave is going to represent atrial depolarization. Now the signal is starting in the SA node, and then it's going to travel through the atria and then get to the AV node. Now after the P wave, we get to the QRS complex. But before we talk about that, we need to talk about the PR interval. So what is the PR interval? Well, it measures from the beginning of the P wave to the beginning of the QRS segment. Now it's actually stopping at the Q, not at the R. That can be a little bit confusing, I know. Now the PR interval is a measurement of the conduction delay through the AV node. Now normally, the PR interval is less than 200 milliseconds. So if you see a PR interval that is longer than one giant bold box, then that is going to be a prolonged PR interval, which can then indicate maybe something like a heart block, and we're going to talk about that in detail later. Now the QRS complex is a ventricular depolarization, which is how long it takes for the signal to get from the top of the ventricle to the bottom. Now you'll notice that the amplitude of the QRS is much larger than the P wave, and that's because the ventricles have a much larger mass of muscle. Now normally your ventricles are depolarizing at the same time. The electrical signal goes through the Purkinje system and the bundle of His, and you have equal depolarization of both ventricles. Now the reason why the QRS complex is very narrow and less than 120 milliseconds is because you are depolarizing the ventricles again at the same time. So how many boxes is 120 milliseconds? Remember, that's just 3 small boxes. Your QRS complex should be within 3 small boxes. Well, let's just say that you don't go through that Purkinje system, the bundle of His, and you depolarize maybe the right ventricle first, and then finally it's going to depolarize the left ventricle next. And that's going to take a lot longer and will result in what we call a widened QRS complex. This could be a ventricular rhythm, meaning that the signal is not originating from the AV node, but rather somewhere else in the ventricle. Now, the normal, very fast signal through that heart starts again from that SA node. It's going to travel down the AV node, and then the signal speeds down the bundle of His and the Purkinje system. Now, if that signal starts or travels in a wrong direction, then you usually get an abnormal and probably a widened QRS. Now, the T wave is what's going to represent ventricular repolarization. So this is the recovery of the ventricle so that they can then be depolarized again. Now, the ST segment connects the QRS complex and the T wave. The ST segment represents the period when the ventricles are depolarized. And as many of you already know, when we talk about myocardial infarctions, we look in this area for any elevation or depression. We'll talk again about that later. Also, T-wave inversion may indicate a recent MI. And those T-waves, again, can also be affected by potassium levels. So if you see peaked T-waves, that might, again, indicate high potassium levels. And then again, flattened T-waves might indicate very low potassium. And then there's another wave called the U wave, and that's thought to be the repolarization of the papillary muscles or the Purkinje fibers. So these are often not seen and only sometimes appear after the T wave. Now, prominent U waves may be associated with hypokalemia or hypercalcemia, and then maybe even hyperthyroidism. Now, the speed of conduction goes very fast through the Purkinje system and a little bit slower through the atria, pretty slow through the ventricles, and very slow through the AV node. Now, the SA node is obviously your pacemaker, but what if your SA node is not functional? Then your AV node is going to end up taking control. If your SA and AV nodes aren't functional, then the bundle of His and the Purkinje system will potentially take control. And again, if the SA node and the AV node and the bundle of His and all those Purkinje systems are providing the electrical signal, then you're going to get this really nice narrow QRS. If all of these are non-functional and then the ventricles have to start doing this, then potentially you're going to get these really wide QRSs. It's going to be longer than that 120 milliseconds, longer than your 3 boxes. So that's a good thing to know, that where is the originating signal coming from. If it's from the top of the heart and if it's going through the regular conduction system, it's going to be really skinny QRS. But if it's coming from the bottom of the heart or from the ventricles or something else is going wrong, then you're going to get a really wide QRS. All right, it's time for that end of session quiz. Let's go through those answers together. First question, how does the cause of a narrow QRS complex differ from the cause of a wide QRS complex? So a narrow QRS complex indicates that a beat is conducted through the normal conduction pathway. So it's either a sinus beat or an ectopic atrial beat, or maybe even supraventricular tachycardia, or even a junctional rhythm. But if the QRS is narrow, you know that the depolarization is coming through the AV node and down the Purkinje system. Now, with a wide QRS complex, the depolarization is not being propagated normally by that conduction system. Either you have a beat originating in the ventricles themselves, like a PVC, or maybe a ventricular tachycardia, or maybe you have some conduction system disease like a bundle branch block, so it takes longer than normal for the ventricles to actually depolarize. Next question, what is the ECG axis given the QRS deflections in the following scenarios? So let's put on our thinking caps here. Positive in lead 1, positive in lead 2. That's easy. Remember, that was the trick. If those two are normal, normal axis. Positive in lead 1, negative in lead 3. That's probably going to be left axis deviation. Next, we have negative in lead 1, positive in lead 3. That's probably going to mean right axis deviation. And then we have positive in lead 1, negative in AVR. That's still going to be another normal axis. Next question, how does hyperkalemia affect the shape of T waves? So remember, T waves mirror the potassium level. So with high potassium, you get tall peaked T waves. With low potassium, you get flattening of the T waves, maybe also a U wave. Next question, what are the most common causes of left axis and right axis deviation? So remember, left axis deviation, you got to think about inferior wall myocardial infarction, left anterior fascicular block, left ventricular hypertrophy, and left bundle branch block. For right axis deviation, you got to think about right ventricular hypertrophy, acute right heart strain like a massive PE, left posterior fascicular block, and then maybe a right bundle branch block. All right, guys, that brings us to the end of session quiz and the end of the video. I hope you learned something. I'll see you next time.
Let's tackle the warm-up review. First question, which adult structures are derived from the third, fourth, and sixth aortic arches? So the third aortic arch gives rise to the common carotid artery and the proximal part of the internal carotid artery. The left fourth arch gives rise to the aortic arch in the adult, and the right fourth arch gives rise to the proximal part of the right subclavian artery. And then the sixth arch gives rise to the proximal part of the pulmonary arteries and the ductus arteriosus. And remember that the fifth aortic arch doesn't give rise to any adult structures. Next, what agents stimulate the release of norepinephrine from the presynaptic bouton? So the three different agents are amphetamine, ephedrine, and tyramine. And the last question, what agents potentiate the action of norepinephrine by inhibiting its reuptake into the presynaptic cell from the synaptic cleft? So we had cocaine, tricyclic antidepressants, and we also mentioned SNRIs. Now let's get started with the lecture.
Hello everyone and welcome to another Step 1 video. Today we'll be talking about beats, which gives me a great opportunity to show you all my free-form rap style. With me always is DJ Funky Travis.
I'm not a DJ, I'm the videographer. Are you sure you want to do this?
Shut up, Travis. Today you are DJ Funky, and yes, I want to do this. I've got sick rhymes and students will love them. Now, throw down a delicious beat, please. No, that's not funky enough. How am I supposed to get down to that? Nope, that's got no flow potential. Zero flow. Come on, man. Well, are you messing with me now? Do I need to take the funky out of your name, Travis? I will do it. Now, the next beat you drop better be so funkalicious that I want to eat it. All right. Winky Bach. Makes me think of Chewbacca. Okay, Travis, I think you're just not ready for this yet. You need to work on your treble and your faders and, I don't know. Sorry, students, no rapping today, I guess. All right, so let's move on to the ECG tracing. So this is a 3-star topic. Some of you might have as many as 2 or even 3 ECGs. Some, maybe not any ECGs at all. It actually varies from year to year and student to student. So it is variable how many you're going to see on your test, but you do need to be able to recognize the different rhythms. So first we're going to start with atrial fibrillation, AFib. So AFib is the most common cardiac arrhythmia, and AFib is described as irregularly irregular. The RR intervals follow no repetitive pattern. Now the ECG will show a great deal of randomness to the QRSs. The rate can be normal, but it's often increased. Now, another very important aspect of AFib is that there are no discrete P waves, and I'll explain in a minute why we don't see those P waves. So remember, when looking at an ECG that may be AFib, maybe not, the 2 things you need to see is an irregularly irregular rhythm, and then again, no P waves. Remember that. So what causes atrial fibrillation? We actually don't know exactly. We think that in AFib there is a triggering signal that arises from the pulmonary veins. But we have identified some risk factors. They include things like hypertension. So AFib patients, 60-80% of those patients have hypertension. Also cardiovascular disease, so 25 to 30%, and then heart failure, about 30% in that one. So each of these is associated with left atrial dilation, which seems to increase that probability of abnormal electrical firing from the pulmonary veins. Now, when AFib is present, there's too much atrial electrical triggering. Then you don't get really that nice coordinated atrial contraction. I try to imagine sort of like the atria just sort of quivering there with excitement, but it never gets out a nice normal squeeze. And you can see this in some ECGs. The baseline isn't very smooth. It kind of looks a bit jagged, but a very, very low amplitude. And because we don't get a coordinated contraction, we don't see, again, those really nice P waves. Now, as we said before, the rate can be normal or increased. The atria are firing off a multitude of signals. Now, often this can result in tachycardia. Now, many of those signals get through the ventricles and then you get that rapid ventricular rate. Now, this is often the presenting symptom. Patients will complain of tachycardia, shortness of breath, a fluttering in their chest, maybe even angina. So what are some of the other consequences of AFib? Well, if the atria can't generate a coordinated contraction, then there can be pooling of blood in the atria. So what does stagnant blood want to do? Well, it wants to clot. And that's why atrial fibrillation is so concerning, because the atria aren't contracting, that pooled blood forms a clot, and then the clot can dislodge and then embolize to other sites. Now, it may travel to the right ventricle and then to the lungs, causing a pulmonary embolism, Or if there's maybe a patent foraminal valley, or if the clot forms in the left side of the heart, the left atrium, then it can dislodge and embolize in the brain, cause a stroke, or then maybe potentially travel to other parts of the body and embolize there. So, how do we treat AFib? Well, first you need to know if this is new or if it's chronic AFib. If the atrial fibrillation is less than 48 hours old, you can do a synchronized cardioversion. You synchronize the cardioverting with the QRS segment so that you are basically resetting the normal rhythm of the heart. Now again, you can do this only if this is new AFib. So why don't we cardiovert an older AFib, greater than 48 hours? Well, we just talked about clots forming in the atria. So what happens if the heart abruptly starts having big, nice coordinated atrial contractions? Well, you run the risk of dislodging the thrombus and then causing an embolus. So if you have a clot in the atria, you do not want to coordinate an atrial contraction at that point. So what about an AFib that lasts longer than 48 hours, or maybe just an unknown duration? Then the patient will need anticoagulation therapy. So what drugs do we use here? Well, first and abruptly, we're going to use the heparin or enoxaparin. So that's the low molecular weight heparin. Now at the same time, we also start warfarin. Now once that warfarin becomes therapeutic, and usually that takes several days, we generally stop the heparin or the enoxaparin, and then we're going to continue that warfarin indefinitely or until further treatment is decided. So what else do we do for chronic AFib? Well, there's two strategies here that we use for chronic AFib, rate control and rhythm control. Now with rate control, you're going to do that same anticoagulation. We want to make sure that we don't have any clots that are going to form or dislodge. And then two, we're going to make sure the patient doesn't go into supraventricular tachycardia. So what are your rate control drugs for atrial fibrillation? Well, digoxin, kind of an older drug, don't use it quite as much, but we definitely use beta blockers a lot and calcium channel blockers. Now, with rhythm control, you're trying to actually bring that atrial fibrillation back into normal sinus rhythm. Now, what drugs are used most often here? We use antiarrhythmics. We use sotalol. We use amiodarone. Those are big ones. These are potassium channel blockers. Flecainide is a sodium channel blocker that's also used quite often. Now, why would you do rate control maybe versus rhythm control? Well, both of these strategies have very similar rates of morbidity and mortality. Now, rate control may be a little bit of a simpler regimen. Patients who are over the age of 65, who are asymptomatic, tend to do really well on this regimen. Patients who are younger or who are maybe more symptomatic may benefit from rhythm control. AFib can be uncomfortable and can lead to, again, that supraventricular tachycardia. All right, let's move on to atrial flutter. So atrial flutter is actually pretty easy to identify on most ECGs because it has that very classic sawtooth pattern. So if you see an ECG with a sawtooth pattern, that in general is going to be atrial flutter. Now, you do have distinct P waves here, but there are just a whole lot of them and you may not be able to see them very well. AFib has no P waves and it's irregularly irregular. A flutter, again, has the P waves and it's going to look a lot more regular. Here you do have atrial contractions. However, because of that elevated rate, there may not be enough time for the ventricles to fill. So in that respect, it actually can look and feel kind of similar to AFib. But overall, A-flutter, not quite as severe as AFib. And just how fast are these atria contracting? Just for reference here. Well, the amount of atrial contractions taking place with AFib, somewhere above 300 beats per minute. Then for A-flutter, slower, somewhere between about 220 and 300 beats per minute. All right, so now let's move on. Let's talk about AV blocks. So AV blocks are looking a lot here at PR interval. That's going to be the star of this part right here. So let's first talk about a first degree AV block. This is just going to be a prolonged PR interval, so greater than 200 milliseconds. So this is bigger than 5 little boxes or one of the big bold boxes that you often see on EKG paper. So this is a pretty benign condition and is often asymptomatic. The only reason why it might be a problem is that you are more likely to go into second degree heart block if you already have a first degree AV block. Now, there are a lot of people out there that are on beta blockers or calcium channel blockers, something like verapamil. They end up with a first degree AV block as a side effect of those drugs. Now, if they need to be on that drug, even that first degree AV block can be tolerated and careful monitoring should then just be continued. And here's a tricky question. What bacterial infection can cause an AV node block? Well, the answer is Borrelia burgdorferi, which can cause an AV nodal block. So this is the organism that causes Lyme disease. Moving on to second degree. So second degree heart block comes in 2 different flavors. You have a Mobitz type 1 and then you have a Mobitz type 2. So Mobitz type 1 AV block has progressive lengthening of the PR interval until a beat is blocked. So a P wave is not followed by a QRS complex. So this also is typically benign and asymptomatic. Now, Winky-Bach is another term for Mobitz type 1 AV block. And don't get confused, Mobitz type 1 is not a first degree AV block. Mobitz type 1 is still a second degree AV block. Now, one way to remember this is that Winky-Bach will give you warning before that beat is blocked. So the W there is to remind you that warning Winky-Bach. Now, the other stupid way that I remember this is a cheerleader cheer. Longer, longer, longer block. That's a case of Winky-Bach. So I don't know, whatever way works for you. So let's move on to Mobitz type 2. This is a bit more problematic. There is no warning here. There is a blocked beat that has no precursor warning, no precursor lengthening of that PR interval that we saw in our type 1 here. So it is abrupt. So again, everything looks normal at first. There are P waves followed by QRSs, and the PR interval is not fluctuating, and then you just lose a random QRS after a P wave. So there's no warning in a Mobitz type 2. Now, the reason why Mobitz type 2 is problematic is that it can progress to third degree heart block, and often these patients are treated with pacemakers. So let's move on. What is that third degree heart block? Well, this is where the atria and the ventricles beat independently of each other. Both P waves and QRS complexes are present, but there is no correlation between the P waves and the QRSs. So the SA node is not communicating with the AV node. And the atria are beating on their own, and the ventricles are beating on their own. So they're kind of like two neighbors that aren't talking to each other. They're just doing their own thing. Now, the atrial rate is going to be faster than the ventricular rate, and this is usually treated with a pacemaker. Now, remember that the other one that required that pacemaker was that Mobitz type 2. And again, don't forget Lyme disease. So Lyme disease can result in a third degree heart block as well. And often you'll see third degree heart blocks with narrow QRS complexes. So this is because you're actually still depolarizing through the AV node. However, there can be a ventricular focus which would potentially result in a wide QRS. So about 2/3 of these are going to be narrow complexes. About 1/3 of these cases are going to be wide complexes. Let's move on to Wolff-Parkinson-White syndrome. So this is also known as ventricular pre-excitation syndrome, where you have an accessory conduction pathway from the atria to the ventricle that bypasses the AV node. So that AV node is acting to delay the signal to the ventricles to give them time to fill with blood. So it's there to delay. Now the AV node also acts to keep the heart rate normal. So if the atria are beating too fast, then that AV node can simply block some of those signals so the ventricles then don't beat too quickly. But in WPW, we have a sneaky bypass between the atria and the ventricles that ignores the AV node. Now, the most famous one is called the bundle of Kent. Now, there are lots of different accessory pathways, but the bundle of Kent is the one that's the most common and most well known. So, as a result, you have an early ventricular depolarization that looks like a delta wave. A portion of the ventricle is depolarizing before the signal gets to the other part of the ventricle through the AV node and the bundle of His and Purkinje system. So, as a result, ventricles begin to partially depolarize earlier, giving rise to that characteristic delta wave. Now, I would be able to recognize that delta wave and know that it is Wolff-Parkinson-White. Now, the reason why it's important to identify WPW is because it may result in a re-entry current leading to a supraventricular tachycardia. Re-entry from the bundle of Kent through the AV node system creates kind of a cyclical pattern and causes a very severe supraventricular tachycardia. So what do we give for supraventricular tachycardia? Usually we give adenosine, except in WPW. So this is a good exception here. We do not give adenosine in WPW. We give procainamide. So this is a sodium channel blocker. You could also give amiodarone, which is a potassium channel blocker, and that's to tone down that tachycardia. Now, the definitive treatment is to destroy that abnormal electrical pathway with a radiofrequency catheter ablation. All right, so now let's move on to paroxysmal supraventricular tachycardia. So this is a rapid heart rhythm that originates at or above the AV nodes. The signal is coming from the top of the heart. So the name is pretty descriptive. In general, there are two mechanisms, and this is similar to what we just talked about in WPW. There can be re-entry or automaticity. Because this is originating at the top of the heart, most of the time you will see P waves. The rate can get upwards to about 200 or even more. Also, because the signal is originating at the top of the heart, we see narrow QRS complexes. So overall, the EKG is going to look pretty normal, except that that rate is very elevated. Now, another less known arrhythmia is Brugada syndrome. So this is actually a genetic problem. So this is an autosomal dominant disorder that is found more often in Asian males. Now, on the ECG, you'll see a pseudo right bundle branch block. You may also see ST segment elevation in the precordial leads V1 through V3. Now, the big issue with this syndrome that you should probably remember is that it is linked to sudden cardiac death. So the primary treatment is an implantable cardioverter defibrillator. So next we're going to talk about ventricular arrhythmias. So these are a bit easier to understand and come in fewer varieties. The first topic is on ventricular premature contractions, or beats. Often we just refer to these as PVCs, so you'll hear me say that. So premature ventricular beats or contractions are early occurring widened QRS complexes that have a bizarre morphology, which is markedly different from the sinus QRS complex. Now, most often they are the result of micro re-entry at the level of the Purkinje fibers, which generate a premature complex due to a single transmission around this circuit. So the signal is coming from below the level of the AV node. Now, the electrical signal is not going through the usual avenues, and that's why we see kind of this fat, crazy looking QRS. So in general, there's not going to be a P wave identified before a premature QRS complex. The QRS complex of a PVC is widened, kind of bizarre looking, often even notched, with a QRS duration greater than 0.16 seconds. So that's greater than 4 boxes. In a normal QRS, it really should be less than 3 boxes. So this is pretty big. Now, a couple of terms that you should know. Ventricular bigeminy is present when a ventricular premature beat follows each sinus beat. Ventricular trigeminy is present when 2 sinus beats are followed by the ventricular premature beat. Now, most of the time we don't need to worry about PVCs, and treatment is directed at eliminating really severe symptoms associated with palpitations. So really no study has shown that eliminating those PVCs with anti-arrhythmic drug therapy reduces the risk of arrhythmic death in patients, even with structural heart disease. Next, let's move on to ventricular escape rhythm. So an escape ventricular beat or rhythm occurs when there is failure of the sinus and AV node to generate an impulse. So the top of the heart is not doing its job very well to provide the bottom of the heart with enough signals to produce a normal ventricular rate. So the ventricles are just sitting there waiting for a signal from that AV node, and after enough time, the ventricles kind of get tired of waiting and decide to make a signal of their own to get the ventricles pumping. Now, there is an absence of P-wave activity, and the QRS complex is widened, which resembles a PVC. Now, usually you'll see a kind of decently long pause and then a QRS that looks like a PVC is going to come up. Now, persistence of this activity leads to multiple successive ventricular complexes representing an escape ventricular rhythm with a rate that is slower than the normal sinus rhythm that you normally see. Now, in cases of complete or third-degree heart block in which there is sinus node activity but failure of conduction of that AV node, then you might get something called a junctional escape rhythm where the AV node is the pacemaker. The QRS segment in this case are going to be narrow because that AV node is able to coordinate a fast conduction through the ventricles. Now let's talk about ventricular tachycardia. So ventricular tachycardia is defined as 3 or more successive ventricular complexes. So the signals are coming from the ventricles, but instead of being slow, like we just talked about a second ago, this rate is very fast. So non-sustained VTAC is a series of repetitive ventricular beats which have a duration of less than 30 seconds. Sustained VTAC lasts for more than 30 seconds. Now the rate of VTAC is generally greater than 100 beats per minute, but may vary widely. And the rhythm is usually regular, although there may be slight irregularity of those RR intervals. Now the width of the QRS complex is generally greater than 0.16 seconds, which is widened. So how would this differ from supraventricular tachycardia? Well, remember that supraventricular tachycardia is originating in the atria. Therefore, those QRS complexes, again, are going to be normal, not widened. And then supraventricular tachycardia can become serious, but generally patients are not about to die. Sustained polymorphic VTAC will lead to immediate hemodynamic collapse. Big, big deal. So emergency asynchronous defibrillation is required for survival. Moving on to torsades de pointe. So this is a very specific type of ventricular tachycardia that is characterized by shifting sinusoidal waveforms. Sinusoidal is what you got to remember here, and that's on that ECG. So this is a ventricular rhythm, so it has a very wide QRS. It is a tachycardia, so it's very fast. Now the amplitude, and this is the important part, of the QRS changes. So it's very small amplitude, then very large, and very small, and they're very large. So it looks like a ribbon that has actually been twisted. That's why it's called torsades de pointe. Now it is twisting of the points, twisting of a ribbon that's creating that sinusoidal pattern that you're going to see on the ECG. Now unfortunately this can progress to VFib, which is why it is so dangerous. Now, anything that prolongs the QT interval can predispose to torsades. There are certain drugs that are known for prolonging that QT interval. These drugs should not be given to patients that already have a prolonged QT. Now, a few I want to mention include things like macrolides, so antibiotics, erythromycin is an example there. Anti-malarial, so chloroquine, mefloquine. Antipsychotics like haloperidol, risperidone, methadone is used for opiate addiction and heroin addiction. The HIV protease inhibitors and a lot of the antiarrhythmics themselves, so the class 1A, and also the potassium channel blockers. So a lot of the antiarrhythmics, unfortunately, can actually cause arrhythmias. But the 1A sodium channel blockers and those potassium channel blockers can cause torsades specifically, so try to remember that one. So how do we treat torsades? Well, you treat torsades with magnesium. For someone with just low magnesium, we'd give magnesium over a few hours, but here you're going to push that magnesium very quickly to correct this arrhythmia. And then we have ventricular fibrillation. So this is a completely erratic rhythm with no identifiable waves. Remember when we talked about AFib looking like a quivering pair of atria? Well, imagine what would happen if you had a pair of quivering ventricles without normal contraction. So like sustained VTAC, this will lead to hemodynamic collapse and requires emergency asynchronous defibrillation right away. So these patients are going to die unless they get an abrupt correction to their rhythm. So you start CPR with ACLS protocol. Hopefully you have a defibrillator close by, otherwise it's not going to go very well for them. All right, guys, that brings us to the end of our video part. It's time for that end of session quiz. Try to answer those on your own, and then we'll go through them together. First question, what is the initial treatment for ventricular fibrillation? So remember, these patients are dying. So CPR, defibrillation. So that's as laid out in the ACLS protocol. The protocol also calls for certain medications, but for step one, you really just need to know that VFib is a rhythm that needs to be shocked. Next, what are the major characteristics of atrial fibrillation? So tachycardia, usually, but not always. Irregular rhythm, that's a big part. And also remember, no P waves on that ECG. Next, what is the hallmark of a third-degree heart block? So in third-degree heart block, there is no correlation between P waves and the QRS. They are completely out of sync with one another. Next, what drugs are known to prolong the QT interval, increasing the likelihood of torsades in those that are at risk? So remember the macrolides, remember chloroquine, remember haloperidol, risperidone, remember those protease inhibitors, HIV drugs, remember the class 1A antiarrhythmics like quinidine, also the class 3 antiarrhythmics, think of sotalol and amiodarone. Next, what are the two different types of second-degree AV block? How do they differ? So there's the Mobitz type 1, which is Winkie-Bach. You remember that Winkie-Bach gives you a warning. So you have progressively prolonged PR intervals and then a blocked beat. Then there's the Mobitz type 2, which has no warning at all. You just have a blocked beat without that progressively increasing PR interval. Next, why is warfarin anticoagulation important in patients with chronic atrial fibrillation? So remember that atrial fibrillation, you don't have normal atrial contractions, so the blood can pool in the atria and cause thrombosis or clotting. Then pieces of that thrombus can embolize. It can break free, travel through the circulation, causes stroke. So patients with atrial fibrillation are at increased risk of thromboembolic strokes or other embolic events. So we anticoagulate them with warfarin to reduce that stroke risk. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.
Yo, what's up? You're watching DIT TV, the best place for new music and the highest yield medical knowledge.
We've got more great hits coming your way, but first, we had a request for this new release by Todd Skure, coming out next month.
That's right, so here he is, Todd Skure with The Rhythm of My Heart, only on DIT TV.
Across the street, I see your face. Down in my chest, heart is skipping away. Is this love that I feel? I'm so glad you asked. Thumping out a rhythm that's entirely too fast. Heartbeat is irregularly dizzy and lightheaded, really scary. But I may survive somewhere, some way. Need a calcium channel blocker that would slow me down today. Oh, the rhythm of my heart is beating out of sync. Fibrillation of the atria, I think. Oh, but I don't die, but the EKG don't lie, and the doctor says my heart is an AFib. Oh, the rhythm of my heart was beating way too fast, but till tires am it slow me down at last. AFib is not a joke, and I sure don't want a stroke. So I need some warfarin and check my PLC.